are able to share, then your time will be counted. Now start. Your time started.
Good afternoon, all the honorable and respected judges, my colleagues and friends. I am Dr. Gautam Gavania, first year resident from NHL Municipal Medical College. Here I am presenting a case of para-ovarian cyst. Para-ovarian cysts present in approximately 5 to 20% in adnexal mass. Majority of them are present with the abdominal pain. And here is a 35-year obese female patient came to our hospital with a complaint of abdominal pain for 3 days. Obstetric history includes for full-term ND. Last menstrual period was 15 days back. She has history of similar pain episode 20 days back and outside UST suggestive of 8 by 8 by 7 centimeter of right ovarian cyst. On examination, general examination, vital data and systemic examination were normal. On local examination, per abdomen soft, obesity plus, approximately 10 by 10 centimeter size of mass felt. Per speculum cervix hypertrophied and pap smear was taken. Per vaginal, uterus anteverted, normal size and bilateral phonesis clear. All the investigations were sent and tumor markers are within normal range. As per shown figure 1, ultrasonography suggestive of 8.2 by 8.9 by 8.8 centimeter of right adnexa independent from the right ovary, which is suggestive of para-ovarian cyst. Initially, we have managed this patient with analgesic and antibiotic. Then we have planned exploratory laparotomy and remove the right side para-ovarian cyst and send for the histopathological examination, which is showing the benign cystoadenoma as per figure 4. Para-ovarian cyst occur majority in the 3rd and 4th decade of the life. It also plays a role in ectopic pregnancy and infertility by disturbing the tubal motility. Obesity also a risk factor for it. It is difficult to differentiate it from the ovarian cyst. Ultrasonography is the first line diagnostic imaging tool. Differential diagnosis by ultrasonography are ovarian cyst, peritoneal inclusion cyst, and hydrosalpinx. Benign para-ovarian cysts are more common. Complication of para-ovarian cyst are cyst enlargement, adnexal hemorrhage, torsion, rupture, and benign tumor. Tumors, a majority of the patients are managed with laparoscopy or laparotomy procedure. There is no role for hormonal treatment. If found incidentally during surgery, it should be excised to avoid possible complications. Management of it depends on the age, presence, and severity of the symptom, cyst size, and its complication.
Gautam, your time is over. Gautam, your time is over.
Thank you, ma'am.
Dr. Gautam, how will you differentiate the para-ovarian cyst with hydrosalpinx by ultrasonography?
Sir, there is a split sign in para-ovarian cyst on ultrasonography. There is oscillatory movement opposite side with the vaginal probe of UST. And in hydrosalpinx, there is no split sign seen.
How can you reduce the blood loss during cystectomy? Suppose you are laparoscopically doing the ovarian cystectomy.
Yes, sir. First, we have to clamp the cyst. Sorry, sir, I don't know.
Okay, Gautam, you in your poster said that the ultrasound diagnosis you were quite certain that it's a para-ovarian cyst. Is there a rule of going for all the markers which you went for in this patient, or you could have done away with a single marker?
Yes, ma'am. We have done AFP, CA, and CA.
Yeah. What did you have in mind when you went for all the 3 markers?
Differentiate, ma'am, neoplastical, any this or not?
Which neoplasm did you want to rule out by doing all the 3 markers which you have done?
Mucinous carcinoma, serous cystoadenoma.
What was the age of the patient?
35 years of age.
Okay. Both the ovaries were normal when you did the laparotomy?
Yes, ma'am.
Okay. How will you follow up this patient now?
Ma'am, initially we have called the patient after 15 days after discharge on 14th day, and after stitch removal we have discharged the patient and follow up call this patient after 15 days, and initially patient was stable.
Gautam's time is over.
Thank you, ma'am.
Okay, very good presentation, Gautam. Now I invite the Dr. Khushbu.
One minute, ma'am.
Next candidate, be ready.
Dr. Khushbu,
Yes, ma'am.
Yes.
start your slide sharing.
Good afternoon, respected judges and
Your-
my colleagues. I, Dr. Khushbu Kundaria, first year resident of NHL Medical College, presenting case report of eclampsia. Eclampsia is a deadly and often unpredictable complication of pregnancy-induced hypertensive disorder. It is characterized by sudden hypertension, proteinuria, edema, and episode of generalized tonic-clonic seizure. So here I am presenting one such case, 33-year-old fourth gravida with no live issue patient came to our emergency department with one episode of conversion at home. Conversion is associated with the rolling of eyeballs, breathing at mouth, urinary incontinence, and tongue bite. A patient had a history of gestational hypertension in previous pregnancy also, but time of onset was unknown. Patient is not taking any antihypertensive at present and has not been diagnosed in current pregnancy. General examination was done. He was drowsy and disoriented, and her BP was 180 by 100 mm of mercury, and her urine albumin was +2. He had grade 2 of bilateral pedal edema, and per abdominal examination was done. Uterus is about 20 week size, and external ballotment was present. In her previous examination, all os was closed, and all relevant investigation were sent, and all are within normal limit. Her USG fetus was done. In USG fetus, single intrauterine live fetus with variable life and cardiac activity was present. Fetal maturity was 19 weeks 4 days, and her liquor was 2 to 3 centimeter, which signify severe oligohydramnios. Her bilateral renal artery Doppler was normal. On arrival, we immediately IV line was taken, and airway secured, mouth gag was placed, and suctioning was done. We have given a loading dose of Maxelf, and after checking her urinary output, knee jerk, and respiratory rate, we have initiated maintenance dose of Maxelf. After trying to stabilize vitals for several hours, we decided to terminate pregnancy. So hysterectomy was done. On post-op, we have shifted the patient to obs ICU for observation, and patient was discharged on day 10 after stitch removal with oral antihypertensive drug, and monitored her regularly on OPD basis. In India, incidence of eclampsia varies from 0.17 to 3.7, and maternal mortality is 2.2 to 23% in all eclamptic women. Perinatal mortality is high, about 24 to 48%. Eclampsia is often associated with a complication like myocardial infarction, stroke, coagulopathy, AKI, cerebral edema. About half of eclampsia was
Khushbu, your time is over for presentation. Now the question answer.
Okay. Dr. Khushbu, how will you decide the mode of delivery in case of eclampsia? Whether you would like to go for CS or you would like to go for induction of labor? Means vaginal delivery.
patient. If a patient has the bad obstetric history, like in previous pregnancy, spontaneous abortion, recurrent abortion was present, then we
See, depending on gestational age, depending on stability of fertility.
Suppose you are opted for vaginal route of the delivery, how much time you will wait? કેટલી કલાક? How?
24 to 48 hours. Depending upon her.
What is the contribution? Okay, once is a case of eclampsia, not simple hypertension. Now, what is the contribution of hypertensive disorder in maternal death in our country?
2.2 to 24%.
Okay, Khushbu, in your investigations, you said that renal artery Doppler was done. So do you think something was missed in this patient in her one antenatal visit or whatever she had taken? Do you think she had
Yes,
some
ma'am.
underlying cause which has,
Yes, ma'am.
what do you think could have
Ma'am, she
been
has
missed?
history of gestational hypertension in previous pregnancy also.
Therefore,
She had history of gestational hypertension. So how could you do something in her first trimester to predict her for having severe preeclampsia, and could something could have been started in her?
they are
Suppose this patient had come to you regularly
Yes, ma'am.
in view of her past history.
first physically you do renal delivery.
Khushbu, your time is over. Time is over.
Thank you, ma'am.
Okay. Now, I invite the Dr. Dhruvi.
Yes, sir.
Dr. Dhruvi.
Yes, sir. Yes, sir.
Now it's your turn. Start your slide sharing.
Yes, sir.
Good afternoon, respected honorable judges. Myself, Dhruvi Ashok Dadania, first year resident from NHL Medical College, Ahmedabad. I presenting a case of bladder injury during cesarean section. Since cesarean delivery being the cornerstone of obstetric history, it is very common. I presenting a case of a registered patient, 31-year-old, second gravid patient, presented to our hospital with 7 months and 11 days of amenorrhea with complaint of abdominal pain. She had a previous full-term cesarean 6 years back with a delivery of a live male child and indication being elective cesarean section. On examination, patient was vitally stable. Per abdominal, it was 30 to 34 weeks, with breech presentation floating and scar tenderness was present. Per vaginally, patient had one finger loose, early phase, and lower segment was formed. Hence, patient was shifted for ultrasonography, which showed us breech presentation and scar thickness of 2.4 mm. Soon, the patient was shifted for emergency preterm cesarean section, with indication being previous cesarean plus breech. Abdomen was open layer-wise, and Few adhesions was found between bladder and lower segment. Hence, there was also scar adhesions 2 centimeter on the left hand side. Therefore, an incision was made slightly above previous cesarean section, and baby was delivered, which died soon after birth. Soon, a Foley's bulb was visualized and urine was blood stained. Hence, bladder injury was confirmed. An extent of injury was identified on the dome of bladder and was repaired layer-wise with a non-absorbable suture. Afterwards, abdomen was and uterus was closed layer-wise. Post-operatively, patient was given antibiotics and analgesics. Urine output was maintained, and on third day, patient was mobilized, and there was a drain output increased to 400 cc from 50 cc. Therefore, ultrasonography was advised, and drain routine microscopy of drain fluid was done. Ultrasonography suggested of 7 by 5 centimeter clot in the urinary bladder with no free fluid in the pelvis. And routine microscopy of drain fluid showed no blood, blood stained ascitic fluid. Slowly, from post-op day 5 to 14 days, 2 hourly every bladder wash given, and hence every day a follow-up USG was done to estimate the clot size. Slowly, after 14 days, clot size reduced to 3 by 2 centimeter, and afterwards, a follow-up cystoscopy was planned for the removal of clot and bladder wash under anesthesia. Then, patient was discharged on post-op 25 day without any complaint. Incidence of bladder injury during cesarean section is very
Khushbu, your time is over.
okay, ma'am.
Dr. Khushbu, what are the conditions or indications of cesarean section where bladder injury is likely more? So you have to be vigilant.
Previous cesarean section, if there are emergency cesarean section and cesarean section performed during second stage of labor, there are chances that more bladder injury occurs in these cases.
Suppose in case of previous cesarean section, bladder is adherent in the center, how will you proceed?
Slowly, we would try that we make a bladder flap by reducing the adhesions, and exploration of uterus can be avoided to prevent the bladder injury.
If sir is asking if the bladder is adherent, what technique will you apply for dissecting the bladder? You're not able to have access to the lower uterine segment.
We would make an incision slightly above, slightly on the above part, so the bladder injury can be avoided.
What suture material was used for closing the bladder?
Polyglactin suture. Non-absorbable.
Polyglactin is non-absorbable?
Sorry, absorbable suture.
That's what when you mentioned, you said non-absorbable, so it caused an alarm in my mind.
Sorry, ma'am.
What was the reason for the clot formation in the bladder? How could it have been avoided?
Might be a proper during closure. If it was a proper closure, then it might be avoided.
Okay, Khushbu, your time is over.
Thank you, ma'am.
Now I would like to invite Dr. Dipesh.
एक सेकंड सर. ओली बता अभी तो पोस्टर चालू की होची त्या पोस्टर करવાનો हां तो पोस्टर ओली बच्ची ना ओली નથી ત્યાં WhatsApp માં जा एक सेकंड सर. One second.
Start the slide sharing.
Sorry, sir.
Okay, your time starts now.
एक second. Good afternoon. Good afternoon, all the judges and my colleagues. Myself, Dr. Dipesh, the first year resident from NHS Medical College. Here I am presenting the case of triplet pregnancy. The term triplet is used when 3 babies born to a mother at one time. Twin deliveries are quite common, but triplets are rare. According to Duggan's rule, estimated incidence for the triplets for 1 out of every 6,400 deliveries. Incidence of multi-fetal gestation has increased in recent past due to frequent use of ovarian stimulant drugs such as the clomiphene and gonadotropins for treatment of infertility. Perinatal mortality rate for twins and triplets is as high as 4 to 11 times that of singleton. One such case is reported here, and problems are discussed. A 32-year-old third gravida para to live female pregnant woman with 8 months 2 days of amenorrhea came to emergency department of our hospital with chief complaints of abdominal pain and discharge fever. Detailed history was taken and general examination was done. All the vitals and routine investigations were normal for this patient. Ultrasonography for the fetus was done. All the fetus were in cephalic presentation and their maturity around 31 to 32 weeks. And all fetus has weight around 2.1 to 2 kgs. And there were no congenital anomalies. Gross congenital anomaly was found during the ultrasonography. On admission, as she was in labor, prophylactic dexamethasone was given to mother before delivery to prevent hyaline membrane disease in the fetus. And three babies, each weighing 2.1, 2.2 kgs, were delivered by lower segment cesarean section. 3 resuscitation team were kept ready for the receiving of babies. Babies were asphyxiated birth and were resuscitated. There was no evidence of gross congenital anomalies was found. First of the triplet had separate placenta, and whereas the second and third had a common one. All of them had their own amniotic sacs. All the babies' blood groups were positive, same as their mother. They were managing neonatal ICU in the thermo equivalent environment using incubator and a radiant heat hormone under complete asepsis. Expressed breast milk and reconstituted powder milk were given to them through nasogastric tubes. The first one, who had a separate placenta, had feed intolerance and poor thermoregulation, succumbed on 4th day of life to apnea of prematurity. Second and third baby of triplets will remain stable and are growing well. In management, there are different schools of thought regarding trial of normal labor in such pregnancies. However, interlocking of fetus, knotting of cords, and delayed delivery of second and third babies causing hypoxia may jeopardize fetal outcome, and hence cesarean delivery may be better to overcome these problems. Energetic resuscitation and neonatal care under supervisions of neonatologists produce the rewarding outcome and good prognosis in twins and triplet pregnancies. In multifetal pregnancies, usually first delivered baby has a low risk as compared to babies delivered subsequently.
Dipesh, your time is over.
Okay, ma'am.
Dr. Dipesh, what do you mean by selective fetal reduction, and what is the ideal gestational age for selective fetal reduction?
In multifetal gestation, if we are doing ultrasonography antenatally, if we found one of the fetus is congenital anomaly, if found congenital anomaly in one of the fetus, we can abort that baby by giving KCL injection under ultrasonography, under guidance of ultrasonography, around 10 to 12 weeks of gestation.
Okay. What are the points you will include in the consent of selective fetal reduction?
Actually, I don't have any idea about that thing, sir.
Okay.
What are the complications
Madam.
of triplet pregnancy?
Pardon me, ma'am?
What are the complications of triplet pregnancy?
Complications like polyhydramnios, pregnancy-induced hypertension, and gestational diabetes mellitus to mother and postpartum hemorrhage after delivery.
What percentage of triplet pregnancies will reach term?
No idea, ma'am. In triplet pregnancy, we should plan delivered maybe around 30 to 32 weeks, ma'am.
Why?
No idea, ma'am.
What are the causes of increasing multifetal gestations?
Nowadays, we are frequently using artificial reproductive techniques and ovarian stimulating drugs like clomiphene citrate and gonadotropin analogs, ma'am.
Okay, Deepesh, your time is over now.
Okay, ma'am. Thank you, ma'am.
Now, I invite Dr. Jaga Jaidas. Your time
Dr.
starts
Ja-
now.
Okay, series is.
You are not audible.
Unmute.
Unmute yourself first.
Hello.
Yes, now audible.
Good afternoon, everyone. I, Dr. Jaga Jaidas, resident in Department of Obstetrics and Gynecology, MGM Hospital, Aurangabad. I would like to present my poster on the topic Twisted Ovarian Tumor Complicating Pregnancy, a case series. Ovarian torsion is said when ovary becomes twisted on this ligamentous support and can result in compromised blood supply. The presentation of ovarian torsion mimics intra-abdominal pathological condition, hence requires high level of clinical suspicion. Ovarian cyst may be complicated by torsion, rupture, and hemorrhage. Torsion of ovarian cyst is commonest complication during pregnancy, which rises fivefold in pregnancy to approximately 5 in 10,000. A retrospective analysis of medical records of 3 pregnant women with ovarian torsion in the period of 6 months was done. The study aimed to compare the clinical manifestation, ultrasonography findings, operative procedures, and histological diagnosis and pregnancy outcome. At the bottom, you can see 3 cases with images. The first one was the torsion of a serious mucinous cyst adenoma in pregnancy. There was evidence of didelphys uterus, and you can see a picture of untwisted ovarian cyst. A second case was a rare case, torsion of ovarian fibroma in pregnancy, where you can see a bosselated mass with intact capsule, and a solid mass with fleshy appearance is seen, which is also seen in ultrasonographic findings. A third case is a torsion of dermoid cyst in pregnancy, where you can see a bluish-black ovarian cyst and a cut section where sebaceous material is seen. These are the clinical details of the 3 cases. All were in the age group of 20 to 30 years of age. The first case was the early pregnancy, the first trimester case, and the second and third was the second trimester case. Multigravida patients presented to emergency services with pain in abdomen and other non-specific complaints like nausea, vomiting, and pain in abdomen. On per abdomen examination, there was tenderness, gardening, and adnexal mass felt. And on USG findings, there were different findings like anochrotic cystic lesion, followed by in the second case of soft tissue lesion seen. And in the third case, multiple dense internal echoes were seen. All were taken for emergency laparotomy, and the intraoperative findings are shown in the slide. And it was seen that the right side was more dominant, and on HPR, there was the first case had mucinous cyst adenoma, the second was a rarer case, ovarian fibroma, and the third was a mature cystic ovarian teratoma. The first case had gone under spontaneous abortion at 18 weeks, and the second and the third case, the pregnancy continued and was uneventful. So in my study, the age and parity had no correlation with occurrence of ovarian torsion, which is in agreement with the study. Ovarian torsion may occur in any trimester, but more commonly reported in 6th and 14th weeks of gestation.
Jaga, your time is over. Now question answer.
Yes, ma'am.
Dr. Jaga, can we manage all these 3 cases by laparoscopy?
Yes, sir. We can manage them, but the laparoscopy has becomes more difficult in second trimester. So,
okay, what are the likely difficulty or complication may occur
sir,
with
we might
laparoscopic route?
injure the uterus, and so the gas which is used can cause insufficient, so more. So in our college, we usually prefer doing laparotomy in such cases.
Okay. What
Jaga,
are the
you-
sonography findings suggestive of twisted ovarian?
Yes, sir.
What are the sonography findings suggestive of twisting of ovary
Sir,
or ovarian?
so there might be ovarian enlargement, there might be ovarian edema. Then a wall sign is also seen, sir, which is the coiling of the ligamentous supports. And so the on Doppler, we can see decreased blood supply to the ovary.
Jaga, you told that majority of your case series patients have got right-sided ovarian
Yes, ma'am.
lesion. Is there any rationale or significance, or it is mere coincidence?
Ma'am, actually, I read some literature about it, which said that the right side of the ovarian ligament is more favoring for the rotation because it's longer than the left, and the presence of sigmoid colon also reduces the space for the torsion on the right side. So that is why on the left side. So right, that is why right is more common, it says. In my cases, only 2 had right and 1 had left.
What
And
extra laparoscopic procedure you can do to prevent the recurrence?
Sir, we can, so fixation of the ovary to the lateral pelvic wall and shortening of the ovarian ligament.
Jaga, what are the complications which can occur with this surgical intervention during pregnancy, existing pregnancy? Though it is very safe nowadays to do it in the second.
Ma'am, one of my cases are undergone spontaneous abortion. And ma'am, injury to the uterus again.
How injury can take place?
Oh,
Okay, your time is over.
Okay. Thank you, ma'am. Thank you, everyone.
Now I invite Dr. Kranti.
Good afternoon, sir. Am I audible, sir?
Yes. Start the slide sharing.
So is my slide synced?
No.
Yes, yes. Fine. Your time starts now.
A very good afternoon to the chairpersons and delegates present here. Expressing my heartfelt gratitude for permitting me and accepting my poster, I, Dr. Kranti Kulkarni Fadnas, bring you greetings from Navi Mumbai. Obstetrics has always been challenging and changing. Yet the current pandemic of COVID-19 and its family have vanquished all other segments of medicine, emerging as the only exigent rivulet capturing all our attention. Quite evident that technology today has proved beyond doubt its capacity to surpass pandemic and save lives. With due respect to the organizers and very much adherent to the theme for the conference today, Best on Yuva Fogsi, Technology Saves Lives. My poster for today is Tech Boost Docs. To start with my poem that I've written, technology was present, medicine was old. Through corona's tensions, tech re-explored. Through radiations and scans, tele-reporting peaked. Else, with minimal hands, future was bleak. Docs consulted patients online. Video conferences happened on Zoom. Tech kept us moving on time. Corona showed tech's a boon. While technology revived and medicine grew, anti-COVID vaccine we made. But how to reach the rural flu? Drones dropped vax, contacts spared. Robots in OT, no need to feed. Prosthetic limb freely moves. No chance of aging for this steel. AI shines, again it proves. Nano robots, happy folk, Fitbit in store. Tech is changing bios on earth. Thanks Corona for 1 to 4. We call you Techno Mom for medicine's rebirth. So let's see how technology has boosted life in today's docs. Online consultation, video conferences, robotic surgery, imaging, CT scan, PET scan, MRI, tele-reporting, and drones for vaccine during a pandemic. We have seen all the headlines and all the newspapers are flooded with how the vaccine and how the ventilator, low-cost ventilators, tailor-made by the Indian Institute of Science, and it's been a real boon. Artificial intelligence in medical decision making, the amount of medical information is growing exponentially, and the use of such solutions in assisting medical decision making is inevitable. Watson computer is a supercomputer, and it has been shown that it is extremely useful and being used in more and more institutions. Like IIT Bombay has launched on the 18th of May this newspaper headlines in healthcare informatics. Nanorobots in the bloodstream. For years, nanotechnology has presented the possibility of using nanotech devices in treating diseases. Nanorobots in the bloodstream could intervene even before the disease appears. They could keep tissues safely oxygenated after a heart attack, specifically target cancer cells or remove platelets. On 22nd May, in the newspaper, I read, artificial intelligence will help to contain infectious bugs even before they turn virulent. This was a boon for neurosurgeons as well as oncologists. Nanoparticle-based shot, like the CDC of US, had an experimental recombinant protein nanoparticle vaccine that stimulates a strong immune response to the flu.
Kranti, your time is over.
Yes, ma'am. Free genome sequencing, 3D printing evolution, the prosthetic arm, CT scan, MRI.
Your time is over now. It's open for your question answer.
Yes, ma'am.
Dr. Kranti, what
Yes,
is the role of robotic surgery in gynecology?
Come again, sir.
Robotic surgery in gynecology. This is also one technological aspect development in gynecology.
Yes, sir. The technology is evolving. It comes with a high cost, sir. The cost and the availability. There are some pros and cons. If the robots are placed, we should be able to place it correctly. It has a lot of learning curve. The expertise and the cost, whether it is available to everyone, makes a lot of a difference.
Okay. Arti madam.
Once we place the robots, we can't move. There are some negative aspects of it. But since we are talking about all the pros of the technology, so I did not talk about the trouble with Google and the trouble with technology. So we are just talking about the plus points of.
What is this, being an India developing country, what is the scope of all this technology in our developing country in Indian medicine?
It is surely going to come up. Artificial intelligence will somewhere or the other make a lot of difference for the medical practice. It will, the robots will be replacing the general prescriptions. A lot of difference will be there, but eventually the touch and the feel of the consultants and the non-verbal communication are all a big question mark. So somewhere the personal contact, I believe, will always be valued as against the robotic. But definitely India will be upcoming.
Okay, your time is over.
Thank you, ma'am. Thank you, sir.
Now I invite Dr. Vidisa.
Good afternoon, one and all present here. Am I audible?
Wait. First, share your slide.
Yes.
Your time will be start after sharing. Don't worry.
Yes. Is it seen, sir? Is it seen, sir?
Yes, now your time start. Slide show.
Yes, sir. Good afternoon, one and all present here. I am Dr. Vidisha, third year resident from Government Medical College, Baroda. My topic for poster presentation is eclampsia, the fetal-maternal outcome at a tertiary care center. Sir, as we all know, eclampsia is a conversion in the setting of pre-eclampsia when any other neurological cause of conversion has been ruled out. There are the higher incidence of eclampsia and its complications in the developing world. They are due to the early age of the first pregnancy, poorly equipped maternal healthcare centers, and underutilization of the available healthcare facilities. Maternal complications usually are electrolyte imbalance, DIC, abrupt shift in renal failure, elevated liver enzymes, health syndrome, neurological deficits, maternal death. In fetuses, it is usually IUGR, preterm delivery, birth asphyxia, and cerebral palsy. they are associated with eclampsia. The objectives of my study are to study maternal and fetal outcomes in eclampsia, to observe the delivery mode of delivery and compare their outcomes, and to analyze the convergence to delivery interval and study the impact. Methodology: the present study was conducted for a year, that is April 2020 to April 2021, and 215 pregnant women with eclampsia who came to Government Medical College of Baroda were examined. At the time of admission, the entire history and examination was done as our routine investigations were sent with special emphasis on the liver profiles and the renal profiles. Ultrasound, as we do, is all done in the antenatal period. Maternal outcome was studied in terms of respiratory complications, fever, TIC, hepatic and renal dysfunction, as well as the fetal outcomes were studied. Sir, as my chart shows, maximum had respiratory symptoms, which is about 30%. 18% of females or the patients had hematuria. 19% had elevated liver enzymes, while the more previous complications like DIC and health were seen about 7 to 3%. Sir, here I have shown a table showing the mode of delivery. So, out of 215 pregnant women, 127 went under vaginal delivery, while 88 LSCs were done. Of the vaginal delivery, most of 77% were preterm, while 22% were term, and out of them, stillbirth were 23%. Maybe the reason may be preterm delivery or IUGR. Out of the LSCs done, 52% were preterm, while 47% were term pregnancies, while the stillbirth ratio is 0. So here is another interesting table showing the conversion to delivery interval. This states that most of them delivered within 0 to 6 hours and 6 to 12 hours, while the rest of them delivered within 12 to 24 hours, while 13% delivered more than 24 hours. Eclampsia which are seen at our college, mostly they were antepartum eclampsia, that is about 81%, while 17% were postpartum, while only 2% were intrapartum.
Vidhi, your time is over.
Thank you, ma'am.
Okay, now Vidhi, tell me what is the contributions of hypertensive disorder in maternal death in our country?
Sir, about 5 to 10%.
Okay.
Most of them were the reason being DIC, health syndrome, or the effects on the liver and the kidneys.
What are the bedside tests you will do to rule out the DIC?
So bleeding time, clotting time can be done.
Okay, Aarti madam.
What are the indications of cesarean section in cases of eclampsia?
When it is a term pregnancy, the Apgar score, the Bishop score is not very good, and the ultrasound suggests that there is no brain sparing effect or any change in the Doppler study. When you expect a completely normal fetus and you do not want to have this effect of prolonged labor which occurs in eclampsia, and that should not affect the fetus.
If VSUP score is favorable, what will you do in a full-term patient?
We will go for vaginal delivery.
How long you will wait for a vaginal delivery with the patient having eclampsia? First onset of the convulsion to the delivery.
8 to 12 hours.
Okay, your time is over.
Thank you, ma'am.
Now I invite Dr. Srushti Patel.
Yes, sir. Am I audible, sir?
Yes, your time starts now.
Good afternoon, everyone. Today's my topic is ferric carboxymaltose for correction of the iron deficiency anemia. Introduction. Anemia is one of the world's leading cause of the disability and thus one of the most serious global public health problem. In India, 41.8% of pregnant women are affected from the anemia, which is the one of the major underlying cause of the maternal and perinatal mortality. Iron deficiency anemia is the common nutritional deficiency among the women of the childbearing age group. Pregnant women with iron deficiency anemia have the increased risk of preterm birth, fetal growth restriction, IUFD, low blood score, and the infection. According to the WHO, anemia in the pregnancy is defined by the HP level less than 11 gram per deciliter. Injectable iron sucrose is known for the higher incidence of the anaphylaxis and other adverse reactions, which is markedly lower with the use of the ferric carboxymaltose injection. Multiple doses of infusion are also reduced by giving the intravenous ferric carboxymaltose injection. FCM has a neutral pH and the physiological osmolality, so that can make it possible to administer the higher single dose over a short time period. It does not contain the dextran, so anaphylaxis reaction is a very low and test dose is not required. My aim of this study is to use of the injectable ferric iron carboxymaltose in the treatment of pregnancy with anemia and to improve the quality of life and to withstand the stress of the liver. Method and material. It is a comparative study. Total 100 women with iron deficiency anemia of the SSC Hospital Baroda between the 28 to 34 week of gestation were included in our study. Total 100 cases randomly distributed in two groups consisting of 15 cases of each. Group A receiving the IV iron sucrose in 5 doses of 200 mg diluted in 100 ml of the 0.9% of the normal saline and infused over 20 minutes on alternative day up to the 5 days. And group B received the IV ferric carboxymaltose 1000 mg single dose in the 250 ml 0.9% of normal saline over 15 minutes. Inclusion criteria. 28 to 34 week of gestation were included in this our group. Exclusion criteria: women having the history of allergic reaction to previous parenteral iron therapy, megaloblastic anemia, thalassemia, sickle cell anemia, history of asthma, allergy, and patient with anemia due to the chronic illness like a liver disease and the renal disease and infection are excluded. Total dose calculation for iron deficient is total iron dose required in milligram is equal to 2.4 multiplied by body weight in kilogram multiplied by target HB minus actual HB in gram per deciliter plus 500 mg to replenish the iron store. The factor 2.4 is derived from the blood value, which is a 7% of the body weight, and the iron content of the HB, which is a 0.34%. So 7 multiplied by 0.34 is equal to 2.4 mg per. Result in this study, 15 cases received a 5 dose of IV iron sucrose, which increased the HB level at 6 weeks is 3.4 gram per deciliter, and increase in the serum ferritin level is 63.93 nanogram per deciliter. In other 15 cases who received a single dose of IV FCM injection, which increased the HB level at the 6 week of duration is 4.4 gram per deciliter, and increase in the serum ferritin level, which is 106.7 nanogram per deciliter, which is higher than the iron sucrose injection. Percentage of the patient achieving the target HB 12 gram per deciliter in two groups.
Shruti, your time is over. Shruti, your time is over.
Yes, ma'am.
Okay. What is the place of blood transfusion for correction of anemia in pregnant women? Is there any role?
Is depend on the person who come at which gestation age. In the early gestation, we give the oral or parenteral iron supplementation, but in the when patient come in the third trimester near term, then it's better to give the parenteral iron parenteral blood transfusion.
And when will you give the blood transfusion?
When in case of the severe anemia and the patient come near the term in labor, then near 1 week earlier, yeah, at least in case parenteral iron injection or oral iron injection, the improvement of the HB take the at least 1 week. So in that cases, when need the urgent improvement of the HB in labor or in the term, we give the blood transfusion.
What
will you give blood or pixel volume?
PCV, RCC, it's concentration pixel volume.
What other precaution you will take to prevent the failure during blood transfusion?
We take not that the allergic reaction of that PCV volume. So we give the either IV the anti-allergic regimens, Avil या फिर dexamethasone.
Okay, any question, madam? No?
Okay, no. Okay, next candidate. Time is as such over.
Thank you.
Now I would like to invite Dr. Dhaval Patel. Your time starts now.
Good afternoon to respected chairperson, judges, and fellow colleagues. I am Dr. Dhaval Patel, third year resident from Department of Obstetrics and Gynecology, SMIMET, Surat. I am presenting a poster on laparoscopic ovarian detorsion in pregnancy. Maternal ovarian torsion during pregnancy is a rare event with a reported incidence of 1 to 10 per 10,000 spontaneous pregnancies. Although the exact etiology is unknown, common predisposing factors include the moderate size cyst, free mobility, and long pedicle. There is a 5-fold increased risk of ovarian torsion during pregnancy. Ovarian torsion in pregnancy more commonly occurs in the first half of the gestation. Early diagnosis and the treatment is very important to salvage the adnexa in the woman desiring to continue the pregnancy and the preserve ovarian for future function. Case report: a 21-year-old female, primary gravida with 2 months of amenorrhea, presented with acute lower abdominal pain more on the right side for 1 day. On per abdominal examination, mass of 18-week gravid uterus felt, which was standard. On per speculum examination, cervical congestion was present. On per vaginal examination, suggestive uterus, anteverted 10-week size deviated towards left side, around 5 by 6 cm square size, right side tender adnexal mass felt. Her USG suggestive of single live intrauterine fetus of 9 weeks, 6 days of gestation. Right ovary was bulky, approximately 4.4 by 4.6 centimeter square size and 2.6 by 2.4 centimeter square size. 2 simple cysts without internal vascularity with multiple hyperechoic follicles in the ovary. Possibility of ovarian torsion. On laparoscopy, 6.6 centimeter square size ovarian cyst was present with blackish discoloration and with small areas of preserved vascularity seen on the right side. 2 rotations of fallopian tube and the ovary present about 2 to 3 centimeters away from the conval end. Laparoscopic ovarian detorsion with cyst puncture with shortening of ovarian ligament was done. Post-operative was uneventful and the patient discharged on 4th post-operative. On follow-up, she had no significant complaint with USG of 14 weeks of gestation. Ovarian cyst during pregnancy may be managed conservatively with observation if diagnosed in first trimester. The optimum time for the surgical intervention during pregnancy is between 16 and 28 weeks of gestation. Immediate surgical intervention, irrespective of gestational age, may be warranted in cases of ovarian torsion, rupture of ovarian cyst, or if there is a suspicion of malignancy. Diagnosis of the ovarian torsion in a pregnancy can be made with clinical presentation in conjunction with ultrasonogram and color Doppler. Treatment options are limited to the surgery, either by the laparoscopy or laparotomy. Pregnancy loss seems to be very rare, and the post-operative progesterone supplementation is recommended when the corpus luteum is removed prior to 7 to 9 weeks of gestation. I am concluding that ovarian torsion is a gynecological emergency and can occur during pregnancy. Detorsion alone or detorsion with plus ancillary procedures carried out via laparoscopy is recommended to treat pregnant women suffering from ovarian torsion, owing to the advantage of a shorter hospital stay and the favorable surgical and pregnancy outcome. These are the references. Thank you.
Dhaval?
Yes, ma'am.
Which are the criteria will you consider before taking the decision of detorsion of ovary?
Ma'am, first of all, examine on history basis and the patient gestational age. And in patients, patient came with ovarian torsion with ultrasonogram suggestive of ovarian torsion. Directly, patient admitted for the posted for the surgical procedure.
Okay. Intraoperatively, are there any criteria which will determine to go for a detorsion or to remove the ovary?
Ma'am, is there on exam during intra-op there is a black necrosis or ovarian particle is there, so we can preserve. Recent studies that shows that in earlier era there was some belief that if detorsion occurs, it may be causes the embolism, but in recent studies shows that detorsion cannot do that such things like embolism. if blackish necrosed area after detorsion, 100% oxygen is delivered if there is a chances of revascularization in that in future.
How will you carry out the follow-up of a patient who has undergone detorsion? Category 1 is pregnant and category 2 is non-pregnant.
If the woman is pregnant, then the follow-up USG suggestive of that patient have on basis of examination and the history complaint wise is that patient has a previously significant complaint and then relief in complaints. In not pregnant, we can go for serial ultrasound.
Which things will you see on ultrasound in follow-up of a non-pregnant detorsion of the ovary has been done?
Vascularity on color Doppler of ovarian pedicles, which we have operated.
Okay, fine. Deepa, madam?
Yes. Any advantages of laparoscopic detorsion over open surgery during pregnancy?
Ma'am, it causes a shorter hospital stay and pregnancy outcome will be there. If we put incision for laparotomy, it might be hampered to the uterus.
Anything to do with the anesthesia which is given during laparoscopy? Do you need to explain to the patient about the risks of anesthesia?
During in laparoscopy, we have general anesthesia.
Yeah. So do you think you need to explain something to the patient?
It may be hampered to, it might be affected to patient.
Okay, what are the like ultrasound findings of torsion?
There is the edematous ovarian pedicle, then classical whirlpool sign if vascularity is intact.
Okay, why do the chances of torsion increase in the first time?
There in pregnancy, increase the increased vascular pulsation flow, increased vascular flow that might be causes the incomplete torsion might turn into complete torsion.
Okay, your time is over now.
Thank you, ma'am.
Now I invite Dr. Aishwarya Nayak.
Ashwin bhai, now you start the time management, okay?
Yes, madam. Aishwarya, start.
Respected chairperson, judges.
Slide sharing. Yes, your time starts now. Slide sharing first. Slideshow.
Good afternoon, respected chairperson, judges, and all my dear colleagues. I, Dr. Aishwarya Nayak from Sleeman Medical College, Surat, presenting my poster on obstetric hysterectomy with 24-week fetus in situ in a case of placenta percreta. Placenta accreta spectrum disorders refers to the penetration of tropoplastic tissue through decidua basalis into the underlying uterine myometrium. Past disorders have emerged as a significant obstetric challenge with an exponential increase in the number of cases, mainly due to the liberalized use of cesarean section. Past disorders contribute significantly to maternal morbidity and mortality because of severe and sometimes life-threatening, intractable postpartum hemorrhage requiring emergency hysterectomy. Case summary. A 33-year-old female G5P2L2A2 with previous 2 cesarean section presented with history of 6 months of amenorrhea and USG suggestive of 23 weeks IUFD with placenta percreta. On admission, the patient was vitally stable. On per abdomen examination, uterus size was 24 weeks. The hemogram showed HB of 9.3 gram per cell. Decision for a planned obstetric hysterectomy was taken after discussing the risks, complications, and need for post-op ICU care with the patient's relatives. Under spinal anesthesia, the abdomen was opened with a vertical incision. A gravid uterus with ballooned out placenta was seen with a thin strip of myometrium and serosa over it in some areas. Bladder fibers adherent with the uterus and bladder was separated with blunt and sharp dissection. Sequential clamps were applied and uterus with the fetus in situ was removed. 4 units of RCC and 4 units of FFP were transfused in the perioperative period. Histopathological examination of the specimen confirmed the diagnosis of placenta preta. The post-op period was uneventful and patient was discharged on the 5th post-op day. Placenta accreta is defined as abnormal trophoblast invasion of part or all of the placenta into the myometrium due to the partial or complete absence of metabux layer. The most accepted hypothesis is defect in the endometrial myometrial interface, which leads to a failure of normal decidualization in the area of the scar. Antenatal diagnosis can be made using USG with color Doppler as early as 2nd trimester. The diagnostic feature on USG includes absence of a normal hypoechoic boundary between the placenta and the myometrium. The most accepted approach for management is cesarean hysterectomy at 34 to 36 weeks with placenta left in situ after delivery of the fetus. Attempts to remove the placenta are associated with significant risk of hemorrhage. Other complications include future loss of fertility, ARDS, DIC, complication related to massive blood transfusion, and injury to other pelvic organs. To conclude, high degree of suspicion in the presence of risk factors and timely antenatal diagnosis followed by elective surgery in a tertiary care center with multidisciplinary approach is mandatory for successful outcomes in cases of past disorders. Thank you.
Aishwarya, which are the predisposing condition or risk factor in cases of this past disorders?
Ma'am, past history of cesarean section, myomectomy, hysteroscopic surgery, uterine curettage, or endometrial ablation, and concurrent with placenta previa, it is more common.
Okay. Is there any association of higher the risk with an increasing number of cesareans?
Yes, ma'am. Definitely, there is a higher chance with the increasing number of cesarean sections.
Do you know what is the percentage chance with 1 cesarean section, with 2 cesarean sections, and with 3 cesarean sections?
Ma'am, it is around 3% with 2 cesarean section, 23% with 3 cesarean section, and around 50% with 4 cesarean section.
How will you decrease the intraoperative blood loss in case of past disorder?
Ma'am, we can do aortic compression. We can give tranexamic acid. We can, while proceeding for obstetric hysterectomy, we can first clamp cut and drop the pedicles. And after uterine artery ligation, we go for ligation of the cornual pedicles.
Any role of intermediate ligation?
Ma'am, it has been tried, but not found to be very successful, in particularly in past.
Okay, what are the other complications with placenta accreta syndrome spectrum?
Ma'am, first is massive blood loss, needing massive blood transfusion, injury to pelvic organs like ureter and bladder, and post-op complications like ARDS, DIC, multi-organ failure, and need of venti support and ICU care.
What is the rationale of leaving the placenta behind and monitoring the patient post-operatively? Has it found to have any benefits, or it has been abandoned?
Ma'am, expectant management has not been found to be very useful. It has to be done on the basis of case selection, not very useful.
Okay. Disadvantages of massive blood transfusion?
Ma'am, volume overload, complications due to volume overload like acidosis, coagulopathy, hypothermia, hyperkalemia, hypocalcemia, etc.
Okay, time is over.
Thank you, ma'am.
Thank you.
Now I invite Dr. Jarana Patel. Okay, your time starts now.
Good afternoon, everyone. Respected chairperson, judges, and all my fellow colleagues. I, Zarna Patel, first-year resident of Smimer Medical College, would like to present my poster on acute uterine inversion, a life-threatening obstetric emergency. Uterine inversion is a rare but life-threatening obstetric emergency. It is defined as passage of the uterine fundus through the endometrial cavity and cervix, turning the uterus inside out. Its incidence is 1 in 2000 in vaginal delivery. The incidence of uterine inversion has decreased fourfold after the introduction of active management during third stage of labor. Case report: a 21-year-old female P2L2 was referred to our hospital with postpartum hemorrhage. She delivered a live and healthy female child 2 hours prior and had profuse vaginal bleeding. On examination, patient was pale and anxious with tachycardia and blood pressure of 90 by 60 mmHg. Her HB level was 7 gram%. On per abdominal examination, it was soft, tender, and uterine fundus was not palpable. On per speculum examination, cervical rim was seen with a globular firm mass in the vagina and active bleeding. A diagnosis of acute second-degree uterine inversion was made and immediate resuscitation was initiated using intravenous fluids and 4 pints of RCC and FFP. All high-risk consents were explained and taken. Patient was immediately shifted to the operating room and uterine reposition was done under general anesthesia by Johnson's maneuver. Uterotonic agents were given after repositioning of the uterus. Oxytocin infusion was maintained for 24 hours to prevent reinversion. Post-op patient was stable and was shifted to OBS ICU. She made an uneventful recovery and was discharged on 5th postpartum day. Risk factors associated with this situation can be spontaneous, that is 40% due to short umbilical cord, fetal macrosomia, placenta accreta, and connective tissue disorders, while iatrogenic cause comprises of faulty management of third stage of labor and unskilled pulling of the cord. Diagnosis of uterine inversion is mainly clinical, often suspected in presence of massive blood loss after childbirth or in absence of uterine fundus during abdominal palpation. It can be classified in 4 degrees depending on the localization of the uterine fundus. As shown in the above figure, a prompt recognition will enable the immediate repositioning of the uterus before it becomes edematous and incarcerated by the constricting ring, which requires surgical intervention. To conclude, uterine inversion is a life-threatening obstetric complication that can lead to hypovolemic and urogenic shock, requiring rapid diagnosis and prompt surgical intervention and practicing active management of third stage of labor, thus reducing morbidity and mortality associated to it. The references are shown below. Thank you.
Your time is over. Question.
Jharna, how will you manage third stage of labor to prevent such kind of life-threatening complication?
Ma'am, in active management of third stage of labor, with a uterine contraction within 1 minute is initiated by giving uterotonic agents immediately after childbirth, and a controlled cord traction is given, and fundal massage is given after delivery to prevent postpartum hemorrhage.
Where should your left hand be when you're giving controlled cord traction to prevent uterine inversion?
Ma'am, the palmar surface of the left hand is placed over the pubic symphysis at the junction of upper and lower uterine section, and it is placed in upwards and backwards direction towards the umbilicus.
What will be the immediate clinical manifestation of uterine inversion?
Ma'am, the patient will be in shock with hypotension and tachycardia and profuse vaginal bleeding. The patient will present with postpartum hemorrhage.
If the placenta is already adherent and placenta is not separated, do you anticipate any bleeding or some more or other type of shock will be there? What is that type of shock?
Ma'am, if the placenta is already adherent and it is not separated, then we should try to reposition the uterus first rather than removing the placenta. And after the repositioning, the placenta should be removed.
Okay, time is over.
Thank you, ma'am.
Now I invite the Chetna Damor.
Can I start?
Yes, your time starts now.
Good afternoon, respected chairperson, judges, and my dear colleagues. I, Dr. Chetna Damur, third year resident in the Department of Obs and Gynecology, Mimir Surat, presenting a poster of laparoscopic vaginoplasty by David's method in case of MRK syndrome. MRK syndrome is a congenital aplasia or severe hypoplasia of Mullerian duct derivatives. Incidence is about 1 in 4,000 to 5,000 per live female. Patients with Mullerian agenesis usually are identified when they are evaluated for primary amenorrhea with normal growth and pubertal development. The vaginal canal markedly shortened and may appear as a dimple below the uterus. Among surgical procedure of MRK syndrome, the laparoscopic Davidoff technique seems to be offer the most feasible and effective approach for creating a new vagina. A 25-year-old nullic gravida female presenting with primary amenorrhea, normal secondary sexual character with cyclical abdominal pain. On local examination, the vaginal canal markedly shortened and may appear as a dimple. On per-rectal examination, uterus not filled, and USG revealed hypoplasia of uterus with both ovaries normal. The diagnosis of MRK syndrome was made after informed written consent laparoscopic vaginoplasty by Davidoff's method was planned. Cost of dilatation of vagina done with mold until commencement of regular sexual activity. The principle of the Davidoff technique is to create a new vagina on peritoneum is the lining. A new vagina space created on dissection vaginally and by opening the vesical space laparoscopically, a free fold of peritoneum was created through the gentle dissection. The mobilized peritoneum was pulled down and sutured to the edges of inside vaginal mucosa with help of 4 vertical stitches. First string stitches taken laparoscopically to close peritoneal end of new vagina. A Davidoff technique of vaginoplasty is a minimal invasive method having advantage because peritoneal lining changes to stratified squamous epithelium resembling normal vagina and having acidic pH, minimal graft rejection and failure, less chances of contracture, and minimal post of dilatation required. A laparoscopic approach to vaginal reconstruction is safe and effective in situation where vaginal dilatation has failed. It offers reduced morbidity compared to the classically available procedure. As both ovaries are fixed with the apex of new vagina, in future, we can retrieve ovum by vaginal route and patient can have child with surrogacy. Thank you.
Chetna, before posting the patient for vaginoplasty, which factors will you consider?
Ma'am, evaluate a patient's condition, history, taking like primary amenorrhea is a main clinical feature, and karyotype is done. USG done, ma'am.
All these patient of having absent vagina has got such kind of definitely investigating report, but hello.
Huh, ma'am.
All the patients having absent vagina has such kind of reports or fixed criteria, but before posting the patient for vaginoplasty, how will you counsel the patient and which points will you consider?
Ma'am, before we do operation, patient counsel about this. It is not a it is not after this OT a patient not conceive. So patient only.
So you need to reinforce that it is going to only serve the purpose of the sexual function.
Sexual activity, ma'am.
Okay.
Production, right?
Okay. Deepa, madam?
Yeah. How can you prevent the contracture? You said there are less chances of contracture with this procedure, agreed. But still,
Yes,
to prevent contracture, you would have had done something, no? You would have, what did you do?
Ma'am, post-operative mold is kept and advised to patient continue sex. If patient is sexual active, so advised to continue sexual intercourse, or in some patient mold is kept on neovaginal space.
Okay, time is over.
Thank you.
Now I invite Dr. Amit Baldania.
शेअर कर.
Sir, can I start?
Your time starts now.
Good afternoon, respected judges, chairpersons, and my fellow colleagues. I here Amit Baldani, R1 in Obstetrics and Gynecology Department, present a case of cesarean scar ectopic pregnancy. Scar ectopic is the rarest type of ectopic pregnancy and approximate incidence being 1 in 2000, in which the developing blastocyst implant into the myometrial defect in the site of previous uterine scar. This type of pregnancy is the leading cause of pregnancy-related mortality in the first trimester due to life-threatening complications such as rupture and hemorrhagic shock. However, incidence seems to be raised due to increasing number of cesarean section and widespread use of transvaginal sonography that allow earlier detection of such pregnancies. A case of 23-year-old female G2P1L1 with history of 2.5 months of amenorrhea and LSCS 3 years ago came with TBS UG suggestive of LSCS scar pregnancy of 49 into 33 mm size gestational sac with live embryo. Entire choriodecidual plate was in LSCS scar region with outer quanta bulging and cover internal walls. Myometrial thickness overlying the gestational sac is 1.9 mm to 3.7 mm. She was vitally stable with normal blood profile. On examination, per abdomen was soft and non-tender. On per vaginal examination, uterus was anteparted with 8 to 10 weeks size. She was admitted and posted for elective laparotomy for scar ectopic. In intraoperative finding, ballooning out G-sac was present over the previous LSCS scar. Small transverse incision capped and G-sac with placental membrane removed. Her post-operative period was uneventful.
Yeah,
Most accepted theory for cesarean scar ectopic is in which the blastocyst into to a microscopic adhesion tract which occurred due to trauma of previous cesarean sections or any other uterine surgery or even after manual removal of the placenta. Another complication of cesarean section and scar ectopic is the morbidly adherent placenta. It is believed that scar ectopic and a morbidly adherent placenta are contempt spectrum implantation abnormalities starting with scar ectopic and progressing to different placenta elevation as the gestation advances. There are two types of management, medical and surgical. The medical management mostly consists of methotrexate administrations. Either systemically or locally. The medical approach is sometimes combines uterine artery embolization, minimizing the risk of life-threatening hemorrhage. Surgical intervention consists of laparoscopy or
Please unmute karo. Hello. Unmute. We cannot able to hear you. Please unmute your computer.
Thank you.
Now we can, no problem. Now we can hear you.
Okay, sir. Hello.
You are on this.
Nitrofilament 100. 100. So power.
Dr. Amit, you can proceed. We can able to hear you.
Old question chapter. So cesarean's conclusion, cesarean scar pregnancy is a rare form of ectopic pregnancy which can lead to life-threatening complication. Treatment should be planned taking into consideration the hemodynamic status of the patient's absence or presence of scar rupture, HCG level, and desire for further fertility. Thank you.
Hello.
Ma'am.
Amit, which are the criteria which will you consider before deciding the line of treatment? That is, this patient will be for surgical management or this patient will be for methotrexate therapy. Are there any criteria? Can you enumerate?
For medical management, first we go for beta HCG level. The pregnancy, for medical management, the cardiac activity should be absent. Beta HCG level should be less than 5,000 international unit.
Location of the GSEC has any role in deciding the line of treatment?
No idea.
Okay. What dose, how will you give the methotrexate therapy? What dose and what kind of schedule?
There are two types of regimen, single dose and multi-dose. Single dose consists of 50 milligram per meter square body surface area of the patients, and multiple dose 1 milligram per kg on day 1, 3, 5 and 7.
આને તો બધું મિથોટ્રેક્સેટ નું પૂછ્યું યાર. શું પૂછ્યું?
Hello. Hello.
Yes, ma'am.
Is there any role of evacuation through vaginal route in case of CSP?
Yes, ma'am. Yes, it can be considered.
Which precautions will you take during evacuation?
Can it be done under guidance of ultrasound?
Yes, ma'am. It must be done under the guidance of ultrasound.
Any laparoscopic guidance is required in which particular type of cases?
Laparoscopy, mostly unruptured type of unruptured tubal ectopy, unruptured ectopic, and his patient should be hemodynamically stable.
Okay, Deepa madam.
Yeah, as madam said, what are the advantages of doing it under laparoscopic guidance? Have you read about it somewhere? Okay. What is the cause of scar ectopic pregnancy? What has gone wrong during this? Has anything gone wrong during the suturing of the during the cesarean section, which has led to the implantation in the scar? Are there any theories related to it?
Means increased number of in myometrial defect during cesarean sections or any surgery in uterus leads to more chances of cesarean scar pregnancy.
So anything which can be done to prevent that?
No.
What are the radiological findings of scar ectopic pregnancy? Radiological diagnosis.
Time is over.
Okay, thank you.
Now I invite Dr. Jigisa Patel.
You can start sharing your screen. Jigisa.
Your time starts now, Jigisa.
Good afternoon, judges, chairperson and all my dear colleagues. I, Dr. Jigisha Patel, first year resident in Obs and Gynec Department, SMIME Surat, presenting an unusual presentation of the cervical fibroid. Cervical fibroids are rarity as compared to fibroids arising from other part of the uterus and account for 1 to 2% of all fibroids. They arise from supravaginal or vaginal portion of cervix. A cervical fibroid can lead to menstrual irregularities, urinary retention, urinary frequency, constipation, dyspareunia, and postcoital bleeding, depending upon their location. Large cervical fibroids are difficult to handle and need an expert hand to operate these cases.
A case report, a 45-year-old female V2L2 presented with complaint of inability to pass urine since 7 days, breathlessness on exertion since 5 days, and irregular menses and abdominal pain since 1 month. Abdominal examination revealed a mass corresponding to 16 to 18 week size of uterus, and in vaginal examination, mass is variegated in consistency and mobile with uterus. MRI pelvis revealed a large fibroid arising from posterior wall of the cervix or lower uterine segment situated in POD, causing anterior inferior displacement of uterus and anterior displacement of urinary bladder. After necessary investigation, arranging adequate blood and return informed consent, patient was posted for exploratory laparotomy. Intra finding were mass of approximate 10 into 10 centimeters square in size arising from posterior cervix, capsule of mass dissected with sharp and blunt dissection from periphery, then mass with uterus removed, a total abdominal hysterectomy with bilateral salpingectomy done. Her post-op period was uneventful and HPV report was in confirmatory with that of cervical leiomyoma. Discussion, cervical fibroid may be classified as anterior, posterior, central, and lateral according to their position. Anterior fibroid bulges forward and undermine the bladder, causing urinary retention and frequency. A posterior fibroid flatten the pouch of Douglas, compressing the rectum against the sacrum, resulting in constipation. Lateral cervical fibroid starting on side of cervix burrow out into broad ligament and expand it. Central cervical fibroid expand the cervix equally in all directions but produce mainly bladder symptoms. Treatment of cervical fibroid is either myomectomy or hysterectomy. They give rise to greater surgical difficulty by virtue of relative inaccessibility and close proximity to bladder and ureter. Wherever the ureter and uterus are in relation to fibroids, they will always be extracapsular. The knowledge of this fact can turn potentially dangerous procedure into relatively safe one. Conclusion, a large cervical fibroid are very rare scenario and require an expert hand to operate them to avoid blood loss, prevent inadvertent injury to ureter or bladder. Intracapsular myomectomy followed by hysterectomy is good intervention to avoid many complications. Thank you.
Jigisha, what are the intraoperative complications of hysterectomy when you perform for a huge cervical fibroid? And how will you prevent it?
Firstly, ma'am, there will be severe blood loss and injury to ureter, bladder, chances of infection. And we, for blood loss, we can arrange a pre-op. We can arrange pre-op blood product for the patient after investigation of her CBC report. And for ureter injury, we can perform a methylene blue dye test.
Anything else preoperatively you can do to map the ureter so that you don't inadvertently cause injury?
Okay.
You have the availability of someone in your institute.
Yes, ma'am. Nephrologist.
Will a nephrologist help or someone else will be of help?
Sorry, ma'am. A urologist.
What can be done? And if that cannot be done and you are finding that it's a large cervical fibroid as you have stated in your case, what other things can be done intraoperatively to delineate the ureters?
Ma'am,
I think in the capacity of first year, you must be knowing the anatomy of pelvic ureter. So what will be the changes in that particular anatomy in cases of fibroid?
Okay, time is over, madam.
Okay.
Thank you.
Now I invite Dr. Tripal Rathwa. Okay, your time starts now. Unmute yourself first.
Tripal.
Yes, start now.
Good afternoon, respected judges, chairperson, and all dear my colleagues. First, I, Dr. Tripal Rathwa, first year resident from Smimer Medical College, Surat, presenting a rare case of vaginal leiomyoma. Vaginal leiomyoma introduction. Vaginal leiomyoma remain an uncommon untidy. Vaginal leiomyoma usually occur as a single well-circumscribed mass arising from the midline anterior wall and less common from posterior and lateral wall. Case report. A case report of a 36-year-old female P2L2 presented with the complaint of lower abdominal pain, difficulty in maturation, and heaviness in vagina. Since last 1 year, on PS examination, anterior vaginal swelling was present. Cervix was higher up, and which was seen separately from swelling. On PV examination, uterus was retroverted and bulky. 5 into 5 centimeter square form swelling was presented on the anterior wall. USG TVS was suggestive of presence of 43-38 into 47 mm size well-defined solid heterogeneous hypoechoic lesion was noted in the soft tissue of the posterior wall of urethra, anterior leaf of cervix, anterior wall of upper vagina. Patient was managed surgically with the excision of mass through the vaginal route. Bladder and urethra were protected by catheterization. Diagnosis of a leiomyoma was confirmed by histopathological examination. Discussion. Leiomyoma are common in uterus and to some extent to the cervix, the round ligament, uterosacral ligament, inguinal canal. The clinical diagnosis of the vaginal leiomyoma required a single higher index of suspicious because the tumor could be easily mistaken for cystocele, urethrocyst, Skinner duct abscess, Gardner duct cyst, urethra diverticulum, vaginal cyst, Bartholin gland cyst, and or vaginal malignancy. To conclusion, vaginal leiomyoma may present with the variety of clinical feature and may be mistaken preoperatively for a cervical fibroid. Excision and enucleations are the treatment of choice. Thank you.
Triple. Before excising this vaginal myoma, which is on the anterior vaginal wall, which precautions will you take?
First, protect the bladder and urethra by catheterizations.
Okay.
And emptying the bladder and downward the protect the bladder first and bladder and urethra.
What is the commonest site for a vaginal leiomyoma? Which anterior vaginal wall or posterior vaginal wall?
Anterior vaginal wall.
So what is the most common entity with which you can confuse this vaginal leiomyoma?
Vaginal cyst, vaginal malignancy, then Skinner duct abscess, Gardner duct cyst, then the Bartholin gland cyst, then urethra diverticulum, cystocele, urethrocyst.
How long will you keep catheter in situ post-operatively?
Post-operatively 48 hours, ma'am. After surgery, 48 hours.
Okay. What are the post-operative delayed complication of this vaginal myoma excision?
Vaginal myoma excision.
Your time is over.
Thank you, ma'am.
Now I invite Dr. Dhruv Mangukia. Okay, your time starts now, Dhruv.
Good afternoon, respected chairperson, judges, and dear colleagues. I, Dr. Dhruv Mangukia, Department of First Year Resident, Department of Obstetrics and Gynecology, SMIMER, Surat, presenting a poster on case of immature teratoma in 11-year-old girl. Introduction. An immature teratoma is derived from 3 germ layers, which is highly malignant tumor, accounting for 40 to 50% of malignant germ cell tumors. Reasons of immature or embryonal structures differentiate them from benign mature cystic teratoma, that is dermoid cyst. It is usually seen in women with 10 to 20 years of age group and rarely post-menopausal group affecting only one ovary. 11-year-old girl presented with complaint of abdominal pain for 10 to 15 days on per abdominal 7 by 4 centimeter square solid non-tender mass with restricted mobility arising from pelvis was present. USG suggestive of 7.2 by 8.4 by 8.7 centimeter cube. Degenerated mass in pelvis with necrotic area was present. Possibility of ovarian tumor or ovarian teratoma. CT scan suggestive of large lobulated solid cystic mass lesion showing multiple prominent vascular channels extending from pelvis to umbilical region and compressing bilateral ovaries and uterus with neoplastic etiology likely of ovarian origin. Tumor markers were alpha fetoprotein 1900 nanogram per deciliter and LDH 397 unit per liter. Patient had undergone staging laparotomy with right salpingo oophorectomy for ovarian teratoma. Intraoperative frozen section suggestive of immature teratoma. Diagnosis of immature teratoma was confined by histopathological examination. Post-operatively, patient had taken 3 cycles of chemotherapy, including BEP regimen. A discussion: an immature teratoma may remain asymptomatic or may present with acute pain in abdomen because of torsion, infection, rupture, or malignant change. More specifically, immature formations of teratoma are classified into 3 categories. Firstly, lesions that include immature ectodermic tissue and neuroectodermal epithelial tissue in rosettes and tubules. Secondly, masses that contain immature mesenchyme with immature cartilage, immature fat, osteoid, and rhabdomyoblast. And in third one, immature endodermal tissue as well as hepatic tissue, intestinal type epithelium with basal vacuolization, and embryonic renal tissue. The malignancy risk increases with the rate of increase of neuroepithelial tissue in immature teratoma. Follow-up after treatment is usually based on clinical examination and symptoms with expert use of CT scans. Conclusion: malignancy of immature teratoma in women less than 20-year-old is confined between 0.2 and 1.4 per lakh, while in women between 20 to 29 years old does not exceed the level of 2.2 per lakh. Although the tumor is rare, but in young adolescents, the possibility of this teratoma should always be considered and multidisciplinary approach for their treatment should be conducted. Thank you.
Through pre-operatively, how will you counsel the parents of 11 years old girl?
Pre-operatively, for the counseling, for in future the fertility desire of the patient, and
she is 11 years old.
11 years. So I will go for salpingo oophorectomy. And if the malignancy is more than, if it requires bilateral oophorectomy, then I will ask for fertility desire and
what is the role of frozen section which was done?
Frozen section, it will help in diagnosis, and as we are doing staging laparotomy, it will help in further dissection during the intraoperatively.
How will you differentiate a mature cystic teratoma from an immature cystic teratoma clinically?
In immature teratoma, it only consists of mostly neuroepithelium, while in mature cystic teratoma, it contains the bone, cartilage, hair.
Okay, time is over.
Thank you.
Now I invite Dr. Vishwa Patel. Okay. Your time starts now.
Good afternoon, everyone. Good afternoon, chairperson, judges, and fellow colleagues. I, Vishwa Patel, first year resident in Obs and Gynec Department, SMIMER, would like to present my poster on laparoscopic vesicovaginal fistula repair. Vesicovaginal fistula represents a significant morbidity in female urology with an incidence that varies between 0.3 and 2%, most of which are iatrogenic. It is estimated that 0.8 per thousand of all hysterectomies are complicated by the development of a VVF. The typical post-surgical fistula is the result of localized trauma to healthy tissue. Coming on to the case, we had a case of a 40-year-old female, P3L3, who came with complaint of watery discharge per vaginum since 20 days. She underwent a total abdominal hysterectomy 1 month ago in a private hospital. On her 10th post-op day, she developed watery discharge per vaginum. On per abdominal examination, the abdomen was soft, non-tender, and an AH scar was present. On per speculum examination, watery discharge was demonstrated. On performing the 3 swab tests, there was discoloration of the middle swab, indicative of the vesicovaginal fistula. She underwent a CT IVP, which showed a 6 by 5 millimeter square fistulous tract between the posterior wall of the bladder and the anterior wall of the upper 1/3 of vagina. The patient underwent a cystoscopy with bilateral stent insertion and laparoscopic repair of the vesicovaginal fistula, with primary repair of the bladder and vagina along with omentopexy. The patient was catheterized with a Foley silicone catheter, which was removed after 21 days. The stent was kept in situ for 6 weeks, and after its removal, the patient was clinically asymptomatic. The vesicovaginal fistula can be allowed to heal spontaneously in cases where it is small or epithelialization has not yet occurred. But in majority of the cases, it has to be operated either by vaginal or abdominal route. Simple fistulas can be treated through vaginal approach, whereas complex fistulas can either be treated by using a myocutaneous flap or through an abdominal approach. Laparoscopic repair of vesicovaginal fistula with intracorporeal suturing and omentum interpositioning is a feasible procedure in selected patients. It is a useful adjunct to transvaginal repair of fistulas if the surgical morbidity of the open abdominal approach is decreased. To conclude, total abdominal hysterectomy can be complicated with the occurrence of vesicovaginal fistula, but it can now be operated through a laparoscopic route, which is a minimally invasive approach. It is associated with a faster healing time and less post-op complications. However, this procedure requires expertise. Thank you.
Vishwa?
Yes, ma'am.
What are the points will you consider in post-operative care of a patient who had undergone laparoscopic vesicovaginal fistula repair?
Ma'am, the first thing that we need to ensure is that there is a continuous bladder drainage, that the catheter care is appropriately taken for the patient, because the patient needs to be catheterized for at least 21 days till at least the hematuria resolves. And that is the main priority that we need to take care in the post-op care of the patient.
As in the capacity, I think you are first year resident, huh?
Yes, ma'am.
In capacity of first year resident, how will you take care of catheter?
Ma'am, catheter care is where every day the length of the catheter that is present outside the urethra, we clean it with betadine followed by spirit, and we clean the entire length of the catheter that is present outside. And we also flush the catheter both ways.
Which catheter is preferable?
Ma'am, a silicone catheter is preferable because we can keep it for a longer duration of time without changing the catheter.
What is the cost of that silicone catheter?
Silicone catheter is probably around 500 to 600 rupees.
Is it available in the institute or you need to?
Ma'am, we have it is available in our institute.
Okay. Good. What is the incidence of bladder injury with an abdominal hysterectomy and with a vaginal hysterectomy?
Ma'am, it is around 0.3 to 2%.
For?
Sorry, ma'am?
For which route?
For abdominal hysterectomy, the incidence is less when it is in vaginal hysterectomy and more when it comes to abdominal hysterectomy. Because in abdominal hysterectomy, there is involvement of mobilization of the bladder. So that is why there is a higher incidence when it comes to abdominal hysterectomy.
Okay, time is over.
Thank you, everyone.
Now I invite the Hina Wasim. Hina Wasim.
Good afternoon, sir.
Good afternoon. Start the slide sharing first.
Okay, sir.
Mimer people, first stop your slide sharing.
Sir, it's already done.
Okay.
Hannah, your time starts now.
I'm first year resident from Shardaman Hospital under Srimati NHL Municipal Medical College. My topic is corneal pregnancy and its management. Corneal implantation of the blastocyst is rare, accounting for 2 to 3% of ectopic pregnancies, which are not viable. The complications include uterine rupture and massive bleeding, which usually occur before 12 weeks of pregnancy. My case is of a right-sided corneal ectopic, which was diagnosed by serial beta HCG levels and transvaginal ultrasound, and was managed by diagnostic hysteroscopy and laparoscopy, followed by evacuation of the ectopic by laparotomy and right-sided salpingectomy. My case was of a third gravida female who was having 2 months of amenorrhea, who came to our hospital and had undergone DNA 2 times at a private hospital, and then she was referred to a tertiary center to rule out corneal pregnancy. History was she had 1 previous CS and 1 vacuum delivery. She was also having history of DNA at private hospital and was referred to tertiary center. And she was admitted in our hospital prior to this and was managed conservatively. Serial beta HCG level was advised and progesterone withdrawal was given. Vitally, she was stable. Transvaginally, maturity was 8 weeks 1 day. Cardiac activity was absent, and there was a GSAC 45 by 36 mm size noted in right corneal region, which showed the possibility of right corneal pregnancy. Serial beta HCG was done, which showed decreasing trend. Management was done, and diagnostic hysteroscopy and laparoscopy were done. Hysteroscopic findings were left cornu and ostia were visible, but uterine cavity was obliterated with bulging mass from right cornu and fundus region, and right cornu and ostia were not visible. Laparoscopic findings were a bulging mass was seen at right corneal region with bluish discoloration and vascularity, and right tube was seen congested. And on-table decision was taken for laparotomy, and the corneal ectopic was evacuated. Control the bleeding right uterine artery followed by right ovarian artery was ligated. Most ectopic pregnancies usually occur in the fallopian tube and account for approximately 90% of all ectopic pregnancies, and is followed by less common corneal pregnancies accounting for about 2 to 4%. Morbidity and mortality of corneal ectopic is directly related to the length of gestational age. Even up to 16 weeks length of gestational age, and this type of pregnancy in particular can be discovered with advanced gestational age even up to 16 weeks due to adjacent supporting myometrial walls and good blood supply. Mortality rate for all ectopic pregnancies is roughly 9 to 14%, and for this it is considered the leading cause of death in the first trimester of pregnancy. Diagnosis is usually delayed in this case because the tube has good muscular and vascular support.
Your time for presentation is over.
Okay.
Now, what are the complications of corneal ectopic pregnancy? Main complication of corneal ectopic pregnancy. Suppose it rupture, then what happens and why?
Massive hemorrhage and bleeding and can occur because that area is supplied by uterine artery and ovarian artery, so hemorrhage can occur.
What are the other variety of ectopic pregnancy which may require the hysterectomy?
Other varieties.
One is corneal ectopic, one more ectopic can need for the hysterectomy.
I don't know, sir.
Okay.
Was there any predisposing factor in your case for,
No.
for the occurrence of cornolectopic?
No, there were no predisposing factors. No
What's
risk
the
factor.
obstetric history you said?
There was one CS and one vacuum delivery was done.
How will you control hemorrhage during cornolectopic resection?
We can ligate the ovarian and uterine artery.
Your time is over. Thank you.
Thank you.
Now I invite the Harsh Patel.
Hello.
Start your slide saying first.
Good afternoon, everyone.
Your time starts now.
Dear resident at Shardaben Hospital, which is under the NHL Municipal Medical College. My today's poster presentation topic is successful management of chronic ectopic pregnancy by systemic use of methotrexate. Implantation of blastocyst elsewhere from the endometrium is termed as ectopic pregnancy, which has led to considerable morbidity and mortality. Urine and serum serial beta HCG, SS and TVS allows earlier diagnosis and clinical.
Okay, continue. You continue, Harsh.
Harsh, you please continue speaking.
Harsh, you are unmuted. What happened?
Hello. Am I audible, sir?
Yes.
My case report is a 23-year-old Muslim female patient of low socioeconomic status, gravida 2, para 0, abortion 1, live 0 issues, came to SL hospital with 2 months amenorrhea with on and off spotting PV for 10 to 15 days. She had a past history of spontaneous abortion 2 years back, followed by DNE. On general examination, she was vitally stable with no paler ictus edema. On per abdominal examination, it was a soft obesity plus without any rebound tenderness. On per speculum, cervix was NAD. On PV examination, uterus was retroverted. Exercise can't be made due to obesity, and mild right fornicel tenderness was felt. On USG evaluation, uterus was retroverted. ET was 10 mm, approx 18 by 16 mm size. Well-defined echogenic lesion was found in the with surrounding vascularity was found in the right fallopian tube. CA was absent. Right adnexa was seen separately from the right ovary. Left ovary was MSF. Her baseline beta HCG level was 2654 international unit per ml. In our institute, we decided to manage it conservatively by medical management. We used multi-dose regimen of methotrexate at the dose of 1 milligram per kg, followed by on day 1, followed by injection leucovorin 0.1 mg per kg. Then serial beta HCG was done. After 48 hours, after first dose, the beta HCG level was found to be 2304. As the fall was less than 15%, second dose of methotrexate plus leucovorin was decided to given, and her follow-up beta HCG level were 1087, which is more than 50% of initial fall. She was monitored weekly beta HCG level, which returned to pre-pregnancy level after 1 week. As methotrexate is directly hepatotoxic and renally excreted, her routine RFT LFT investigations were done, which were within normal limits. From one meta-analysis, the overall success rate of methotrexate therapy was found more in multi-dose regimen as compared to the single-dose regimen. She was successfully treated by medical management. Moreover, conceptions within the first 6 months after methotrexate treatment for this indication are not associated with elevated rates of miscarriage or fetal malformation and growth restriction. Several trials compared multi-dose methotrexate treatment with laparoscopic surgery and found no differences for tubal preservation and primary treatment success rate. Based on these studies, we conclude that women who were hemodynamically stable, who is compliant for this treatment, and who has no fetal cardiac activity, and her initial index beta HCG level is less than 5,000 million international unit per ml, have similar outcome with medical and surgical management. Thank you.
What is the role of the combined beta HCG and transvaginal sonography to diagnose the ectopic pregnancy?
Sir, her baseline beta HCG level, if it is more than 1500 IU per ml, which is a set discriminatory zone for the diagnosis of ectopic. And on TVS, if it is non-diagnostic, we do serum beta HCG levels. If it is more than the discriminatory zone, we can go for a DNC, and on DNC, if chorionic villi are absent, then we confirm it for ectopic pregnancy. If beta HCG levels are less than the discriminatory zone, we repeat serial beta HCG in 48 hours.
Okay, how will you decide the dose of methotrexate in case of single dose methotrexate therapy?
It is based on the body surface area, sir. 50 milligram per meter square.
How will you calculate the body surface area?
No idea, sir.
Okay, madam, please.
Any side effects of methotrexate?
Yes, ma'am. Methotrexate has direct side effects on GI mucosa and respiratory epithelium, as they are proliferating cells. It has gastritis and active. It can cause active pulmonary disease, and bone marrow suppression also can be.
So do you need to repeat the complete blood count also for the patient?
Yes, ma'am. As a follow-up for bone marrow suppression.
Okay. When will you call the patient for follow-up after completing the 1357 regi?
We will call after 1 week for doing serum beta HCG level. If they return to a pre-pregnancy level, then we will follow up monthly. And if it does not return to pre-pregnancy level, then weekly follow-up is done.
Okay, time is over.
Thank you, sir.
Now I invite the Kush Thakur.
Good afternoon, everyone. I am Dr. Kush Thakur, first year resident at the Shardaben Hospital under NHL Municipal Medical College, Ahmedabad. I am going to present the poster on the topic of pregnancy in unicornate uterus without rudimentary horn. Basically, the unicornate uterus results from failure of the development of one of the Mullerian duct. Among all the varieties of the Mullerian duct anomalies, unicornate uterus is less common type. According to the classification, unicornate uterus is usually classified with rudimentary horn or without rudimentary horn. And the incidence of pregnancy in unicornate uterus is around 0.1% of all the pregnancies. I would like to present a case of the unicornate uterus with the pregnancy. 25-year-old Hindu female primary patient from the lower socio-economical class came to our hospital with the 9 months of amenorrhea with the chief complaint of lower abdominal pain and leaking per vaginum since 1 hour. On the 1st of March 2021, she has the active married life of 1 year. Her last menstrual period was on the 1st of June 2020, and her expected date of delivery would be on 8th of March 2021. Her past menstrual history was regular, moderate, and having painless cycle. There are no significant personal or family history. On the general examination, her general condition was good. No pallor, icterus, or edema was present. The patient was vitally stable. On the systemic examination, per abdominally, uterus was full term, breech fixed with FHS regular 140 beats per minute. On the per speculum examination showing leaking per vaginum with clear liquor. Per vaginal examination shows cervix 2 finger loose to 3 centimeter dilated, 20 to 30% effaced, presenting part breached with membrane absent, leak plus, liquor was clear with show plus. So we have decided to manage the patient and taken for the emergency LSTS for the indication of primary breach prom. On the per operative finding, there was scanty clear liquor, LS position, placenta was fundo-posterior in a unicornate uterus with normal left-sided fallopian tube and the ovary without rudimentary horn. So the main thing is diagnosis of the unicornate uterus should be made prior to the delivery with the help of the hysterosalpingography and the MRI. Woman with the unicornate uterus having the impaired pregnancy outcome like the spontaneous abortions, breech presentation, preterm delivery, intrauterine growth restriction, and increased chances of cesarean section. The reproductive performance of a woman with unicornate uterus is associated with live birth rate of 29%, chances of prematurity around 44%, and the ectopic pregnancy around 4%. Women may also present with a first trimester abortion, intrauterine growth restriction, and stillbirth, which may be explained by the poor uterine artery blood flow. The review of literature also showing increased incidence of infertility, endometriosis, and dysmenorrhea associated with the Mullerian duct anomalies. Thank you.
Okay. Now, which class it belongs to as per the international classification?
Unicornate uterus comes under class 2 according to American fertility classification. Basically, they divide the Mullerian duct anomalies into the 7 classes, depending upon the
Now,
clinical scenario.
Which abnormality have the best obstetric outcome and which abnormality have worst obstetric outcome?
Most common type is arcuate type of uterus, and it has the comparatively good pregnancy outcome.
And worst?
Usually, it's in the unicornate uterus.
Okay. How will you differentiate the bicornuate uterus with septate uterus? Which investigation will be helpful?
Hysterosalpingography, sir.
How will you differentiate bicornuate and septate in hysterosalpingography?
Usually on the bicornuate uterus, there will be complete defect in the central canalization. So there would be 2 uterus along with the 2 cervix and the 2 vaginas, while on the septate uterus, there is only a defect into the central canalization. So there is a...
Okay, madam, you ask.
Yes, what can your this unicornate uterus diagnosis was an intraoperative finding?
Yes, ma'am. In my case, it was found intraoperatively.
Operatively. So, is there any importance of now mentioning it in your discharge card? What benefit it can have?
Yes, ma'am. For the further pregnancy, it would be helpful.
And knowing that unicornate uterus is associated with premature delivery, 44% chance, what can you do in the next pregnancy to prevent premature delivery?
Ma'am, we can go for the cervical encerclage, and for the better fetus outcome, we can give the steroid doses.
That you will anyway do. Anything else?
Okay, your time is over.
Thank you.
Now, Deepa madam, you will check for the time limit.
Yes, sir.
Now I invite Dr. Jalpa Bhatt.
Your time will start after you start your screen sharing, Jalpa. So, okay, you can start.
You are not audible, Jalpa.
You're not audible.
Unmute yourself.
Am I audible?
Yes.
Yes, now audible.
Start now.
Good afternoon all. my topic for presentation is unique case of anemia in pregnancy, ultimately diagnosed as neurodegeneration with brain iron accumulation. Neurodegeneration with brain iron accumulation is a rare inherited neurological disorder characterized by abnormal accumulation of iron in brain, which results in degeneration of nervous system and resulting in progressive dystonia, Parkinsonism, spasticity, and optic atrophy. And several genes have been identified for this. A 28-year-old female, Gravida 5, Para 4, living 3, with 7 months of amenorrhea came in our OPD for routine antenatal checkup and found having moderate anemia, and we admit for further evaluation. Patient has further uneventful normal delivery and history of multiple iron sucrose taken at the periphery level. Patient has also complained of progressive difficulty in speaking, generalized slowness, limb and gait ataxia, and intention tremor. Patient has no other significant history. On examination, mild failure was present, and on CNS examination, there is hypotonia, and there is scanning of speech and dysmetria on finger nose test. There is ataxia. On investigation, HB of patient is 8.4, and on PS picture there is mild to moderate hypochromic microcytic RBC with few elliptocyte and target cell. And on HB electrophoresis there is beta thalassemia trait was present, and USG ops of the patient is normal. On MRI brain there is atrophy of cerebrum, cerebellar and midbrain, and there is hypointense signal on T2 images suggestive of the paramagnetic substance deposition. So there are three differential diagnoses: Wilson's disease, neurodegenerative disease, or psychiatric disorder. So in management, we have done HB electrophoresis for the refractory anemia, and patient is having found beta thalassemia trait. And neurophysician reference is done for neurological problem, and as per his advice, MRI findings suggestive of substance deposition disorder. For that, tablets Sindopa started and physiotherapy given. And psychiatric reference and often reference done for the rule out other differential diagnosis. Patient delivered a healthy child at full term, and we done postpartum tubal ligation. Most of the anemia in the pregnancy are of iron deficiency type. So patient was given multiple iron sucrose at the periphery level without any investigation. In spite of the multiple transfusion, hemoglobin not improved. So for refractory refractory anemia, HB electrophoresis was done, and patient found to be having beta thalassemia trait. And this overtreatment with iron sucrose causes aggravation of the neurological symptom. So this patient is diagnosed as NBIA, and for this, several genes are responsible, so genetic study required, but due to non-cooperation of the relatives, it could not be done. And genetic counseling also required, as this disease is autosomal recessive in manner, and treatment of NBI should be palliative and should be specific to the
time is up, Jalpa.
So NBI is very rare. Most of cases of anemia in pregnancy has iron deficiency, but we have to keep in mind.
Your time is up.
Okay.
Jalpa, apart from NBIA, what are the other special type of the anemia where the iron injection may be harmful?
What's that?
In which other type of the anemia where injectable iron may be harmful, like at your case?
Thalassemia, sir.
If we give the iron, it lead to the overload. Which are such other situation?
Thalassemia.
Thalassemia. Okay.
Sickle cell anemia.
Okay. Now, what is the role of peripheral smear in differential diagnosis of anemia?
Differential diagnosis like is iron deficiency anemia, chronic anemia of the chronic anemia, anemia of the chronic disease, thalassemia, hemolytic anemia.
By peripheral smear, how it helpful? Peripheral smear.
If it is a microcytic hypochromic type, yes, then it is iron deficiency anemia. If there is megaloblastic cell, then it may be B12 deficiency anemia. If there are teardrop cell, targeted cell, then it is anemia of hemolytic disease. There is hemolysis is present.
Okay, madam, you ask now.
What do you mean by refractory anemia, and what are the causes for that?
Refractory anemia is, madam, in this in this case, we have given multiple iron sucrose at the periphery level, but her hemoglobin level is not improved by iron therapy. So, this is refractory anemia, and causes are like beta thalassemia, anemia of chronic diseases.
What is the role of bone biopsy in cases of refractory anemia?
To rule out any aplastic anemia, we should done bone marrow biopsy.
Deepa, madam.
Yes, what is the importance of HB electrophoresis as a screening test in first trimester?
By HB electrophoresis, we should done in every cases to rule out any beta thalassemia trait. If husband and wife both are having beta thalassemia trait, then there is possibility of children having beta thalassemia disease.
The time is up.
Thank you, ma'am.
Now I would like to invite Palak Patel. Slide sharing, please.
Good afternoon, everyone. Presenting a rare case report, endometrial osseous metaplasia. I'm Dr. Palak Guladi. Endometrial osseous metaplasia is a benign condition characterized by the presence of mature or immature between the endometrium. First, this case is first described in 1909 by Mayer. Endometrial osseous metaplasia is a rare entity for infertility with estimated incidence is 3 per 10,000 cases. Endometrial osseous metaplasia can be due to endochondral ossification or inflammation related to mesenchymal transformation of previous early pregnancy loss. Histology is a gold standard for diagnosis. We report a 37-year-old lady presenting with a secondary infertility. See her obstetric history. She has a one female child, 7-year back, and DNA done for incomplete abortion at 12 weeks, 4-year back. She had a regular menstrual cycle. Male cause of infertility is clinically ruled out. She didn't have any other gynecological complaint. She didn't have any gynecological examination or treatment since last abortion. For that, we have done her primary investigation for infertility. Her day 3 FSH level is 10.2. Level is 0.4, which is baseline borderline low. Husband's serum analysis is as per WHO criteria is normal. Her USG PVS suggestive of linear echogenic band in the endometrial cavity. Diagnostic histolaparoscopic finding on laparoscopic finding there is no abnormality as such. On histoscopic finding, small endometrial polyp is present, bilateral chemoperturbation is present. So we have done Curie test and material sent for the histopathological examination which is suggestive of osseous metaplasia. This is the picture suggestive of histopathological examination of bone trabecular. Bone act as a contraceptive device and prevent implantation by chronic aseptic endometrial inflammation. Spontaneous or assisted conception reported after the treatment. Pregnancy outcome is not affected by the history of endometrial osseous metaplasia. Most common cited sonographic appearance is one of the single or multiple hyperechoic bands, which appears similarly like IUDs. Histological diagnosis is a gold standard. Dilatation and Curie test was used for the diagnosis and treatment of these cases. As a clinician, we should keep this rare disorder in mind, especially in patients with a history of late miscarriage. Our patient did not conceive. We have done last treatment in March. After that, due to pandemic, we didn't done any follow-up as patient doesn't.
Your time is up.
Doesn't want consent.
Okay. What are the likely difficulty you may have to remove the bone in hysteroscopy? For example, bone is embedded to the uterine wall. Then how will you remove it in hysteroscopy, and what are the likely problems in procedure?
During the histoscopy with grasper we can catch the bone, but is the if the size of bone is large, we cannot catch with the grasper, or there is bone breakage. So the in endometrial cavity, the appeared part of bone can be removed, but embedded in the endometrial cavity or within the myometrium cannot be removed.
What are the complications that may occur after even removal of the bone? Suppose you remove 4 or 5 pieces, what can happen post-operatively?
So the after removal of bone, complication is like Esserman syndrome, because of the removal of bone trabecula. There is formation of adhesions within the endometrial cavity, which can lead to Esserman syndrome.
And how can prevent Esserman syndrome in such case?
After any endometrial treatment via histoscopy, we can kept copper with removal of I think the copper content of the copper which is removed, and plain copper can be placed copper 380.
Madam, you take.
Do you know the entity, like apart from endometrial osseous metaplasia, there is an entity which is known as a non-epithelial osseous metaplasia? In a patient who had undergone a dilatation and evacuation at the later gestational age, that is during early second trimester or late first trimester, when there is accidental perforation of the uterus, this entity can also happen. Okay.
So
Deepa,
time is up, ma'am.
Okay.
Now I invite the Himani Chaudhary. Himani is there. Hello.
Is Himani there?
Himani Chaudhary, case is perforating hydatiform mole from Yuva Medical College.
Himani Chaudhary.
Slide share, please. Himani.
Share your screen.
Please do slide share. You are connected, but you need to do the slide share. Himani is there on board. Please answer. Okay, we will go to the next candidate.
Vrunda Gandhi.
Vrunda Gandhi. Vrunda Gandhi from GMCS.
Good afternoon, sir.
Your time starts now.
Good afternoon, sir, madam. I, Dr. Vrunda Gandhi from Government Medical College, Surat. I presenting a poster of COVID-19 infection in pregnant women, a case report. Introduction. COVID-19 is caused by the RNA virus, severe acute respiratory syndrome, CoV-2, coronavirus 2, which is a part of coronavirus family. Pregnant women are at increased risk of severe disease, specifically need for hospitalization, ICU admission, mechanical ventilation, and already complex management of infection with an emergent pathogen may be further complicated by pregnancy. Case history, a case of antenatal patient, 31-year-old female, third gravida primipara, previous one full-term normal delivery, 30-week pregnancy, presented with us with a complaint of high-grade fever and cough since 4 days and breathlessness since once a day. On the clinical examination, temperature was 101 degrees Celsius, pulse was 130 per minute, and BP was 110/70 millimeter of mercury. RR was respiratory rate was 40 per minute, and SpO2 were 88% on room air. Investigation, we do all blood investigation like hemoglobin, total count, platelet, and all inflammatory marker, which was raised in this patient. D-dimer was 1,550 international urine, and INR, PT-INR growth PTNR was 1.1. And second was USG thorax was done, suggestive of changes of infective pneumonitis in middle and lower zone of both lungs. RT-PCR of COVID-19 is positive for this patient. Treatment, oxygen therapy is mainly the cornerstone of the treatment for this patient. Initially, patient kept on the BiPAP mode of ventilation for 4 days and then shift to the NRBM on the 15 liter per minute for 2 days, and then shifted to simple O2 mask for 4 liter per minute for another 2 days, and then shifted to room air. And corticosteroid therapy was given, injection dexamethasone 8 mg stat followed by 4 mg twice a day given for 5 days. Immunobooster, as immunobooster we give the injection remdesivir initial dose of 200 mg IV slowly once a day followed by 100 mg once a day for 5 days. Thromboprophylaxis therapy, injection LMWH, which is enoxaparin 0.6 mg subcutaneous twice a day for the 6 days, followed by 0.6 mg subcutaneously OD for 2 days. Usually we continue the LMWH prophylaxis until the patient come on room air or mobilization of the patient can occur. Antibiotic therapy, injection ceftriaxone 1 gram IV 12 hourly for 7 days given to this patient. Patient discharged after the 9 days with continuation of pregnancy. Discussion. From above case study, woman infected with COVID-19 may be present with the mild flu-like symptom form of the disease. For the timely diagnosis and treatment with oxygen therapy, thromboprophylaxis therapy, corticosteroid therapy, and immunobooster required, we prevent the transmission of disease to another person by social distancing, face mask, and do ANC visits at least at 20, 28, and 36 weeks of gestation. Conclusion. Emerging data suggests that pregnant women experience more severe disease following the infection with coronavirus compared to the non-pregnant counterpart. Although some studies show equivalent rate of severe and critical infection to that observed in the general population.
Your time is up.
Okay. Now, Dr. Vrunda.
Yes, sir.
What are the common drugs we should avoid during pregnancy and COVID, which we are routinely using in non-pregnant women and COVID? We are not able to listen you, Vrunda.
No, sir, I have to listen.
Which drug we have to avoid in COVID and pregnancy?
Ivermectin and doxycycline.
Yes, of course, doxycycline. Now, tell me the importance of doing D-dimer in pregnancy and COVID. Is there any cutoff limit to start the anticoagulant?
Yes, sir. If that is greater than 500 international unit, we start the thromboprophylaxis.
My question is, suppose your patient is having mild disease only and D-dimer is 700, would you like to start the anticoagulant?
No, sir. We could not start the LMWS therapy in vitally stable patient or asymptomatic patient. We started the LMWS therapy in those patients which are bedridden or chronic require chronic O2 support, and and the symptomatic patients. We started the LMWS therapy in that patients.
Suppose your patient on anticoagulant and develop the thrombocytopenia, what will
Yes,
you
sir.
do?
We, sir,
Because
we,
thrombocytopenia is also
yes,
common in COVID.
most common complication of LM.
Yes.
Sir, LMWs does not causes that much low level of thrombocytopenia that causes unfraction heparin. So we continue that LMWS therapy in lowest dose.
Okay, madam, take.
Will you do the follow-up, obstetric follow-ups of such kind of patient?
Yes, yes, madam. We usually take a follow-up in at least 4 antenatal visit if required. Does not require the 13 antenatal follow-up. Does not require that. At least four follow-up at 12, 20, 28, and 36 weeks. If patient had a start labor pains or any complaint like a decreased fetal movement or any respiratory symptom, then she can come for follow-up. For specifically for the antenatal routine checkup, that is not require any follow-up in this COVID area.
What percentage of obstetric patients will go for severe COVID infection with lung involvement?
I have no idea, ma'am.
What are the physiological changes in the respiratory system which predispose to severe COVID infection in pregnancy?
Vital capacity was decreased, and the diaphragm, due to the gravitational diaphragm goes upward, so functional lung volume was decreased. So in the COVID infection, that will cause impairment of respiration.
The time is up.
Respiratory rate was also increased. Thank you, ma'am.
27. Now I would like to invite Dr. Kuldeep.
Hello, my name is Dr. Kuldeep Rathod, second year resident doctor in GMC Surat. I am going to present a poster on hydatid cyst of ovary, a case report.
Share your screen.
Yes. Do the slide, sir. Okay. Start. Your time starts now.
Okay, poster on a case report of hydatid cyst of ovary. Hydatid disease remains a significant health problem in India. Humans are accidental intermediate host for the parasite Echinococcus granulosus. Hydatid disease occur most frequently in liver, followed by lungs, muscles, bones, and uncommonly in kidney, brain, and spleen. However, its incidence in ovary is very rare. It ranges from 0.2 to 2.25%. Hence, here we present a case report of incidentally and intraoperatively diagnosed hydatid cyst of ovary. A 70-year-old lady presented to New Civil Hospital OPD with complaint of urinary retention and lower abdominal pain for 3 months. She had previously undergone a laparotomy for some pelvic mass 30 years back. On her clinical examination, a mass of approximately 20 to 14 uterine weak size with tenderness on deep palpation, restricted mobility, variegated consistency, and lower margin not reach out. Her CT report was suggestive of 11 by 10 by 8 centimeter cube multiloculated cystic lesion with multiple septations with few foci of calcification noted in pelvic cavity with compression of right lower ureter resulting in hydroureteronephrosis with overall finding suggestive of neoplastic etiology of ovary, that is probably mucinous cyst adenoma. Ovarian tumor markers were done and found to be within normal limits. In view of ovarian neoplasm, staging laparotomy was done and intraoperatively on right side, there was 15 by 15 centimeters square ovarian mass adherent to bladder anteriorly, and during dissection, there was inadvertent rupture of the cyst which led to discovery of multiple daughter cysts within the rupture mother cyst suggestive of hydatid cyst of ovary. Injection adrenaline 0.5 ml IM state and injection dexamethasone was given to prevent anaphylactic shock. Excision of ovarian mass along with the cyst was done by sharp dissection and opposite ovary was normal. 3% normal saline wash was given and her histopathological report was suggestive of hydatid cyst of ovary. Post-operative period was uneventful and patient was discharged successfully on tablet albendazole 400 mg twice a daily for 4 weeks. Discussion. Primary hydatid cyst of ovary is extremely rare. Most of the cases occur due to rupture of hepatic cyst. However, in current case, hydatid cyst was not found in liver. Ovarian hydatid cyst usually simulate polycystic disease or malignancy. In present case scenario, it simulated malignancy in view for which laparotomy was undertaken. Ovarian hydatid cyst usually present with non-specific symptoms of abdominal pain, infertility, or pressure symptoms due to mass effect on pelvic organ. Conclusion. USG and CT finding pre-operatively is important and required so as to prevent its iatrogenic rupture. Treatment of choice remains to be radical cystectomy along with anti-helminthic therapy to prevent recurrence. Hydatid cyst can occur at any site of human body and
The time is up.
Okay.
Okay. Now, when there is a complex ovarian mass or adnexal mass, what are the tumor markers you will do in reproductive age? Suppose your patient is in reproductive age with complex cyst. What are the common tumor markers we have to do?
Sir, we can do CA125, CEA, LDH, alpha fetoprotein.
What do you mean by risk malignancy index?
Sorry, sir, I don't.
Okay, madam, please.
So your patient is 70 years old, status postmenopausal. And
Yes,
if you find out bilateral ovarian mass, apart from tumor marker, which investigation will you carry out pre-operatively?
Ma'am, pre-operatively, I would like to do normal CBC and RFT, LFT of this patient and USG and X-ray and X-ray and USG of this patient and CT scan and tumor marker like CA125.
To find out tumor metastasis, which other investigation will you carry out?
Tumor metastasis.
નથી અવાજ નથી મારામાં બી નથી આવતો.
Deepa madam.
Yeah, given that this is a rare entity.
Apart from CT, we can do USG or X-ray in case of any match.
Is there any role of X-ray chest, especially in your case?
Yes, sir. Maybe there may be if there is primary hydatid cyst of the hydatid cyst is more commonly occur in liver and second most common site is lung. So, sir, it may be in my case if there is primary, there can be a primary hydatid cyst in lungs that can be detected by X-ray.
Okay.
Thank you.
Now I would like to invite the Ria Bodawala.
दीपा चश्मा बसमा चढ़ाई है
Ashwin bhai, Shruti Taylor.
Sorry, one is left. Number 27, Shruti Taylor. Shruti Taylor.
पेपर प्रेजेंटेशन लीव करवानी कसी करवा
तो डायरेक्ट बनत के देन मोबाइल है लैपटॉप मोबाइल में जो है
Good evening, everyone. I am Shruti Taylor from Government Medical College, Surat. I will be presenting a case report on successful management of pregnancy complicated with acute kidney injury with peripartum cardiomyopathy. Now, severe acute kidney injury in pregnancy is usually less frequent, but earlier diagnosis and proper management can markedly reduce the morbidity and mortality associated with it. Incidence of AKI requiring dialysis, which complicate pregnancy, is approximately 1 case per 10,000 births. And in case of peripartum cardiomyopathy, it is potentially a life-threatening complication with overall incidence of 1 to 4 per 4,000 live births. In this case report, I will be describing a successful management of pregnancy which was complicated both with acute kidney injury and peripartum cardiomyopathy. A 26-year-old lady, 4th gravida primipara, previous is a 37-week pregnancy, presented to labor room with complaints of abdominal pain since 3 hours. Her emergency cesarean section was undertaken in view of previous seizure with short interdelivery interval. Intraoperative period was uneventful. On 0th post-op day, patient developed tachycardia with tachypnea. So patient was immediately shifted to OB-ICU and transfused 1 unit PCV. On first post-op day, active bleeding was noted from cesarean section stitch site. So she was taken to GOT for drainage of subacute hematoma where stitch site bleeding was controlled and PCV and FFP transfusion was done. On second post-op day, her urine output was nil in 10 hours with input of 2000 cc and her serum creatinine was 4.1. With third space collection, raised inflammatory markers and COVID-19 RT-PCR status negative. After consultation with physician and nephrologist, her hemodialysis was started and patient was on regular hemodialysis twice weekly from 2nd to 9th post-op day, which was uneventful. On 9th post-op day, patient developed complaints of breathlessness with development of bilateral crepitations on RS examination, suggestive of pulmonary edema, which was confirmed by HRCT. She was kept on BiPAP mode of ventilation and her 2D echo was done, which showed global left ventricular hypokinesia with peripartum cardiomyopathy, ejection fraction of 25 to 30%. Cardiologist opinion was taken and accordingly Lasix infusion was started and patient was given injection Lasix 6 hourly followed by tablet bisoprolol 2.5 mg/d. Patient was kept alternatively on BiPAP and NRBM support for 5 to 6 days with oxygen, where oxygen support was gradually tapered over a period of 5 to 6 days. Patient stayed in OB-ICU for approximately 1 month where she underwent 17 cycles of hemodialysis, infusion of 3 human albumin, transfusion of 4 PCV, 6 platelet concentrate, and 6 FFP with average daily urine output of 1.2 to 1.5 liter per day. Now, postpartum acute kidney injury is one of a challenging problem in developing countries. Most commonly, AKI is associated with preeclampsia, sepsis, HELP, abruptio placenta. However, in the current case scenario, it was not associated with preeclampsia or any other previous nephrological insult. Also, AKI was further complicated by development of peripartum cardiomyopathy without any history of hypertension. So, in present case, with proper management, early diagnosis, close observation for oxygen saturation, prompt treatment. Yes.
Tell me the common obstetric condition which may lead to the acute renal failure in our day-to-day practice.
In first trimester, most commonly in developing countries, because of induced abortion, there is increased incidence of sepsis, and that can lead to AKI in first trimester. And in second and third trimester, most common causes are preeclampsia, eclampsia, HELP syndrome, or abruptio placenta, which could lead to development of AKI.
Any non-obstetric cause for acute kidney injury in present era?
Non-obstetric cause could be an hypovolemia or in right now cases of COVID-19 also most certain times patient are landing up with AKI in present situation.
Deepa madam.
How, in this case, how did you come to the diagnosis of acute kidney injury?
We monitored the urine output of patient which filled into the which was approximately nil in 10 hours, and it was less than 400 ml in 24 hours. Patient was oliguric. Also, her serum creatinine level was gradually deteriorating and increasing tighter. And so, based on that, we came to the diagnosis that patient had been landed up in acute kidney injury. Also, patient also had development of third space collection with pleural effusion. So we had made the diagnosis of acute kidney injury and started early hemodialysis of the patient.
Thank you. The time is up.
Thank you.
Now I invite Dr. Riya Bodawala.
Good evening, everyone. I would like to present a poster on a rare case of placenta percreta with bladder invasion successfully managed by multidisciplinary surgical management, which includes obstetric hysterectomy and bladder wall reconstruction. Major obstetric hemorrhage is the leading cause of maternal morbidity and mortality. In rare cases, life-threatening hemorrhage in pregnant women may result from abnormally implanted invasive or adhered placenta, collectively termed as Eccrite syndrome. Placenta percreta, the rarest and the most severe variant of placenta eccrita syndrome, occurs when villi penetrate the full thickness of myometrium and may invade neighboring organs such as bladder or rectum. Bladder invasion by the placenta is potentially life-threatening obstetric complication, although a rare one. A preoperative diagnosis can be made by MRI, but not the confirmatory one. The firm diagnosis can be established intraoperatively when attempts are made to separate adherent placenta from the bladder, which causes massive hemorrhage that is often quite challenging to control. Use of alternative surgical approach may decrease morbidity and blood loss. My case is a 25-year-old lady presented at 37 weeks of gestation with complaint of abdominal pain. Her antenatal USG was suggestive of complete placenta previa with possibility of placenta eccrita or increta. MRI, which was done at 36 weeks of gestation, was suggestive of complete placenta previa with placenta increta with no evidence of placenta percreta or urinary bladder infiltration. Patient's obstetric history was significant for one prior pregnancy delivered at term by cesarean and complicated by placenta previa. Her current pregnancy was without complication. Sorry.
You can continue.
Her current pregnancy was without complication up to the day of presentation. In view of full-term pregnancy with complete placenta previa with possibility of increta, decision was taken for emergency cesarean section. Patient and her relatives were explained about the possibility of hysterectomy preoperatively. Intraoperatively dilated veins were seen over utrovesical fold of peritoneum. Therefore, the delivery of an alive and healthy female child of 2.8 kg was conducted by transverse incision, which was kept somewhat higher side on the lower segment. Then active bleeding starting from the placental bed, which was allowed to separate spontaneously. On reassessing the depth and location of placenta, focal placenta percreta was found on anterior side, involving bladder wall, reaching up to mucosa. Immediately, emergency hysterectomy was proceeded. Surgeons were consulted intraoperatively. Complete placental tissue was removed by fine dissection and anterior bladder wall excision. Bladder wall was reconstructed in a single layer with continuous absorbable suture, and 16 French Follis catheter was kept as suprapubic catheter. The loss of approx 3.5 liter blood volume was replaced by transfusion of 3 units of PEG cell volume and 4 units of fresh frozen plasma intraoperatively. Post-operatively, the patient was shifted to ICU and was kept on invasive mechanical ventilation and on inotropic support for 24 hours. Urine output was adequate post-operatively. On 15th post-op day, urethral catheter was removed. Suprapubic catheter was removed on 18th post-op day. Patient did not. experience any urinary difficulty or leak after catheter removal. Healthy mother and baby were discharged on 20th post-op day.
Time is up.
Okay, ma'am.
Now, what are the ultrasonography findings by which you can diagnose the placenta accreta syndrome antenatally?
Sir, in ultrasonogram, we have to look for the retroplacental vessel location and the thickness of myometrium. In placenta accreta syndrome, there is a thinning of myometrium with presence of vessels from the placental side.
If any sophisticated, any special radiological intervention will be helpful to reduce the blood loss in such case, placenta percreta?
We can do the embolization of in uterine artery.
Madam,
which
please.
can help to control the blood loss.
Which are other intervention intervention which can help to reduce or minimize the blood loss during surgery of PAS?
The most important step that can control the bleeding is attempt not to separate the placenta from its bed. We should allow the placenta to separate spontaneously. The blood loss is mostly the twice the in the blood loss is double if we try to separate the placenta, or we try to do manual removal of placenta.
Okay, so you will perform the hysterectomy with placenta in situ is what you mean to say,
Yes,
right?
ma'am. The hysterectomy should be done with placenta
any
in
role of
situ.
internal iliac ligation prior to proceeding for hysterectomy?
Sorry, yes, ma'am. There is a study that suggests that internal iliac ligation will help to reduce the blood loss, but it is not necessary.
Okay, the time is up.
Thank you, ma'am.
Thank you. Now, Dr. Himani is there. Number 24, Dr. Himani Chaudhary from CU Shah Medical College.
कोई आया तो आओ कोई आओ ना हिमानी नहीं आ रही है
Okay, so here we end the first half of the poster session. And now I request the Dr. Yamini Trivedi Madam to continue the poster presentation session. Yamini Madam.
Ruti Ben is there, I think.
Yes, sir. Good evening, everybody.
Good evening, madam.
Good evening, ma'am.
So Ashwin bhai, we can take over to them this second team.
Yes, I will now just I will do the phone to the Yamini Madam and tell her to take over. We will make the just break of few minutes.
Exact 5 वागे आपने
કંટ્રોલ રૂમમાં નહીં ના એક દેશમાં ડોક્ટર સાથે તમારે વાતચીત કરવી હોય ને તો વોટમાં ફોન નંબર છે આપણે તમારે કયા વોટમાં છે 14B હા તો 14B માં આપણે નંબર આપ્યો છે ફોન પર રિંગ કરો કે અહીંયા ડોક્ટર વાત કરશે કંટ્રોલ રૂમમાં કેના માટે ડોક્ટર અહીંયા ના હોય કંટ્રોલ રૂમમાં ડોક્ટર જે કાંઈ રેસિડેન્સની છે વોર્ડમાં જ હોય Smruti madam is there. Smruti madam. Hello.
Yes, yes.
Okay, madam. Now, Preeti Punathar, Dr. Preeti.
Present.
Okay. Yamini madam. Dr. Yamini Trivedi. Okay. Now, Smriti madam, you can start with you two people. I am just contacting with Yamini madam.
Sure, we can start.
બરાબર ટાઈમ લિમિટ એન્ડ એવરીથિંગ તમે ડિવાઇડ કરીને સ્ટાર્ટ કરી દો બરાબર યામિની મેડમ જોઈન થઈ જશે
Nice presentation, answer all questions also.
Okay, so first case, who's the student? Are we ready? Mobile laptop yes, madam.
We have to keep time. One of us will have to keep the
Yes,
time.
Smriti ma'am. Madam, just my same posters.
Who will keep initially? I'll keep the time.
Sure, ma'am, please.
Madam, I got
And
So that is 3 minutes for presentation and 2 minutes for question answer.
Okay, ma'am, as you say.
Right? એટલે ગઈકાલે આપણને કીધેલું
Yes,
એ
ma'am.
પ્રમાણે.
Sure, ma'am. So time તમે રાખો છો, correct, ma'am. You lead that.
Yeah.
Sure, ma'am. Okay. So start करिए, ma'am.
નામ તો ઇન્વર્ટ
ઓકે સ્ટાર્ટ યામિની મેડમ ઇઝ ઓન ધ વે તમે સ્ટાર્ટ કરી દો વચ્ચે જોઈન્ટ થઈ જશે
Sure. You can start. So if I have to introduce myself, I am Dr. Preeti Punathar, working as additional professor, GGH, Jamnagar. And along with us, we have Smruti ma'am. Ma'am, if you can introduce yourself.
I'm Dr. Shruti Vaishnav, professor at Pramukh Swami Medical College, Karamsar, and interested in high-risk pregnancy and critical care pregnancy.
Okay, thank you, ma'am. So, and we are waiting Yamini ma'am. Until then, we can start. Who's the student now? The first one, the first contestant?
નિધિ રામાણી
Yes, Nidhi, are you there?
Hello.
Yes, ma'am.
નિધિ
Yes, okay.
Yes, ma'am.
Yes, so we
Start.
are able to see you. Can we start?
Yes, ma'am.
and Preeti once they start the slide sharing then you count the time
Sure. Screen sharing start થઈ ગઈ છે મેડમ હવે આપણે ટાઈમ સ્ટાર્ટ કરીએ
Okay, okay.
ઓકે બેટા સ્ટાર્ટ
Okay.
Good evening, respected judges, chairperson, and all my dear colleague. I, Dr. Nidhi Ramani, third year resident of Obs and Gynec Department, SMIMER, would like to present a poster on laparoscopic ovarian transposition. Ovarian transposition is a unique surgical maneuver used to protect ovarian function before administration of gonadocidal doses of radiation therapy. This procedure aims to move the ovary out of the radiation field by creating a retroperitoneal tunnel and suturing it to the lateral abdominal wall. Thus, it is protected from direct irradiation and irreversible damage in cases of gynecologic and non-gynecological cancers undergoing gonadotoxic pelvic radiation. A 17-year-old unmarried girl presented with complaint of abdominal pain and bleeding PR in surgical OPD. On clinical examination, she had a rectal mass, after which a colonoscopy guided biopsy was taken, which was suggestive of Burkitt's lymphoma. Before starting of radiotherapy, she was referred to Obs and Gynec department for preservation of ovarian function, for which a laparoscopic ovarian transposition with formation of peritoneal tunnel was done on both sides. Post-operative period was uneventful. He was posted for pelvic radiation on 5th post-op.
Wait, I'm not able to hear you.
Make the mute those who are not online.
Hello, am I audible?
Yes, now
Yes,
start.
Beta, now you are. So we lost you in between. Can you restart?
Okay, ma'am.
Oh, transposition and cutters. After that?
From beginning?
No, not from the beginning. Like you had transported and deposited. वहाँ तक सुना आपका case. That's 2 minutes only. I think we have not heard.
Okay, ma'am.
So the case you were describing, what you did, that we, I think starting 1-2 minute का सुना है.
Okay. A 17-year-old unmarried girl presented with a complaint of abdominal pain and bleeding PR in surgical OPD. On clinical examination, she had a rectal mass, after which a colonoscopy guided biopsy was taken, which was suggestive of Burkitt's lymphoma. Before starting of radiotherapy, she was referred to Obs and Gynec department for preservation of ovarian function, for which laparoscopic ovarian transposition with formation of peritoneal tunnel was done on both sides. Post-operative period was uneventful. She was posted for pelvic radiation on 5th post-op day. At 1-year follow-up from completion of chemoradiation treatment, normal menstrual cycle at regular monthly intervals were reported, suggestive of normal ovarian function. There are a number of young patients having various cancers in reproductive age group, so preservation of ovarian function and fertility must be considered. Various methods of ovarian preservation are laparoscopic ovarian transposition, freezing of ovarian tissue or oocyte preservation through treatment with GnRH agonist or antagonist during chemotherapy, newer radiation therapy techniques including intensified mediated radiation therapy. Among all these, creating a retroperitoneal tunnel for passing the ovary through it is a feasible and effective technique to prevent ovarian vessels from taking a sharp turn into the pelvic cavity. The metal clips around the ovaries help to verify that they would be out of the radiation portals on the radiation verification films. This technique is reported to have a success rate of 88.6% for preservation of ovarian function as documented by the measuring of gonadotropins level after cancer treatment. To concluding this, laparoscopic ovarian transposition is considered to be a safe, effective and minimal invasive surgical option to prevent from premature ovarian failure and to optimize preservation of fertility. The laparoscopic approach enables the patient to return normal function and start radiation within the days of procedure. Thank you.
Your time is over. West.
Thank you.
What is the lethal dose for ovary? Radiation dose.
The lethal dose 50, that is the dose required to eliminate 50% oocyte is 2 gray.
Okay, so Nidhi, how many of such cases have you seen?
Ma'am, I have seen only this one case.
This is the one and the only. Okay, so fine. Yes. And how many references? Before doing this, what was the homework that you did?
Ma'am, the patient may require post-operative chemotherapy and radiation therapy. Burkitt's lymphoma.
Okay, so what were the chances? I mean, what were your options, other options?
For which, ma'am?
For your case.
Ma'am, in future for the patient?
No, for this only. I'm not asking about future, for the present one. What you did is one approach, correct? So what are the other approach available to you?
Okay, ma'am. In future, ma'am, IVF pregnancy. Then, ma'am, she may conceive normally, which is rare but possible.
Okay, time is over.
Okay, thank you.
Okay, thank you, Nidhi.
Thank you, ma'am.
Next, please.
Yes, the next one.
Neha Prajapati.
Yes, Neha.
Am I visible, ma'am?
Yes, you are visible and your screen is also visible. You can go ahead.
Good evening, everyone. I'm Neha Prajapati, second year resident of OBGY from Government Medical College, Surat. I'm going to discuss a case report of successful management of traumatic postpartum hemorrhage, a maternal neonate. The postpartum hemorrhage is defined as a blood loss from the genital tract exceeding 500 ml of vaginal delivery and 1000 ml in cesarean section, resulting in changes in the hemodynamic parameters. However, significant blood loss can be well tolerated by most young healthy females, and an uncomplicated delivery often results in blood loss for more than 500 ml without any compromise of mother's condition. Primary postpartum hemorrhage occurs within 24 hours of delivery, and secondary postpartum hemorrhage occurs 24 hours to 6 weeks after delivery. Most cases of postpartum hemorrhage are early postpartum hemorrhage, with many women delivering outside of hospitals and early postpartum hospital discharge being a growing trend. Postpartum hemorrhage that presents to the emergency department may be either primary or secondary. These patients are usually critically ill and warrant early surgical or medical intervention. Postpartum hemorrhage has an incidence of 1% in hospital deliveries of traumatic PH accounts for 20%. The case is the 30-year-old lady referred from private hospital on first postnatal day of third para full-term vaginal outside, which is non-institutional delivery with traumatic PPH, presented to emergency with complaint of bleeding per vaginum on the date of 3rd February 2021. On admission, she was altered conscious and pulse and BP were not recordable, and active bleeding was present coming from cervix and vagina on per speculum and per vaginal examination. Our investigations were hemoglobin 8.8 gram percentage, total counts were 31,600 and platelets were 1,23,000. There was 3 by 2 centimeter square size cervical tear present, which was repaired under general anesthesia, and the bleeding was not controlled, so decision of exploratory laparotomy was taken. On laparotomy, there was 4 by 5 centimeter posterior uterine wall hematoma and 5 by 5 centimeter square right broad ligament hematoma were present. So decision of total obstetric hysterectomy and bilateral internal iliac artery ligation was taken. Post-operatively, patient was kept in OBS ICU and on pulse and BP were not recordable for 48 hours. Patient was kept intubated and on inotropic support for 72 hours. Patient recovered thereafter, and on her 12th post-op day, she developed burst abdomen and lavage laparotomy was taken for same. Patient has been transfused 9 units of RCC, 10 units FFP, and 3 units of platelets, 3 human albumin. Thereafter, her post-operative period was uneventful. Patient was discharged on good condition on 17th of March 2021. Discussion: the obstetric hemorrhages were world's leading cause of maternal death, 24% or an estimated 1,27,000 deaths. The postpartum hemorrhage, if traumatic, is easy to tackle once the source of bleeding is identified, especially in case of
Okay, start.
Especially in case of lower genital tract trauma, but the situation worsens when systemic factors complicate, like shock with severe anemia.
In the setting of dilutional coagulopathy, it became very essential to rapidly resuscitate and control the bleeders. It is advocated that in presence of coagulopathy, a package of transfusion units should be given, that is 3 units PCB, 5 units FFP, and 5 units platelets. In this patient, since platelets were not that depleted, only hematocrit improvement and replenishment of coagulation factors was done. Each unit of FFP gives 5% of replenishment of coagulation factors. In case where cryoprecipitates are available, clinical improvement is seen to be faster with infusion of cryoprecipitate along with FFP, since the replenishment of coagulation factor is faster. In the absence of both FFP and cryoprecipitate, a replacement by PCV, whole blood, and crystalloids is essentially done till the above can be managed for. A paravaginal hematoma, if gives away, should be evacuated and bleeder identified and ligated. If bleeding per vaginum is not controlled with routine medical and surgical methods and patient is deteriorating, it is wise to take decision of obstetric hysterectomy earlier. Conclusion
Your
is
time is over.
okay, ma'am.
What are the likely long-term complications in this patient? Hello?
Yes, yes, ma'am.
Yes, Neha.
Yes.
Long-term complications. Can you think of any? Okay, so the next you
because of
say that her
postpartum
pulse
hemorrhage-
and blood pressure. Yes, obviously your case, beta. Come on.
Because of large amount of blood volume loss, patient is remain in anemia. She may develop anemia.
Okay,
And
so
any
coming to the
surgical
next.
strip site complications.
So what complications? We are talking about long-term. Ma'am is not asking about the immediate ones, correct? Ma'am's question was long-term complications. Okay, fine. The next question, you said that her pulse and BP were not recordable for the first 48 hours. So what exactly her pulse was?
Sir, on admission, ma'am, her pulse was 160 beats per minute and blood pressure was not
Correct.
recordable.
Right. So after
Only carotid
operation,
were
after your
present.
OT. Yeah, so I'm asking, what was the rate?
After the operation, her rate was 180 pulse.
Okay,
And
so pulse
they were
was
very
180.
feeble, so they were not recordable.
Correct. Okay. And your count was also high.
Yes, ma'am.
So what are the chances? What are the DDs? I mean, how will you manage? How will you confirm whether your patient is? I mean, earlier also the count was high, correct?
Yes.
So was the infective component was present initially along with this or not? How will you differentiate between the two? That the infection is not there, it is sheer blood loss only, or the infection component is also there. How will you
Infection
differentiate in such a
component,
scenario?
infectious component was always also there.
So how would you differentiate? Usually the counts थोड़े बहुत तो ज़्यादा आते हैं ना. What is the differentiating things?
True note is defined
Inflammatory
as
process is also
emptying
there
of
in
a
the body,
segment of
correct?
umbilical cord, usually without obstructing.
Patient was having complaint of fever and
Can you
signs
name
and
any
symptoms of
investigation
sepsis.
which helps you to differentiate? Blood investigation, do you know any which can help you to differentiate between the two?
Your time is over.
The neutrophil count, ma'am, differential neutrophil counts.
Okay, thank you, Neha. So the next student. You may start.
May I start, ma'am?
Yes, please.
My name is Sakshi Modi. I'm a second year resident in New Civil Hospital, Surat, in departments of obstetrics and gynecology. My topic is successful management of cesarean scar pregnancy with multiple dose systemic methotrexate therapy. Our case was a 25-year-old lady, third gravida, previous to LSCS, with history of 2 months amenorrhea and bleeding PV since 15 days. Her USG was suggestive of a 48 by 38 mm square sized, well-defined echogenic lesion with peripheral vascularity in the anterior myometrial wall, which was in the lower uterine segment, with possibility of scar ectopic pregnancy. And her serum beta HCG was 50,522 milli-international units per ml, and patient was not willing for surgical management. After baseline CBC LFT-RFT reports, she was given a multi-dose regimen of methotrexate. Her serum beta HCG on 11th day was then 6,558 milli-international units per ml, and which was a decline of more than 15%. And this was followed by subsequent measurements until the levels fell to less than 5 milli-international units per ml after 1 month. So a scar ectopic is an implantation of an early gestation in the hysterotomy scar incision with a previous cesarean birth. The incidence is 1 in 2,000 pregnancies, and it's increasing alongside the cesarean delivery rate. Most of them result in severe complications like uterine rupture, life-threatening hemorrhage, cesarean hysterectomy. Reliable data regarding chances of live birth are not yet available. Untreated cases have severe outcomes. Pregnancy termination should be considered taking into account the maternal morbidity and possible mortality. A suspicion of a scar ectopic is when the patient has a previous cesarean section with a low and anterior gestational sac that is less than 5 centimeter from external cervical os. On transvaginal sonography, the uterine cavity will be empty. The gestational sac fills the scar niche. Thin or absent myometrial layer will be present between the G-sac and the bladder. There's a rich vascular pattern which suggests trophoblast on color Doppler. An embryo with or without cardiac activity or yolk sac may be present, and there's a discontinuity on the anterior uterine wall. UPT is positive. In this case, as the patient refused surgical management, medical management was chosen. For medical management, in conclusion, the systemic therapy is non-surgical, less costly, less invasive, effective modality with fertility preservation, and those diagnosed early and treated have favorable prognosis. For choosing medical management, the criteria are gestational age of less than 8 weeks, hemodynamically stable patient, absent fetal cardiac activity, more than 2 mm thickness between the myometrium and the bladder. Successful rates are similar with systemic or local application, but the advantage with the systemic route is that it is less invasive. Methotrexate is used in intermediate dose, so possibility of toxicity development is less, but folinic acid needs to be supplemented. There should be no contraindication to methotrexate, and a regular follow-up and availability of emergency medical facilities should be present in case of emergency. The options given to the patient were local administration of methotrexate, USG-guided local administration of methotrexate, uterine artery embolism, and surgical management, which included a DNC, hysteroscopic removal, laparotomy, colpotomy, transvaginal approach, laparoscopy, and hysterectomy.
How this patient responded?
Ma'am, after 1 month, the beta HCG level was less than 5 milli-international units per ml, and the patient had normal menstruation after that.
Will you do follow-up immediately after discharge?
Ma'am, after 1 week, we kept patient on weekly follow-ups for beta HCG and any complaints. We had explained her to contact the facilities immediately if there is any abdominal pain or vaginal bleeding.
And
Okay,
what was
suppose-
the USG finding?
Yeah.
Sorry.
USG finding after 1 month?
Ma'am, after 1 month, the G-sac was not visible at the scar site, and there was no discontinuity in the anterior uterine wall. The color Doppler changes were not present.
So suppose if patient presents with complications, as you say that bleeding and all can be there, what shall you do?
Ma'am, if the patient presents with complication, based on the hemodynamic stability of the patient, will again
Yes, she is
counsel.
not stable. Okay, she is in a shock. Then what shall you do?
Ma'am, first of all, we'll resuscitate, and at the same time, we'll counsel the patient and the relatives for immediate laparotomy.
What shall you do
Surgical
in
management.
laparotomy?
Ma'am, we can do a wedge resection or we can do aspiration of the.
Fine. So in your consent part, you mentioned that as patient has refused surgical treatment, you have opted for a medical
Yes, ma'am.
intervention. So according to you, which one is the best?
Ma'am, based on the size of the GSAC and
So
the
your case.
yeah, in our case, based as the GSAC size was 4 into 3 centimeters, beta HCG level were high. Patient was hemodynamically stable. We could have gone for a surgical management. That would have been a better approach for the patient. But because the patient was not willing, we went for medical management.
Okay, can you justify why surgical is good?
Ma'am, with surgical management, first of all, there can be a complete resolution. We don't need follow-up. The patient we need not come and follow up, and she can, maybe it might happen that the patient might not have facilities for immediate approach to the facilities in case of emergency. Then, for as a in view of complete resorption and better completeness of the procedure, surgical management would be better. If we had gone for a wedge resection or an aspiration, maybe her fertility would also have been preserved, just like medical management.
Time is over.
Thank you, ma'am.
Thank you.
Hello, Preeti Ben. Hello.
Yes. Hello, ma'am.
Sorry.
So we have Yamini, ma'am.
Yeah.
Okay. Yes, one more judge with us. Kindly, ma'am, introduce yourself and then we can start with the next
Yeah. I'm Dr. Yamini. Good afternoon, everybody. I'm Dr. Yamini Trivedi. I am head of the department at LG General Hospital, AMC Met Medical College. Okay, one of your judges. Okay.
Yes, welcome, ma'am. And the next one. So, madam, till now we have finished 3, Nidhi, Neha, and Sakshi.
Yeah, actually, I talked with Ashwin, but after 5, I can leave my hospital, so I took this much time.
No issues, ma'am. No issues. Now you take the lead, ma'am. So, okay, Manan.
No issues. Just continue, okay? Continue,
Yes,
Preeti.
Manan, we can see your slide. Can you go ahead?
Okay. Thank you, madam. Good evening, everyone. Myself, Dr. Manan Joshi. I am second year resident at New Civil Hospital, Surat. I am going to present topic successful surgical management of rupture corneal ectopic pregnancy. Corneal ectopic or interstitial pregnancy is a rare form of ectopic pregnancy that implants and develops in the intrauterine portion of fallopian tube and invades to the intrauterine wall. Corneal pregnancy often rupture later than the other tubal pregnancy because the myometrium is more distensible. The incidence of corneal pregnancy is difficult to calculate in general population. The incidence of ectopic pregnancy is about 2%.
Continue. Go ahead.
The incidence of corneal pregnancy is difficult to calculate. In general population, the incidence of ectopic pregnancy is about 2%. Interstitial pregnancy account for 2 to 4% of ectopic pregnancy, and that 20% of cases are advanced up to beyond 12 weeks of gestation in rupture. Here, we report a case which was admitted in New Civil Hospital, Surat, where corneal pregnancy was diagnosed, and when exploratory laparotomy done for the hemoperitoneum, in patient, corneal pregnancy ruptured, and hello. My case was a 26-year-old female, second grade, referred with complaint of abdominal pain and spotting per vaginum since 1 day, and with history of 3 months of amenorrhea. Her sonography was pelvis suggestive of single uterine fetus with mean maturity of 14 weeks without evidence of cardiac activity, with subchorionic hematoma of size 6 to 7 centimeters. On this USG finding, patient was induced by tablet misoprostol in previous facility. After 3 to 4 hours of induction, patient condition deteriorated and was shifted to New Civil Hospital, Surat. On admission, patient was hemodynamically unstable with pulse 130 per minute, BP 90 by 60 millimeter of mercury. After CBC report, which was HB was 8 gram, patient was taken for exploratory laparotomy. During laparotomy, 1000 gram of blood clot along with the fetus removed from the peritoneal cavity. A 4 into 3 centimeter size uterine rupture was present at right corneal region. A corneal repair was done thereafter. Total 2 unit PCV, 4 unit platelet concentrate, and 2 unit FFP.
was given to patient, and patient was stable post-operative discharge on 8 post-op day after stitch removal. On discussion, interstitial pregnancies, rare type of ectopic pregnancy accounted for 2 to 4% tubal pregnancies. The surrounding myometrial tissue allows progression of pregnancy into second trimester, but rupture at such advanced age, gestational age may result in catastrophic hemorrhage with mortality rate up to 2%. High mortality rate partially due to difficulty in diagnosis and speed of hemorrhage. Risk factors are previous history of ectopic pregnancy, pelvis inflammatory disease, conception after tubal surgery, etc. Laparotomy with presence of senior gynecologist is necessary in a situation where bleeding might be severe and life-threatening because of the enormous blood supply to the uterine cornu, especially when gestation is advanced at the time of ectopic rupture. Cornual ectopics are associated with high risk of rupture at late as 10 to 16 weeks. It can cause profuse intraperitoneal bleeding, which can be life-threatening. Therefore, expectant management has no place in confirmed cornual ectopic in patient which is hemodynamically unstable. In this case, patient earlier scan missed the diagnosis. The later ultrasonography after rupture showed rupture ectopic pregnancy with a fetus of about 16 weeks, which was clinically suspected as a cornual pregnancy. Diagnosis was confirmed only after laparotomy. So, in the conclusion, cornual pregnancy in the most cases associated with severe catastrophe, clinical suspicions, ultrasonography in experienced hand can confirm diagnosis. Every effort should be made to diagnose case early before catastrophe.
Was using inversion mode, which fills up the entire tube, makes it solid, and therefore easily identified.
Time over.
Okay.
Question.
Hello, ma'am.
What are the various uterine anomalies you know?
First is the uterine septate uterus, bicornate uterus, then diaphylis, uterine diaphylis, and
yes,
then arcuate uterus, madam.
Yes.
Then
which is the other system involved? When you have uterine anomaly, which is the other system involved?
Which is the
in abnormality, congenital abnormality?
urinary tract, madam.
Yes.
Cardiac anomaly can be present with that.
Yes. Sometimes.
Spina bifida may be there, madam.
Yes. Skeletal abnormality. Madam. Question.
Yes. According to yes, candidate is not saying. Which pregnancy you think dangerous, cornual or ischemic?
Cornual, madam, because of the proximity to the uterine and ovarian artery of cornual pregnancy, it may cause profound hemorrhage.
Yeah, and it can grow, right? Quite a
Yes,
large
up
size
to
it can grow, yes.
second trimester. It can,
yes.
So the reason what madam is saying, understand, that is the main reason, not what you say, correct?
Okay.
You're correct. But the reason what it is ma'am is saying. So you said you have seen the cornual repair was done. Do you
Yes,
know
ma'am.
how it was repaired?
I'm a figure of 8.
And what problems did you face?
Repair was done with a figure of 8 suture with 0 number of IQL. But during a repair, there was a bleeding was continuous there.
Yeah. So what did you do for that?
Hemostatic suture, madam, applied it.
Time is over.
Okay.
Okay.
Thank you, madam.
Okay. Thank you, Manan.
Thank you.
Next.
Next candidate.
Yes, Dr. Meeral. We can see your slide. Yes,
Yes,
please.
you can start.
Start.
My case is severe preeclampsia superimposed on chronic hypertension with chronic renal failure with COVID-19 positive case report. Chronic underlying hypertension is diagnosed in women with documented blood pressure of more than 140/90 before pregnancy or before 20 weeks gestation or both. If new onset or worsening baseline hypertension is accompanied by new onset proteinuria or thrombocytopenia, renal insufficiency, liver involvement, cerebral symptoms, pulmonary edema, then superimposed preeclampsia is diagnosed. Systemic reviews and meta-analysis conclude that pregnant women experiencing coronavirus infection are at increased risk of miscarriage, preeclampsia, cesarean birth, and perinatal death. In my case, a 30-year-old female, 4th gravida, previous one cesarean section, 26-week pregnancy, referred with COVID-19 positive. On admission, her BP was 170/110 millimeter of mercury, pulse was 100 beats per minute, respiratory rate was 34 per minute, saturation was 85% on room air and 92% on NRBM. There was bilateral crepitation in respiratory system with edema on both lower extremities and on abdominal wall. Uterus was 28 week size with breech presentation with regular FHS without uterine contractions. On briefly reviewing her obstetric history, first full-term vaginal delivery 8 years back. For baby was early natal death. Second preterm vaginal delivery 7 years back. And third live issue was full-term LSCS done for severe preeclampsia 4 years back. She had history of severe preeclampsia in all previous pregnancy with ICU admission and hemodialysis. Initial investigation on admission, creatinine was 1.4, albumin was 2.1, plus 2 proteinuria and raised inflammatory markers. She was put on non-invasive BiPAP mode of ventilation. Higher antibiotics and antihypertensive was started. Anticoagulants and steroid was started. Decision was taken to stabilize her first and then termination of pregnancy. She was shifted to NRBM after 5 days, but her BP was not controlled despite of starting antihypertensives of 2 different mechanisms of actions. So decision was taken to terminate the pregnancy. Induction was done with double balloon catheter and she delivered fresh SB-BB of 1.1 kg with 900 grams of retroplacental clots. After delivery, 2 unit PCV, 2 unit albumin, 4 unit FFP was transfused. Gradually, oxygen support was tapered, and after 16 days of admission, she was maintaining oxygen saturation on room air with the 140/90 BP with adequate urinal. In COVID, with preeclampsia, there were overlapping laboratory abnormalities like thrombocytopenia and raised liver enzymes. So there was a diagnostic dilemma. COVID-19 and preeclampsia have opposing treatment consideration. Given the potential need for emergent delivery, corticosteroid supporting fetal maturation must be considered in preeclampsia. Pregnancies with chronic hypertension have increased risk of superimposed preeclampsia, IUGR, early delivery, and cesarean section. Before preeclampsia develops earlier in pregnancy, tends to be more severe and more often accompanied by fetal growth restriction. Such pregnancy needs to be carefully planned and managed. Such care is best undertaken by co-management among obstetrician and medical specialists. Such coordinated care will optimize pregnancy outcomes and health of.
Time is over. What advice you will give for her future pregnancy?
She have to take prenatal visits and take antihypertensive in between the pregnancies. Or in early pregnancy, low dose aspirin can be started.
When would you start this aspirin? What is the ideal time?
(16 to 18 weeks).
So for the next pregnancy, we are asking. This one is over, correct? So if she plans a future pregnancy, what is the time when would you like to start aspirin?
12 weeks.
12 weeks.
Yes, ma'am.
Okay, what other care would you like to take in future pregnancy? Can you think of?
Baseline investigation should be done. Complete blood count, RFT, LFT, urine routine micro, coagulation profile, and
So
regular
this
visit.
we are talking about future pregnancy. When shall you order all these things?
Sorry, ma'am.
This is about future pregnancy, right? Ma'am's question was कि future pregnancy में what all care would you take? Correct.
Continue antihypertensives in between pregnancies, or USG KUB fundus examination.
The time is over.
Yamini ma'am, ma'am, we can allow Yamini ma'am has to ask some questions.
That's
Yes,
okay. That's okay,
Yes.
Preeti. Go ahead with the next. Go ahead with the next.
Okay, next. Yes, Ruthvi, we can
Good
see your
evening.
screen.
Yes, good evening, everyone. Today I am presenting the case report of successful management of pregnancy with acute myeloid leukemia. The association of leukemia and the pregnancy is uncommon. Its prevalence is approximately 1 in 75,000 to 1 lakh pregnancies. The majority of the acute leukemias are myeloid lineage, as lymphoblastic leukemia is more common in childhood and adolescence. Acute myeloid leukemia is characterized by an excessive proliferation of immature myeloid cells, resulting in hemopoietic insufficiency. Most symptoms are related to complications of pancytopenia, such as infections or hemorrhagic disease. Early diagnosis is challenging since the initial symptoms of leukemia can be misleading and easily attributed to physiological changes related to pregnancy. I am presenting a 20-year-old case of a 20-year-old multipara woman with previous cesarean at 30 weeks of gestational age was admitted to our center for acute leukemia. On admission, her vitals were normal. Clinically, she was pale. Peripheral blood smear examination and coagulation test displayed WBC count of 11,300 per cubic mm. Hemoglobin was 6.8 gram per deciliter. Platelet was 32,000 per cubic mm. Myeloid precursors and blast cell was present in her peripheral blood smear examination. Fibrinogen was 334 milligram per deciliter. D-dimer was raised about 2,770 nanogram per ml. LDH was also increased. The bone marrow aspirator demonstrated 27% myeloblast and 10% promyelocytes with precursor of or rods suggestive of acute myeloid leukemia M2. As per hematologist opinion, she has been transfused about 10 unit of packed cell volumes, 4 unit of platelet concentrate, and 2 units of single donor plasma. As per hematologist opinion, for to start chemotherapy as early as possible, and after beta-metazone coverage, an elective cesarean section at 34 week was performed, and the live fetus of 2.2 kg was delivered. Post delivery on 4th day, chemotherapy regimen, injection cytarabine plus injection daunorubicin was started. After 15 days of admission, patient was discharged and advised to follow up. Discussion. Early symptoms of acute leukemia such as fatigue, pallor, weakness, and dyspnea are non-specific and often attributed to the pregnancy. Anemia and the thrombocytopenia can be falsely blamed on the pregnancy, thus resulting in a delay of diagnosis. These are relatively common findings in pregnancy. Neutropenia is more rare and merits a further investigation. The presence of circulating blast cell in blood film suggesting a hematological malignancy is an indication for a bone marrow biopsy. Treatment of acute leukemia is urgent and induction therapy should be administered as soon as possible, considering the aggressive nature of this condition. The main treatment for acute leukemia is chemotherapy. When diagnosed in first trimester, elective termination of pregnancy is reasonable regarding the high risk of spontaneous miscarriage, serious fetal malformation, and the fetal death as a result of chemotherapeutic treatment. However, current evidence suggests that the utero exposure of anti-cancer treatment in second and third trimester does not significantly increase the fetal morbidity or mortality. Therefore, premature delivery to enable the adequate treatment is not always necessary, and the treatment delays may compromise maternal outcome without favorable influencing the neonatal condition. However, the timing of the administration of the chemotherapy is important in order to avoid the induced pancytopenia immediately prior to the delivery. Therefore, it should not be given after 35 weeks of gestation because spontaneous delivery is increasingly likely to occur before the bone marrow is recovered. The decision on the timing and the mode of delivery in patient with acute leukemia is based primarily on the gestational age and the fetal well-being.
Your
In
time
any
is over. Question, please, Yamini ma'am. Preeti madam.
Sudhi madam, you can go ahead with the questions.
What will be the effect on the fetus when the mother has acute leukemia?
Intrauterine growth retardation, chances of stillbirth, premature labor.
How do you counsel this patient? What are the important points for counseling?
After
Mother's
pregnancy.
prognosis, mother's prognosis, baby's prognosis. Baby's prognosis, you said, how would you counsel her? Any such patient comes to you with pregnancy, what are the main salient feature of counseling in this patient?
If a patient present in the early trimester, like in first trimester, we should counsel her for termination of pregnancy. As due to the chemotherapy, there are chances of congenital malformations. If patient presents in second or third trimester, we would go for continuation of pregnancy with due risk.
Okay. Yes, Preeti, you want to ask anything? Dr.
No, ma'am,
Preeti?
no, ma'am. Yes,
Okay.
ma'am, yes. No, ma'am, I'm
ask,
just listening. Fine.
ask. Want to ask anything to her?
No, ma'am, no, we can go ahead.
Then we can go ahead with the next candidate. Okay, next.
Okay,
Next.
I can only say that this case is difficult for anybody.
Yeah, that's true. That's true.
So yes, it's good that we has had the guts to bring down such a case.
Yes,
It's difficult to concise it in such a short
yes,
time.
yes. No, nice job.
Yes, Dhwani. No, who is this? Dr. Prakruti.
Yes, ma'am. Good evening.
Yes.
I'm Dr. Prakriti from Government Medical College, Surat, a second year resident. Today, I'll be presenting a rare case report of pregnancy in a case of Yusuf syndrome. Yusuf syndrome is a type of a rare genitourinary fistula where the fistula is developing between the uterine cavity and the bladder. With the classic triad of symptoms, which is cyclic hematuria, also known as menorrhagia and amenorrhea, and without vaginal leakage of urine, which is to be noted here. And this can have variations based on the level of the fistula in the uterine cavity. Because the uterus is provided with a competent internal os, if the fistula is above the level of the internal os, there may not be any menstrual bleeding or vaginal leakage of urine. If it is at or below the level of the internal os, there may be some amount of vaginal leakage of urine. Because of this reason, this type of fistula is usually diagnosed quite late. The risk factors, the primary risk factor is previous history of cesarean section, especially when done in late first or second stages of labor, wherein injury may arise because of difficulty or inadequate reflection of the bladder from the lower uterine segment. Or if there is excessive intraoperative bleeding, it may also cause injury from attempts to achieve hemostasis, which may involve the distal ureter. Other risk factors would include severe dystocia, high forceps delivery, placenta percreta invading up to the bladder, and manual removal of placenta and uterine rupture. And also if the patient has received previous brachytherapy for carcinoma, or any other unrecognized bladder injury might persist, leading to a formation of a vesicouterine fistula. Now coming to the case report, a 24-year-old lady was referred with 7th running month of amenorrhea in a case of 4th gravida, 2nd para, 17 plus 6 weeks pregnancy with previous cesarean section with uterovesical fistula. She had primary complaints of bleeding per vaginum and blood in urine since 4 hours. Her obstetric history was G4P2, A1, L1, D1. The first one being a full-term emergency cesarean section done 8 years back for fetal distress, delivering a healthy baby boy. The post-operative period was uneventful. Next being a full-term vaginal delivery after cesarean section, which happened 4 years back, delivering a baby girl, but the baby died at the age of 2 years due to epilepsy. Later, the patient had spontaneous abortion 2 years back, followed by dilatation and evacuation. Patient gives history of having the classical triad of symptoms leading to the diagnosis of Yusuf syndrome since 3 years. That is, the patient had menstrual bleeding along with cyclical menorrhagia. She was advised corrective surgery but could not get it as she was from rural area and had poor economic condition. On examination, patient's general condition was good. She has tachycardia and rest of the examination was within normal limits. Per abdomen examination showed previous cesarean scar and the uterine scar was non-tender and uterus was 26 to 28 week size and it was relaxed. There were no contractions. On per speculum examination, there was spotting present. On per vaginal examination, the cervical os was parous and it was non-effaced. Her routine investigations were within normal limits and the sonography showed such a picture wherein the head of the baby was in the uterine cavity and the part of the abdomen and the limbs were in the maternal bladder as so shown in the picture. The patient and her relatives were counseled about her current condition and the need for emergency hysterotomy. After taking their informed consent, the patient was immediately posted for emergency hysterotomy. A phalansteal incision was put over the skin and abdomen was opened in layers. Interoperatively, uterus was 20 week size with bladder additions extending till the uterine fundus. A 5 centimeter size horizontal fistula was noted between the isthmus of the uterus and the posterior wall of the bladder. The hysterotomy incision was kept in the upper segment of the uterus. The fetal head was seen in the uterine cavity and the rest of the fetus was in the maternal bladder. After the fetus was delivered through the hysterotomy incision, the fistula tract was traced, the bladder and the uterine ends were visualized, they were freshened and the hysterotomy incision and the uterine end of the fistula was closed in double layer with polygalactin 10 sutures. The bladder end of the fistula was repaired with using monocryl 30 and omentum was interposed between the uterus and the bladder in order to prevent the formation of such fistula in future. A suprapubic catheter and a periurethral catheter was inserted and an abdominal drain was kept to watch for any leakage. Post-operatively, the patient was kept on IV antibiotic course. Injection depot medroxyprogesterone was administered for contraception. And as the patient's blood group was Rh negative, she was given anti-D. Her urinary tract health was closely monitored using urine routine and cultures once in 3 days. And she was put on syrup citralca and vitamin C to maintain the urinary pH. The suprapubic catheter was removed on the 14th post-op day after giving proper bladder drill and the periurethral catheter was removed the next day. The patient was able to void subsequently with residual urine of very minimal, that is less than 30 ml, which was detected via USG. Later, the patient was discharged with the following advice. If in case the patient wants to have an express pregnancy, she was advised to have it only after a period, minimum gap of 1 year. And in case the pregnancy is there, the gynecologist used to need to consider elective cesarean section at 34 to 36 weeks of pregnancy and an antibiotic course was given. Thank you.
Time is over. Good case.
So what do you think that which are the things you should take in mind to prevent such type of fistulous tract developing during cesarean?
Primarily, when we open the abdomen, we need to ensure that there is proper bladder separation through O-corner technique. That is, the uterovesical fold must be properly separated and the bladder must be retracted before keeping the incision over the lower segment. And while closing the uterine incision or while suturing, ligating the bleeders, we should make sure that none of the components of the urinary system is in the way. So that we can prevent formation of fistula. And in subsequent pregnancies, we need to avoid obstructed labor or delivering in second stage of prolonged second stage of labor in such patients.
And how do you differentiate it's not a rupture and this fistula tract? Because half of the baby was in bladder. Could it be rupture?
Ma'am,
it is scar pregnancy. For example, it is a scar pregnancy and it develops there and then it ruptures. The bladder is densely adherent there. So,
ma'am, it could be possible, but in that case, the symptoms would have been much severe with much of blood loss because it would have been an immediate event. And because there is no establishment of a fistula and it's only a rupture, the possibility of the baby being in the abdominal cavity would have been more rather than going into the bladder per se.
You said that the bladder was adherent up to the fundus of uterus. So the baby would never go into the peritoneal cavity because it's all covered, right?
Yes.
So if it is not diagnosed early, these other possibilities, scar pregnancy, which has ruptured, and because the bladder was densely adherent there, it was placenta percreta type of things. And so the baby could be in there, right? That also has to be kept in mind.
Yes.
Yeah.
Time is over.
Okay.
Thank you.
Next, please. Thank you.
So Preeti, next.
Yes, ma'am. The next one. Okay, Dr. Deepika.
Good evening, ma'am. I am Dr. Deepika Bhuya, presenting a case report of successful treatment of COVID-19 infection in a case of twin pregnancy. Coronavirus disease 19 has recently emerged as a major threat to human health. Infection ranges from asymptomatic to severe and critical. In the meantime, the health of pregnant women has become particularly important because maternal organs undergo many changes due to the effects of pregnancy. Current evidence suggests that pregnant women are at increased risk of severe disease. Specifically, they need for hospitalization, ICU monitoring, and mechanical ventilation, and the already complex management of the infection may be further complicated by pregnancy. This case is one example of meticulous management of a high-risk pregnancy with COVID-19 infection. My case report, a 35-year-old lady was referred as a case of fourth gravida second para, 34 weeks twin pregnancy with complaints of dry cough, sore throat, and breathlessness for 4 days. With her RT-PCR report for COVID-19 was positive. She had a history of second marriage with history of tubal recanalization 3 years before. She had history of 2 full-term normal deliveries followed by a missed abortion 5 years back. Currently, she had conceived after in vitro fertilization and had undergone cervical encerclage at 4th running month of amenorrhea. On examination, her vitals were within normal limits, except her respiratory rate was 28 per minute and saturation of oxygen was 88% on room air. On per-abdominal examination, uterus was unduly enlarged, multiple fetal parts palpable, and both fetal heart sounds were located with stethoscope and was regular. She was not in labor. Her initial investigations were as follow. Her hemoglobin was 15.8 gram per deciliter. Her total leukocyte counts were 13,000 per cubic mm. Her platelet were 231,000 per cubic mm with a serum creatinine of 1 milligram per deciliter. Her serum C-reactive protein was 42.5 milligram per liter. D-dimer was 1405 milligram per deciliter with a PTINR of 1. According to COVID-19 management protocol, which included injection remdesivir, injection dexamethasone, injection low molecular weight heparin, other supportive management, and oxygen supplementation as mentioned below. As her initial condition was grave, she was kept on BiPAP mode of non-invasive ventilation and remained so for 3 days. Gradually, her oxygen requirement reduced and she was shifted to non-rebreathable mask on 15-liter oxygen for next 2 days. With all these measures and intensive monitoring, her lung capacity improved, which was reflected as reduction in respiratory efforts and maintenance of saturation within normal limits. Later, she was weaned off to simple oxygen mask for next 2 days. At last, she was kept on room air and was observed for another 2 days. She was successfully cured without any residual complications and was discharged after a hospital course of 7 days. Our experience with this patient demonstrated that Our experience with this patient demonstrated that even with high-risk pregnancies, such as twin pregnancy with COVID-19, might result in good prognosis with timely medical care. Multiple pregnancy might exacerbate the natural vulnerability of acquisition of any infection. Hence, still the best recommendation for pregnant women is to consider strict quarantine and immediate medical help in case of exacerbation of symptoms. My conclusion after this case report is pregnancy with COVID-19 disease is a special scenario that needs a good understanding of pathophysiology of this disease. Training the obstetricians based on the current recommendations and previous experiences would ensure the appropriate care of this subset of population. Thank you. Thank you.
Yes, Deepika, what are the recent guidelines regarding vaccination for pregnant women?
Ma'am, regarding newer guidelines, vaccination can be given in pregnant women, especially if there is some underlying medical conditions or if pregnant women are health workers. Then, according to risk, we can vaccinate these pregnant women.
So can you say who has said this? It's not me or you. So whose words are you speaking right now?
Sir, ma'am, according to RCOG guidelines.
Okay, Yamini ma'am.
And what about vaccine in lactation?
Ma'am, vaccination in lactating mothers can be permitted.
And what about
according to
breastfeeding?
According to ICMR guidelines.
Breastfeeding?
Breastfeeding is also permitted. There is no study showing COVID-19 positive in breast milk secretion.
Suppose the mother has just delivered, can she give breastfeeding to the child?
Initially, ma'am, there is a separation is required up till the viral spreading is window.
Are you sure about this, or this is just one viewpoint?
It is just one viewpoint.
Yeah, so we want to know the statements which are being stated by any body. Okay, right. So, are there any guidelines which you know and would like to share? Do you know the guidelines? Can we allow? There is clear-cut guidelines from this. Correct?
Yes. This according to ICMR guidelines.
Yes. What does ICMR say?
We can
we
permit.
Should or we should not?
We should permit breastfeeding.
Okay. Okay. And what precautions do you take?
Ma'am, during breastfeeding, mother should wear proper surgical mask and she should wash hands and the areas of the breast which are going to be in relation with fetus, babies.
Okay, fine, good.
Okay, time is over. Okay, time is over. Thank you.
Okay, next.
Thank you. Okay.
Good evening, ma'am. This is Sunita Grace from New Civil Hospital, second year resident, presenting a case report of COVID-19 pneumonitis in a pregnant woman. So, introduction: a pregnant woman have higher risk of viral infections because of so many physiological changes occurring during pregnancy in all the systems, respiratory, reproductive, endocrine, and immune systems. For all coronavirus infections, higher rates of negative outcomes have been described for pregnant women. The inflammatory nature of COVID-19 during pregnancy exposes both women and their fetuses to a higher risk of obstetric complications and potentially long-term multisystemic complications in exposed newborns too. My case is a 30-year-old lady, third grade, 34 weeks pregnancy, was referred with COVID-19 pneumonitis with complaints of cough and breathlessness since 5 days. On briefly reviewing her past history, she had 2 uneventful full-term normal deliveries 2 years back, and her personal and family history was insignificant. On admission, patient was breathless with SpO2 80% on roommate. Respiratory rate was 28 per minute. Bilateral creps and wheeze present on auscultation. Per abdomen, uterus was 34 week size. Cephalic presentation with a regular fetal heart, and uterine tonus was relaxed. She was not in labor. Her basic investigations are hemoglobin 10 gram percent, and total WBC count was 6,000, and platelet were 2,45,000. Her inflammatory markers were D-dimer on admission, D-dimer 507, and CRP was 75. And gradually we monitor her reports with all the inflammatory markers. And her clinical course during hospital stay was: on admission, patient was breathless. Her SpO2 was 85% on roommate. Rest rate was 28. Initially, she was kept on NRBM of 12 liters, but her saturation was not maintained. So O2 was increased to 15 liters. As she was still not maintaining her saturation, she was kept on BiPAP support. Patient has been on BiPAP support for 28 hours. Later, NRBM for 6 days, on O2 support for 14 days. She maintained saturation on room air after 20 long days of oxygen supplementation through various modes. She had intermittent episodes of exacerbation of breathlessness, which was managed timely. She was given 8 days of antibiotics and steroids coverage and 5 days of remdesivir. LMWH was given for 25 days, and oral anticoagulants were given for 2 days. And finally, patient was discharged on 28th day of admission with oral anticoagulants. Discussion. COVID-19 infection is an inflammatory thrombotic vasculitis condition. Pregnancy being prothrombotic condition, COVID-19 infection in pregnancy poses more risk for thromboembolic events. Thus, identifying women at risk is important for successful provision of appropriate prophylaxis. Increased levels of D-dimer are associated with a worsening condition of the patient. Risk assessment for venous thromboembolism in pregnant women with COVID-19 admitted in hospital is necessary. Conclusion. Pregnant women with COVID-19 pneumonitis needs to be assessed for the need of
Audio is gone.
coagulation profile and D-dimer of the patient. Management of the pregnant women with COVID infection is best undertaken by co-management among the obstetricians and medical specialists. Such coordinated care will bring better pregnancy outcomes. Thank you.
Okay, Sunita. So, which anticoagulants do you know and are given?
Ma'am, heparin, IV subcutaneous, so heparin we will give them usually.
Correct. And then at home treatment or on oral drugs?
Orally.
Ma'am? Yes, orally.
Orally, aspirin will be supplemented.
Correct. Aspirin. Any other?
Enoxaparin, ma'am.
So oral drugs, do you know any other ones?
Oral anticoagulant.
Anticoagulants, yes.
Rivaroxaparin.
Okay, fine. What is its milligram and how is it given? See, your case is such, so you should know this, correct?
Yes, ma'am.
How do you advise patient to take? How many milligrams?
Usually 0.1 mg per.
Fine. Yamini ma'am, your question.
You said that there are chances of systemic problems to the baby. Can you name one or two? The COVID-19.
To the baby, ma'am?
Yes, you said, right, in your presentation.
To the baby mainly we could expect a premature baby, ma'am.
No, you said some systemic problem later on in the baby. That's what I think you mentioned.
Yes, you did.
Yeah. So what do you have to say about that?
Yes, no. Sorry, ma'am, no idea.
Because I think still because this disease is new,
yes,
we
ma'am.
do not know what will happen in the pediatric age group of those who delivered,
yes,
right?
Yes, ma'am.
Right. So still we have to research those things. Up
Yes,
till now, we know the complication up to neonatal level, right?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. Okay.
Okay, ma'am. Thank you.
Congenital COVID. What are the chances of congenital COVID having baby having COVID?
Yes, congenital COVID. Okay.
Congenital COVID.
Vertical transmission.
Ma'am, vertical transmission, till now, no established data supporting the vertical transmission of the COVID-19
Correct.
infection to the baby.
And
ma'am.
the other way of transmission is
Hospital acquired.
Hospital acquired बोलते हैं क्या बोलते हैं? And what are its chances?
Contact.
Why is COVID not so fatal in neonates? Do you know the reason?
To the baby, only through contact, their chance, ma'am. Contact from the mother.
So I'm just asking you, is there any chance or is there any physiology behind COVID not so fatal for kids or neonates?
Yes, ma'am.
Fine. Okay, done. Thank you.
Okay, fine. Fine.
Thank you. Thank you.
Next.
Okay. Okay.
Yes. Can you share your screen?
Yes, ma'am.
Yes, it's visible now.
Okay.
Yes, Janvi.
Go ahead.
Good evening, respected chairman, all the judges and my fellow colleagues present here. Today I, Janvi Kapadia from Smimer Medical College, Surat, would present a case of a sad fetus syndrome, that is a partial mole with a coexisting live fetus. Gestational trophoblastic diseases consist of broad spectrum of conditions ranging from uncomplicated placental molar pregnancy to choriocarcinoma with metastasis, a rare subclass of which is a partial mole with a coexisting live fetus, sometimes termed as sad fetus syndrome, caused due to chromosomal abnormalities in the fetus. A case of 22-year-old female patient G2P1L1 came with lower abdominal pain and vomiting since 2 days. She underwent normal vaginal delivery 2 years ago and had regular menstrual cycles. On physical examination,
मैंने बोला था शाम को आके कराना.
Patient was vitally stable. Her abdomen was soft and non-tender with 22 weeks of fundal height, and post speculum examination revealed no active bleeding or discharge. On USG, there was a single live intrauterine fetus with 6 of gestation with multiple cystic lesions in part of the placenta and intervening normal placental tissue suggestive of partial mole demonstrating the snowstorm appearance. On admission, her hemoglobin level was 10.3 gram percentage. Total leukocyte count was 13,400 and platelets were 1.5 lakhs. Baseline beta HCG level was 8 lakhs 12,1500 milli-international units per ml. Patient was explained regarding the condition, associated chromosomal abnormalities and maternal complications. Considering the maternal risk, patient opted for termination of pregnancy. After taking proper consent, second trimester MTP was done, induction with intracervical catheter and dinoproston gel was done, and she delivered an abortus of 190 gram along with grape-like molar tissue, which was associated with moderate amount of vaginal bleeding, which was treated with 2 units of RCC transfusion. Patient refused per karyotype study. Beta HCG was repeated 48 hours later and later on after 1 week. With serial beta HCG monitoring, it was found out that it returned to normal level within 4 weeks of delivery. Patient was advised to avoid pregnancy for 1 year and opted for injectable DMPA as a method of contraception. Sad fetus syndrome, also known as molar pregnancy with a concomitant live fetus, is a rare phenomenon with a reported incidence of 0.005% to 0.01% of all pregnancies. Partial moles have triploid karyotype, the additional set entirely of paternal origin. Molar pregnancies with a coexisting live fetus occurs in 3 variants. The rarest one is a healthy fetus with a partially molar placenta, as was our case. Most cases result in termination of pregnancy and do not progress beyond 20 weeks. In the event of a single normal fetus with partial mole, very few cases reach the stage of survivability. Also, these fetuses must be advised karyotyping to rule out chromosomal abnormalities. Molar pregnancy with the coexisting live fetus is a rare condition, the management of which is especially challenging.
Okay, what is the most common differential diagnosis for partial mole pregnancy?
Ma'am, it may be
suppose sonography, you are doing sonography. So what would you think when you see such type of thing? What is the most common differential diagnosis?
Ma'am, intrauterine adhesions.
Still more common?
Query incomplete abortion.
Vanishing twin. We are talking of partial mole, right? So one baby is growing, and
Yes.
right, that
Yes.
that fits this condition. Okay. So here, how would you definitely diagnose it? Then, when you have doubt in sonography,
Ma'am, we'll go for beta HCG levels, which would be.
so beta HCG will tell you. Okay.
Yes,
okay. Preeti, Smriti, Dr. Preeti, Dr. Smriti Ben. Hello, Dr. Preeti.
Hello.
Yes,
Preeti,
ma'am.
ask question.
Yes, okay, fine. So how do you monitor?
Ma'am, with our serial beta HCG monitoring.
So I just want to know practically, how many times would you like to go for beta HCG?
Ma'am, during the antenatal period? Ma'am, every weekly.
So in antenatal period, while following up your patient, every week you would like to go for beta HCG, correct?
Yes, ma'am.
And what should you do about it? Supposing values में you have first मतलब थोड़ा आगे पीछे आता है आपका थोड़ा ज्यादा आता है तो क्या करते हैं आप? Can you give me a guideline?
Ma'am, if the beta HCG level is in the increasing trend, we will explain the patient about the condition. That is, if the baby even reaches the period of survivability, it would be chromosomally abnormal and the survival rate is very low. We would advise the patient to go for termination of pregnancy in such cases.
Correct. So how much more? If it increases what you say, but what is the alarming point? How much would you consider as an increase?
Ma'am, more than 1 lakh international units per ml.
वो तो clear cut है.
Ma'am, when the increase is more than 10% of the previous value, we consider it as in the increasing trend.
Okay, fine. That's what I wanted to ask you. Fine. Okay.
Time is over. Thank you.
Thank you, ma'am.
Thank you.
Okay, beta.
Yes, thank you. So the next one. Smile on face of Janvi. Rajat.
Rajat Sharma.
Yes, Rajat, we can see your slide.
Should I start, ma'am?
Yes, please.
Go ahead.
Somebody else had shared their slides, ma'am. Hello.
Yes, yes. Wait, this one is slide of whom? Himani, can you please not share your slide now?
Sorry, ma'am.
she has to
Sorry,
stop.
sorry.
It's okay, it's okay.
Good evening to one and all present here.
Yes, Rajat.
Dr. Rajat Sharma. I am from Government Medical College, Akola, Maharashtra. We will be seeing a case report of fever, tachypnea, and falling saturation in an ANC patient in COVID pandemic is not always in COVID. A 25-year-old third gravida paravan living an abortion with 30 weeks of gestation presented in the emergency with history of high grade fever with chills, tachypnea, saturation 92% on room air. Patient has high grade fever with chills since last 4 to 5 days. She also complained of pain in her abdomen with distension since yesterday evening, with difficulty in breathing since 2 days morning. Patient was referred from periphery for the further management. On arrival, patient was conscious, cooperative, febrile, 102°F fever, pulse rate 122 per minute, BP 110/70, tachypnic with RR of 32 per minute, shallow breathing, face was flush, paranoid terror, saturation was 90% on room air, air entry decrease on both sides of the chest on respiratory system examination. On abdominal examination, abdomen was distended with guarding and tenderness was significantly evened more in the right hypochondrium. Present. Local examination was within normal limit. On pelvic examination, cervical was closed and there was no evidence of vaginitis or any infection. Rest of systemic examination was within normal limit. Patient underwent blood investigation and was found to have leukocytosis with 21,000 count. The HB and platelet count were within normal limit. Fever screening profile was negative. She was found to be negative for malaria, dengue, Vidal, urine examination and blood culture. On arrival, COVID rapid antigen testing was done since COVID was prevalent and it is still prevalent now. It was found to be negative. Liver function and renal parameters were within normal limits. Remaining serology reports for HIV, HBsAg, HCV, and VDRL were negative. Patient was RT-PCR swab was sent and was found to be negative. Patient underwent X-ray abdomen with shield and USG was done with suspicion of query perforation. X-ray shows bilateral pleural effusion with no free gas under diaphragm. USG was suggestive of large intra-abdominal collection around the 350 to 400 cc with query left lobe hepatic abscess rupture. The case was managed successfully with emergency laparotomy, higher injectable antibiotics, and percutaneous drainage of the abscess. Intra-abdominal collection was sent for microscopic culture. Report was suggestive of abscess with polymicrobial growth. Patient, after discharge within 6 weeks, presented again with fever and pain in the right hypochondriac region. Patient underwent scan, which was suggestive of localized abscess in the left lobe of liver, around 5 into 5 into 6 centimeter in size. Patient underwent USG-guided abscess drainage. The obstetric outcome was affected due to severe oligohydramnios and IgR. Patient underwent section and delivered 2 kg female child. Thus, use of technology not just for the diagnosis but also for the treatment and follow-up has a great implication in saving both mother and fetus. PLA during pregnancy is an extremely rare entity and poses therapeutic and diagnostic challenge. Thus, strong index of suspicion is necessary, but not only suspicion. Availability of basic minimum technology is very important since it has a life-threatening implication on both mother and fetus. Though the presentation of liver abscess itself in pregnancy is very rare, its rupture is very, very rare. We have just 2 reported cases till date, and thus multidisciplinary support, emergency preparedness, and most important, the technology with strong index, suspicion could save not only the mother but also the fetus. Thank you, ma'am. In this, we can see the pre-operative X-ray chest, which was suggestive of bilateral basal pleural effusion. Intraoperative left
lobe hepatic abscess rupture involving segment 5, 6, and 7. On repeat follow-up after 6 weeks, she was found to have a localized circumscribed hepatic abscess, which was underwent USD guided drainage.
Okay, Rajat. So good that technology is important, but my one question is, supposing the patient is presented to you and you don't have such high-tech things, what can you do in such a setting? And you don't have such specialized surgeons, and you have to operate her. You have done a cesarean section, and you find the bleeding is there, peritoneum is there, or liver has got this lesion. What can you do? Can you think of?
On arrival, since patient was having low saturation and everything, we could have done culdocentesis.
Culdocentesis, will that solve your problem?
Or we could have done ascitic tapping since it was a guarding and a rigidity.
So if your liver is bleeding, correct? What can you do?
Ma'am, emergency laparotomy would be the only last resort to save the mother.
Correct. So what will you do in laparotomy then?
Ma'am, since if it is bleeding like hell, then Pringel's maneuver could be done. We just, with the help of a great thumb, we stop the bleeder to achieve the hemostasis. That could be done on an emergency basis. But in our case, there was no as such bleeding. It was just all collection around 400 cc, which while on microscopy report was suggestive of polymicrobial growth.
Yeah, so good. So that is good, but then you can pack and then refer to a specialized center. If your liver is bleeding, at least that you can do.
Yes,
technology is
very
important, but
yeah.
Yes, so that is what the textbook says. If you don't have a specialized thing, if you don't have so many of things, if your liver is bleeding, please pack it and then send it to a higher center.
Okay, ma'am.
Yeah.
Time is over. Yamini madam, puchu.
No, bas, fine.
Thank you, ma'am. Thank you so much.
Thank you, Rajat. It was a good case.
Thank you, ma'am.
Yes, next.
Who's next?
Riyanshi. Madam, this is our college. So I'll
Riyanshi Patel.
Okay, ma'am.
Okay.
Yamini ma'am, aap lenge. Ma'am, at least time you can. Correct? Apde bhi. Timing to Shruti ma'am, તમે start રાખો હે ને?
Sure.
Time limit તમે જ રાખો ma'am, તમારા.
Hello.
Okay.
Yes, hello. Go ahead.
Good evening, ma'am. This is Dr. Priyanshi Patel, first year resident PSMC. I'm presenting the poster for the case report of a hydatiform mole, perforating hydatiform mole, which is proved to be a catastrophe in this case. A hydatiform mole is a part of group of disorder called gestational trophoblastic neoplasm, originating from a placenta with the potential to invade the uterus, leading to rupture and hemoperitoneum. We report a case of perforating mole in a young female presented with shock and hemoperitoneum. There is a history of 20-year-old female referred to SKH trauma care for management of hypovolemic shock and severe anemia, with the history of evacuation 3 months back at 2 months amenorrhea for hydatiform mole of bleeding since evacuation of mole with no medical history, which is significant. On presentation, with primary PP was 60 millimeter of mercury with high respirate and per abdomen showing guarding rigidity with uterus measuring 20 weeks size with cancer tender abdomen. Per vaginally os was closed with bilateral fornicis fullness with no active bleeding present. As the USG was suggestive of hemoperitoneum with complete molar pregnancy with no free fluid present and beta HCG of outside was more than 1 leg, patient was taken for emergency exploratory laparotomy. Intraoperatively, there was hemoperitoneum of around 3 liters and 700-gram clots removed. Perforation was present over posterior aspect of uterus at the uterosacral ligament. Obstetric hysterectomy was performed in view of perforated mole under cover of antibiotics and massive blood transfusion. Post-operatively, patient was hemodynamically stable. Histopathological report was sent and suggestive of invasive complete mole of uterus with involvement of cervix. On follow-up, medical oncology reference was done. On their advice, chest X-ray was done showing patchy radio-opacity in bilateral mid-zone and lower zone of lungs. USG shows 7 by 5 by 7 centimeter of vascular mass at the vault base. MRI brain shows no significant intracranial metastasis. Here is a beta HCG trend showing increasing levels, and based on these reports, patient was planned to start a chemotherapy named Imaco regime. On the day before starting first cycle of chemotherapy, patient presented with profuse vaginal bleeding, with USG showing vault base mass, bottle clot and bleeding PV, bottle clot pads were kept PV, and patient was under conservative management. Colony stimulating factor injections were given for 3 days with 4 PCVs transfused. Patient had received 2 cycles of chemotherapy under Imaco regime. But after that, patient lost follow-up and ultimately she expired this month due to chemotherapy complications. Discussion, there is occurrence of invasive mole in 1 in 15,000 pregnancy with local invasion in 15% of cases. In this, the cells will invade the myometrium with venous channels in the uterus and pelvis. Metastasis commonly occur in lungs, then to vagina, cervix, and genital tissue. But in our case, it metastasized only to lungs. Hysterectomy was the reasonable management for this patient to prevent the life-threatening hemoperitoneum and pervaginal bleeding, but it cannot prevent the metastasis. In molar pregnancy, suction evacuation is the first line of management, but surgical intervention is necessary to deal with hemoperitoneum and complications. Individual patient of GTD should be observed for stringent monitoring of beta HCG levels from the very first diagnosis. As per the WHO high-risk scoring system, they should be treated by chemotherapy with strict follow-up.
Time is over.
Okay, thank you, ma'am.
Okay, in a normal complete molar pregnancy, how do you follow up her beta HCG? What is the schedule for follow-up?
Okay, for complete molar pregnancy, first we do the suction evacuation. If it is not perforated, then after this procedure, we repeat 1 HCG for the baseline purpose.
Okay,
And
1 minute. How do you know it is perforated with suction evacuation?
no, if it is not perforated, if there is no hemoperitoneum or per abdomen finding, specify we get.
Okay.
Or then after that we trace the beta HCG level for the baseline purpose. Then after we continue every weekly till 3 negative consecutive levels, and then after that every month for 6 continuous months.
And what about the contraception?
Contraception should be used for 2 months after that.
Which contraception?
There may be barrier method can be used or oral contraceptive.
Is it mandatory to give contraception or not when you are following her on beta HCG?
Yeah, it is mandatory.
Mandatory.
Because
So
if
which method?
barrier method can be used, oral contraceptive pills can be used, or both.
So, but can be is a different story. I
No,
mean,
yes,
what
what is ideal?
Barrier and oral contraceptives.
So both of them together, or you give a choice of either barrier or oral?
Both of them. We can give a choice.
You give choice to the patient between barrier and OCP, correct? Am I correct?
Yes, ma'am.
That's what you want to say. Okay. Fine. Now tell me, what is the difference in suction of a complete mole patient and say incomplete abortion?
On suction in complete molar pregnancy, there will be vesicles coming out.
So, like I'm just जो निकल रहा है वो मैं नहीं पूछ रही हूँ. What I'm trying to ask you is, what precautions would you take as a doctor or as a performing surgeon while you are doing suction of a patient having H-mole or a patient having complete incomplete abortion?
In complete molar pregnancy, while we are performing suction, uterine sound cannot be used because when the uterine wall is
What
thin.
will you do? I am interested only in that. What you want to do, I am not interested.
Okay, ma'am. I will use the Hager's dilator or reaching up to the internal os, not going inside because the wall is thin, so it can perforate. Uterine sound should not be used.
What else? What one precaution would you take with your suction? Okay, while doing the procedure, how will you know that you might have perforated the uterus? How will you know?
Okay. There will be sudden gush of blood is there. The
Sudden gush of
resistance
blood.
loss.
Where? In your tube?
Yes, ma'am.
Then?
No, that will happen only if you have perforated uterine.
Correct. So usually this will not be there. What will be there? What are the signs which will tell you that you might have perforated? So please stop. What are those signs?
The resistance is lost.
So in H-mole, the resistance is really very little, correct? तो कैसे पता चलेगा? Yes, if you are very particular, you might feel the resistance is lost, correct. What else?
The vesicles are no more coming.
No, that is not the point, beta.
Time is over.
Thank you.
Thank you.
Okay.
Thank you. You can stop sharing your screen.
What is the next?
Next, Dr. Shravani.
Yes.
Dr. Shravani?
Yes, ma'am.
Yeah, can you,
yes. Yes,
Okay.
ma'am.
Okay, start.
Good evening, ma'am. My topic for today is vaginal myomectomy of endocervical submucous myoma. So myoma is also called fibroids, which are benign tumors composed partly of muscle tissue. According to different sites of myoma, it can be divided into the following three types: intramural, submucous, and subserous. It is a common gynecological disorder occurring in 20 to 50% of women of late reproductive age. Cervical myomas account for less than 5% of uterine myomas and may be intracervical or extracervical. Cervical myomas are smooth, benign tumors in the cervix and are closer to organs such as bladder, ureter, and rectum. Cervical myomas may bleed, become infected, block the urinary tract, cause dyspareunia, or prolapse into vagina. Pedunculated fibroids are attached to the uterine wall by a stalk-like growth called a pedicle. Ultrasound, trans-abdominal or transvaginal, and MRI are the effective diagnostic tool for assessment of myoma and plan the management accordingly. Myomectomy or hysterectomy is indicated in case of persistent bleeding with infertility despite medical therapy. So this was a case of 30 years female, Padawan, living one, came to MGM Kalambuli with complaints of menorrhagia with postcoital bleeding, post speculum findings of vagina healthy, and a 4 by 4 centimeter size pedunculated myoma impacted in cervix with bleeding. Per vaginal examination showed uterus normal size, growth seen protruding out of the cervical canal. USG ultrasonography was suggestive of 4.5 by 4.2 centimeters submucosal fibroid in endocervix with endometrial thickness of 7.8 millimeters. Investigations, HB was 6.7, counts and platelet were normal. TSH was done, which was 1.7. Patient was started on injection tranexamic acid, tablet Primulot 10, IV antibiotics, and 2 pints Paxil was transfused. Post transfusion HB was 9.5. Now decision for surgery was taken.
Informed consent was taken for vaginal myomectomy as well as hysterectomy. The surgery was performed under spinal anesthesia and dorsal lithotomy position with Foley's catheterization done. Cervix with fibroid was exposed, pedicle traced and clamped with 2 coccus clamp, and myoma was held with Alice forceps. Spontaneous enucleation of myoma occurred following sharp dissection, and excision of myoma by twisting traction force was done. Hemostatic sutures or traction sutures were taken until pseudocapsule was excised. Hega's dilator was inserted for confirming the patency of internal os of the cervix and kept in situ, and cauterization of the base of myoma was done. Endometrial curating was done following all the procedures. Histopath of report was consistent with leiomyoma surrounded by endometrial tissue, and endometrial scrapings were consistent with secretory phase of endometrium. Vaginal myomectomy is the route of choice in pedunculated submucosal myomas, along with accurate preoperative assessment of myoma size, location, and vascularization by USG or MRI. Abdominal hysterectomy might be indicated in case of narrow introitus, intractable cervix, inability to bypass the fibroid for devascularization of the pedicle due to large myomas. In this case, myoma impacted in cervix and its prolapse on pressure with opportunistic tracing of its stalk was the indication for vaginal myomectomy. In order to reduce the recurrence of myoma, and dyspareunia, improvement hematocrit in anemic patient, a GnRH analog leuprolide acetate is recommended.
What is the differential diagnosis when you first examine this patient in OPD?
Yes, ma'am. It can be initially a uterovaginal prolapse, or it can be cystocele. Can be, if the patient is pregnant, it can also be mistaken for the.
You have seen this patient you had seen before surgery?
Yes, ma'am.
You had seen, okay?
Yes, ma'am.
Have you put the photograph of that? No.
Yes, ma'am. The photograph on the. Yes,
that is of OT, right? Once you opened, okay. When it is nothing surgically done at that time, which is the most common differential diagnosis, you have to keep in mind before doing any surgery on this patient?
If the patient desires for fertility.
No. Have you heard of chronic inversion of uterus?
Yes, ma'am. Yes. Inversion of uterus.
Yeah. Okay.
And so that is what madam has said. That is what is common, and you have to differentially diagnose with this. Now, with this fibroid, you have said menorrhagia. What type of exact problem was there? Menstrual problem. Usually, in patients, what problems do we have?
In patients with bleeding myomas, they can have
your patient, your diagnosis. Okay, I'm discussing about your diagnosis.
Patients can have dyspareunia, can have the myoma, which can get infected as well. And in case of postmenopausal women, the myomas can show signs of degeneration.
Can you tell me what type of bleeding abnormality would be there? Usually,
ma'am, this postcoital bleeding is common in such cases.
So coitus history nahi hai to?
Have you heard of intermenstrual bleeding?
Yes, ma'am.
Is it common in such patient?
Yes, ma'am. It can occur in myomas.
Yes. You have written complaint of menorrhagia. So what type of menorrhagia exactly you wanted to ask? If you can elaborate on that, okay?
Patient had regular menstrual cycles, but the cycles were prolonged with complaints of abdominal pain since the myoma was.
And it was infected, correct?
Ma'am, in this case, it was not infected.
Okay.
Yes, ma'am.
Fine.
Time is over. Please.
Thank you, ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
The next participant.
Mrinalini Agrawal.
Good evening. Let me share my screen.
Yes, good evening.
Can you share my? Can you see my screen, ma'am?
Yes, now we can.
Yes. Good evening, everyone. I'm Dr. Mrinalini Agrawal from Lokmanya Tilak Municipal Medical College, Mumbai, here to present a case on the role of prophylactic internal iliac artery balloon tamponade in a placenta accreta spectrum disease. I'm sorry. My case, a 23-year-old Gravida 2, Para 1, NND1 with previous 1 LSCS, 30.2 weeks gestation, presented with gross discoloration and pain in the lower abdomen. A diagnosis of placenta percreta reaching up to the anterior abdominal wall was made, which was confirmed on MRI. Prophylactic internal iliac artery balloon tamponade was done, which was followed by laparotomy. A total obstetric hysterectomy was performed, and intraoperative and postoperative 5-pint PRC and 5-pint FFP transfusion was done with ICU stay, and the patient was discharged in 15 days. Here we can see the anterior abdominal wall discoloration in this patient. In the MRI finding, we can see the placental tissue which has come up to the anterior abdominal wall. Ma'am, intraoperatively, after the abdominal wall incision, just below it, there was placental tissue present. And placental tissue was densely adherent to the lower uterine segment. In a case of placenta accreta spectrum, which includes placenta accreta, increta, and percreta, bleeding is a major cause of maternal mortality and morbidity. Prophylactic internal iliac artery balloon tamponade is done with the help of interventional radiology, and it helps in reducing the intraoperative blood loss. It significantly lowers the rate of hysterectomy, more in cases of placenta previa and accreta than in increta and percreta, in which we still prefer a hysterectomy. Though there has been noted that there is no real significant effect on the blood transfusion effect index or the units of blood which is transfused post-operatively. According to present systematic review and meta-analysis, though, prophylactic internal iliac artery balloon occlusion should always be performed in a case of placenta accreta spectrum. Placenta accreta spectrum should be managed as a multidisciplinary approach with the help of radiologists, anesthetists, urosurgery standby, and it should be managed in a tertiary healthcare center. Prophylactic internal iliac artery balloon occlusion can help in reducing the intraoperative blood loss. It helps in reducing the hysterectomy rate from 31.2% to 8.9%, which is very significant. It increases the weeks of gestation in some cases. It was all given as a meta-analytic study by Nankali and Salari et al. In Reproductive Biology and Endocrinology Journal. Thank you. Can I have the questions, please?
Yeah, before how many days of her surgery this procedure was done? The same day?
The same day, ma'am. The same morning, the procedure was done in interventional
The same
radiology.
day, yeah, same day she was shifted to the
Yes.
Yeah, radiology.
OT, yeah. Directly from interventional radiology, she was directly shifted to the OT.
What was her weeks of gestation?
She was 30.2 weeks of gestation, ma'am.
30?
30 weeks of gestation at that
So
time.
why has she started bleeding?
No, ma'am, she had not started bleeding, but she was complaining of acute pain in abdomen.
Did baby survive?
Yes, ma'am. The baby was in NICU for a long time, but the baby survived.
What do you think? What was the cause of this acute abdomen pain in acute pain in abdomen?
Ma'am, pain in abdomen in placenta percreta. In my case, it was due to placental invasion, and patient had come to surgery with pain in abdomen, where she was diagnosed clinically diagnosed for obstruction. But then when they got the scan done, they noted that there was placenta percreta reaching up to the anterior abdominal wall. We tried conservative management for her for a week or two. We kept the patient in our wards. We gave her corticosteroids and everything, but then the pain was unbearable. Consent for obstetric hysterectomy and high risk consent was explained to the patient, and guarded consent for the baby was explained as well. And she was taken up for elective elective laparotomy followed by obstetric.
Okay, so Mrinali, in case of percreta, what are the general guidelines like? If you diagnose a case by say 28 weeks, what are the guidelines? What shall you do? How long would you like to continue the pregnancy, and or what decisions do you take? Would you terminate immediately, or you would wait, or you would like to go to term? What are the guidelines?
No, immediate termination is not necessary.
Not getting your voice. I'm not able to hear you.
Yes, sorry.
Yes, right. Correct.
The
Now,
guidelines do not suggest immediate termination. The guidelines say that the patient should be electively taken up between 35 to 36 weeks of gestation after giving corticosteroids to the patient, and pre-operatively there should be either internal iliac balloon tamponade done, or pelvic artery ligation to be done, or in case these facilities are not available, then internal iliac artery ligation can also be done.
Mrinali, do you think that in all cases ligation or even ballooning internal iliac vessel would help in all cases?
No, ma'am. Actually, recently there were studies done in which placenta previa and placenta accreta syndromes were studied by American Journal of Obstetrics and Gynecology, in which they did not really see a significant difference in the blood volume loss and the post-operative care, or even maternal mortality and morbidity. But in those cases, also placenta previa was included in the study. But meta-analysis and systemic analysis do give a significant difference.
No, what I am asking you, okay, does internal iliac vessel ligation or even balloon would help stopping bleeding in all cases of placenta accreta or percreta?
No, ma'am. It will not. No.
No, right?
No.
Right? Why? Why?
Correct. Why?
What's the reason that does not complete the treatment? No.
Ma'am, because bleeding can be due to many other reasons. It can be due to uterine atony, and it can be.
No. We are not going into it.
It's not.
We are not going into it.
So the thing is in placenta accreta.
Hello.
Yes, ma'am.
Yamini madam.
Hello. Hello.
Yes, Yamini
Am
ma'am, we
I
are able to
audible?
hear you.
Okay.
Yes, ma'am.
There are many collaterals which develop from the middle vessel and other vessels which are not branch of internal iliac, right?
Yes, yes.
So it may not suffice all the time.
All the time. Yes.
Yes.
Yes. So here comes my next question. If the vessels have invaded bladder, would you like to see that or not? And would that determine when would you like to terminate the pregnancy?
When the vessels have invaded bladder.
Yeah. Would you like to see that or not?
Yes, yes. I would definitely like to see that. There are bridging vessels.
So there are many criteria which would
Criterias.
determine how long would you continue the pregnancy or you won't. Correct?
Yes, yes.
Fine. Thank you.
Thank you.
Okay.
Hello.
Yes, hello.
Can I start, ma'am?
Yes, yes, please start.
Yes, go ahead.
My topic is intrauterine fetal demise due to true knot on umbilical cord. True knot is defined as entwining of a segment of umbilical cord, usually without obstructing fetal circulation, and commonly result from fetal slippage through the loop of cord. The incidence is 0.3 to 2.1%, and it is often undiagnosed antenatally when present, despite the availability of prenatal ultrasonography. When the true knot remains tight, it may impede the circulation of fetus and may result to fetal death in utero, especially in labor. In majority of cases, true knots of umbilical cord occur without any clinical significance. However, there is 25% association between true knots and intrauterine fetal demise. Unfortunately, below 3 cases resulted in intrauterine demise. Case 1, a 28-year-old gravida to abortion 1 with a singleton pregnancy of 42 weeks of gestation, reported with labor pain. She was vitally stable. On examination, fetal heart sounds were absent. All investigations were within normal limits. Labor was augmented and patient had an uneventful vaginal delivery. Baby was stillborn with macerated with true knot in the umbilical cord. Case 2, a 25-year-old gravida with 35 weeks of gestation came with complaints of absent fetal movements and ultrasound confirmed IUFD. She was vitally stable. All investigation in normal limits. Labor was induced and baby was stillborn with 2 loops of cord around the neck with a true knot. Case 3, a 23-year-old gravida to para 1 leaving 1 previous cesarean section, 25 weeks of gestation, came with complaints of loss of fetal movements. She was vitally stable. On auscultation, fetal heart sounds were absent. USG was done to confirm IUFD. Rest all investigations were within normal limits. She delivered spontaneously. Under a called umbilical cord accidents, which includes more than 30 conditions resulting from resulting in compromised blood flow to the fetus. The compromise could prove fatal to the fetus if it is a complete obstruction. In general, the belief is that the true knot of umbilical cord is formed between 9 to 12 weeks of gestation. This early gestation is a period where the amniotic fluid volume is relatively large. Paradoxically, there is reported evidence of knot formation of umbilical cord when a woman is undergoing labor. Prenatal diagnosis through routine antenatal sonography scan is very difficult. Hence, most of the true knots are diagnosed after birth. True umbilical cords are associated with an increased risk of small for gestation age infants, premature birth, need for neonatal intensive care, and fetal deaths. If true knots or even a loose knot is diagnosed in antenatal scans, active monitoring required till fetal lung maturity using Doppler velocimetry and continuous topocardiography during labor. C-section should be considered if fetus is viable to save the baby. Yes, ma'am.
Okay, time is over. What are the other cord?
Hello. Hello.
Some audio problem?
Other cord abnormalities.
Sorry, ma'am.
What are the other cord abnormalities? Ma'am is asking.
True knots, long cords, short cords.
What do you mean by filamentous attachment? What do you understand by that? Is it dangerous?
When the umbilical cord, yes, ma'am. When the umbilical cord is marginally attached to the placenta.
Is it filamentous? Or it is Betelgeuse?
When the umbilical cord is attached only to the membranes and not directly to the placenta, that is filamentous cord.
How it is dangerous?
It can when it can cause bleeding during the labor, and we might get confused with the maternal or fetal bleeding.
No, so which bleeding is that? It is fetal or maternal? Hello? Hello? Dr. Preeti?
Fetal bleeding.
Fetal bleeding. Yeah, Preeti?
Time is over.
Okay. Preeti, want to
Okay, ma'am. Thank you.
Okay. Next. Shifa.
Thank you, ma'am.
Okay.
Thank you, Harshita.
Thank you, ma'am.
Okay. Next is Shifa.
Thank you. Stop your screen sharing, Harshita.
Who is next? Shifa.
Hello, Shifa.
If she is not available, can we go to the next?
Yes.
Dr. Mayank Shah, next
Yes,
is
ma'am.
Dr. Yeah, Mayank
Yes, ma'am.
Shah. Are you available?
Yes, ma'am.
Yeah, share your screen and start.
Yes, ma'am. Can I start, ma'am?
Yes, go ahead.
Good evening, respected judges and delegates. Myself, Dr. Mayank Shah, first resident doctor in Srimati Sardaben Hospital, Ahmedabad. I am here to present a poster on COVID-19. Things should we know? COVID-19 caused by severe acute respiratory syndrome coronavirus 2 is a global public health emergency. Symptoms include like fever, cough, myalgia, fatigue,
8 minutes,
expectoration. Yes, ma'am.
Mayank, do you have slides? Are you sharing your slides?
मैम पोस्टर है, स्लाइड्स भी है.
Anna, so, are you sharing your screen?
Yes, ma'am.
Oh, I am not getting it. Oh. Okay, go ahead. Yes, okay, ma'am. Okay, go ahead.
Laboratory findings include like lymphocytopenia, elevated C-reactive protein, elevated lactate dehydrogenase, and the radiological findings include ground glass opacity in CT scan. The specimens collected are sputum, bronchoalveolar lavage, and endotracheal aspirate. Endotracheal aspirate. Risk factors. Due to the physiological change in the immune and cardiopulmonary system, pregnant women are more likely to develop the severe illness. Pregnant women with COVID-19 who have pre-existing medical conditions such as diabetes and hypertension or older or overweight are more likely to suffer severe health complications, including the need for endotracheal intubation, ICU admission, and renal failure. COVID-19 also increases the risk of prematurity in pregnancy and postpartum NICU admissions for baby. Checklist for symptoms. Precautions taken at COVID-19 spread by 3 routes: droplet, contact, and airborne. For droplet precautions, put surgical mask on patient. Single room healthcare worker uses personal protective equipment. For contact precautions, single room healthcare worker uses PPE appropriately, including wearing gloves and gown upon entry to room and disposable equipments. Airborne precaution, put surgical mask on patient. Negative pressure isolation room healthcare worker uses PPE appropriately. Then clinical classification, patients classified in 3 groups: suspected case, probable case, and confirmed case. Suspected case is patient with an acute respiratory illness, fever, and at least one sign and symptom of respiratory disease like cough, shortness of breath, and a history of travel to a residence in a location reporting community transmission of COVID-19 during 14 days prior to symptom onset. And probable case is suspected case for which lab testing for COVID-19 is inconclusive, or a suspected case for which testing could not be performed for any reason. Confirmed case, a person with a lab confirmation of COVID-19 irrespective of clinical signs and symptoms. Precautions taken by patient is like social distancing, inform hospital when in labor about COVID status, wear a mask, regular antenatal checkups and fetal monitoring for well-being of fetus, hand hygiene, reduce anxiety, and connect with people. And potential drugs for treatment in pregnant women. First is azithromycin. Azithromycin is commonly azithromycin. Azithromycin is a commonly used drug during pregnancy in human. No increase in the frequency of malformation or other direct or indirect harmful effects on the fetus have been observed. A recent population-based cohort study has shown an increased risk of major malformation when macrolide antibiotics, mainly erythromycin, are administered in the first trimester, and an increased risk of genital malformations when prescribed at any trimester. any trimester and increased risk of genitoma when prescribed at any trimester. Additionally, warnings have been issued in regard to possible increased risk of miscarriage, cerebral palsy, and epilepsy. પછી remdesivir pregnancy માં remdesivir is a broad spectrum direct antiviral nucleotide prodrug which effectively inhibits the replication of SARS-CoV-2 and that of related coronavirus, including MERS-CoV in non-human primates. Then hydroxychloroquine crosses the placental barrier and accumulates in the melanin cells of the fetus, where it remains for prolonged period. Hydroxychloroquine is excreted in breast milk, but at therapeutic doses, no effects are expected in breastfed children. It can be used in lactation. Tocilizumab is an animal study has shown an increased risk of miscarriage or embryo-fetal death at high dose. It is preferred to avoid during pregnancy unless clearly necessary. Thank you, ma'am.
Hello.
Yes, ma'am.
Yeah, you have studied, have you done study on patients, just giving information?
Just information.
Just information. Okay. Have you come across any COVID-19 patient?
Yes, ma'am.
Yeah.
Many patients.
Many patients.
Yes.
So can you narrate any one patient, the basic line treatment, what did you give to her?
As we actually
One
have
patient you treated.
normally asymptomatic patients we have in our hospital for COVID-19. As all patients are have a full term. We
Okay,
just
suppose now I'll give you situation. Suppose patient is serious and she is on BiPAP. So what should be your line of treatment? Should you terminate the pregnancy or should you continue?
If patient supposed to maintain the saturation on BiPAP, but maximum amount of oxygen we given to patient is transferred to baby. For the patient benefit, we have terminated the patient on BiPAP. So whatever amount of oxygen we given to patient.
What are the guidelines?
Right.
Okay, okay. No issues. Preeti, Dr. Preeti.
Yes, ma'am. So that is actually what the same question was. So suppose if a pregnant patient comes and is symptomatic, what are the drugs you would like to give? Apne ye theory we have read, but in your experience, what are you doing?
Ma'am, hello.
She is having fever. She is having 4th day of fever, correct? And her SpO2 on room air is 90. Now, how would you proceed?
Ma'am, if the oxygen is 90, we start just oxygen, give azithromycin and symptomatic treatment to maintain the oxygen level.
Azithro, and you will start oxygen, and then what else?
Symptomatic treatment and
so I'm asking you, what
maximum
else?
IV fluids to.
Maximum IV fluids. What do you understand by it? Okay, so fine. If you
adequate amount of fluids given.
Okay. So now just tell me that while doing a sonography, if I find that the Liker is diminished, okay, if AFI is 1, correct, and she is say 37 weeks of pregnancy, what shall you do or you won't do?
Ma'am, if the baby is well-being and supposed to.
So I'm saying color Doppler, everything is fine, but the Liker is reduced. It's AFI is just 1.
Terminate the pregnancy.
This is the scenario. So would you terminate the pregnancy and on what grounds?
Labor
and active COVID. Okay, fine. Thank you.
Okay, okay, okay. Chalo.
Thank
Next,
you.
Nishi. Next, Nishi Patel. Nisi Patel. The 9-year side.
Hello? Hello?
Yeah, are you Dr. Nisi?
Actually, we can
Yes,
listen
ma'am.
you and we can see your screen as well. Go ahead.
Good evening,
Okay,
ma'am.
go.
My topic was my topic is prevalence of thyroid disorder in antenatal patient and its fetal-maternal outcome. The thyroid disorder are common in pregnancy, and the most common disorder is a subclinical hypothyroidism. Due to some complex hormonal changes during the pregnancy, there is a increase the requirement of the thyroxine during the pregnancy. According to the recent American Thyroid Association guidelines, the recommended reference range for serum TSH are 0.1 to 2.5 international unit per liter in the first trimester, 0.2 to 3 international unit per liter in the second trimester, and 0.3 to 3 international unit per liter in the third trimester. So the aims of the study is to prevalence of the thyroid disorder in the antenatal patient and in fetal-maternal outcome. The study period was 1 year, and this is the observational clinical study. The inclusion criteria for study is the patient, the antenatal patient who has the less than 13 weeks of the gestational age, singleton pregnancy, primigravida or the multigravida, and the non-case of the hypothyroidism. The exclusion criteria for the study was the multifetal gestational, non-case of the chronic disorder like the diabetes, hypertension, or the liver disorder, or any other renal disorder. The previous history of the bed obstetric history, and those who plan to deliver in the other hospitals. The material and the method was the patient who attend the OPD in our hospital. The serum TSH, T3, and T4 reports was done, and on the screening test, the patient divided into the patient who has the hypothyroidism or the hyperthyroidism are included in the study. On the conclusion was the thyroid hormone is essential for the placental development in the pregnancy, especially during the before the 12 week of the pregnancy. The thyroid disorder caused the abortion, preeclampsia, IUGR, placental abruption, oligo, or the low birth weight. The patient who adequately treated during the first trimester with hyperthyroidism or the hypothyroidism, there is a decrease the chances of placental abruption, preeclampsia, preterm labor, or oligo. Thank you, ma'am.
Okay, Nishi, is there any role of pre-conception counseling in this type of patient? Nishi? Hello? Hello?
Hello?
Hello? Hello? Hello?
Hello?
Hello? Nishi? Hello? Nishi, can you listen to me?
Hello?
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 Hello, Nishi? Smruti Ben?
I think there is some connection problem.
There is some problem. So we can call the next candidate rather than wasting time.
Prachi Shah.
Yes, ma'am.
Prachi Shah. Yeah, go ahead, Prachi.
Yes, ma'am. Hello, good evening, ma'am. Can you see my slide, ma'am?
Yes, go ahead.
Okay, ma'am, good evening, ma'am. My topic is Bakri Balloon Tamponade, a life-saving technology. I am first year resident from Civil Hospital, Ahmedabad. So postpartum hemorrhage is an obstetric emergency that accounts for 25% of maternal deaths worldwide. The definition includes there is a cumulative blood loss of greater than 500 after vaginal delivery or greater than 1000 ml after cesarean delivery. The blood loss associated with the signs or symptoms of the hypovolemia within 24 hours of the birth process. PPH is the one of the leading cause of the maternal mortality across the world. The most common cause of postpartum hemorrhage is uterine atony, which comprises of 80% of these cases. First line management is administration of the uterotonics drugs, which are, if their response to uterine administration are failed, the tamponade of the uterine cavity has been found to be effective and can be performed either packing with 4-inch gauze or by placing a Foley's catheter or the Sangstegen Blackmore tube or a Bakri balloon. This is the case of successful Bakri balloon placement in the management of atonic postpartum hemorrhage. So the 27-year-old female patient came with a 6 months amenorrhea with complaint of abdominal pain and bleeding per vaginum since 1 hour. So in general examination, pulse rate was 94 and the blood pressure was 118 by 70 mmHg. On per abdomen examination, the previous year's transverse scar was present, which was non-tender, and uterus was 22 to 24 week size. External balloonement was present and uterus was relaxed. On per speculum examination, clothes were present, which was removed, which was 56 grams. Per vulvar examination was not done as patient had the previous USG, which was suggestive of the low-lying placenta. So USG was done and which finding suggestive of low-lying placenta. Placenta was anterior and fetal cardiac activity was present and Liker was adequate. So after patient spontaneously delivered of the MCH of 750 gram after 5 hours of admission, on birth baby's heart rate was not present, so it was declared stillbirth by the pediatrician. The control cord traction for the removal of the placenta was done, but placenta was still in situ. So after waiting for 30 minutes, decision for the manual removal of placenta under general anesthesia was taken and patient was shifted to the OT. Manual removal of placenta done and uterus was atonic. 2 injections of the carbopros, 250 micrograms at the interval of 5 minutes given. Still uterus remained atonic. So decision was a Bakri balloon insertion was taken. Bakri balloon catheter was inserted and instilled with the 480 ml of the normal saline and total 5 PCV given. Post-operative period was uneventful and Bakri balloon was gradually deflated within 24 hours and there was no active bleeding. Patient was successfully discharged on post-operative day 8 and analgesic antibiotic given. Patient was advised for weekly follow-up and for first month and fortnightly thereafter. At the end of 2 months, the patient was healthy and without any complications. So postpartum hemorrhage is one of the serious obstetric complication. Hysterectomy is the only option when the other interventional treatment attempts fail. Bakri balloon tamponade is second-line management opted for PPH, which are unresponsive to uteronics. So, in the Bakri balloon tamponade are indicated in the uterine atony resulting in acute PPH, cesarean delivery for the placenta previa, low-lying placenta, or a focally invasive uterine placenta, acute or recurrent uterine inversion, and secondary PPH 24 or 12 weeks after delivery. The collapsed balloon is inserted into the uterus, which is filled with fluid. Balloon adapts to the configuration of the uterine cavity to tamponade uterine bleeding. Maximum balloon capacity is 500 ml. One lumen of the dual lumen catheter is used to infuse saline and expand the balloon, while the other lumen allows drainage, which is designed to monitor ongoing bleeding above the level of the balloon. The device is intended for the one-time use. Multiple studies done for the effectiveness of the BPT, which was success rate of approximately 85%. Another surgical procedure include Beeline suture, suturing of the placenta bed, ligation of the interiliac artery, uterine artery embolization, or hysterectomy. But these procedures are difficult to perform and carry a risk of inadvertent injury to the adjacent structures and blood loss, or they may include the blood loss given collateral blood supply to uterus, which may increase the risk of disseminated intravascular coagulability. The use of the Beeline suture may increase the risk of the myometrial
necrosis. In spite of the uterine cavity appearing to have the volume of the macula greater than the maximum capacity of the balloon, placement of the balloon directed in such a way to address the area of concern, it causes vaginal bleeding to stop, and also hemorrhagic stability was achieved. So conclusion is that this was the successful use of the Buckley balloon in case of the postpartum hemorrhage in presence of atonic uterus. As Buckley balloon tamponade is simple, readily available, effective and safe procedure in the second line treatment in the massive hemorrhage that are unresponsive to the uteronics. It is very useful for the peripheral healthcare centers where expert gynecologists and anesthesiologists are not available. It is also can be done by paramedical staff, and it cannot be completely stopped bleeding, but can buy some time to transfer patient to the tertiary healthcare center. Now, new pregnancy are possible and are not negatively affected by the uterine tamponade with the Buckley balloon. Thank you, ma'am.
Okay, suppose you don't have this Buckley balloon available to you with the same mechanism.
Yes,
is there anything which you can do in the periphery?
Yes, ma'am. Yes, ma'am. There is a uterine packing by the gauze pieces, or ma'am, there is a roller packs. So we can do the uterine packing by that.
What is the disadvantage of uterine packing?
Uterine packing, it
When
may.
you do packing, would it allow the uterus to retract properly? And would it allow the blood to come out? Right? You can't see.
Yes. Yes. We cannot measure
rather than any other method. Do you know that which can you make something like Buckley balloon?
Yes, ma'am. Condom catheter. We can do the condom catheter.
So in periphery, if you don't have this, you can utilize even that.
Yes, ma'am.
Okay, Preeti. Dr. Preeti. Dr. Shruti Ben. Hello. Dr. Preeti. I think are they online or what? The other judges. Dr. Preeti. Okay then. Okay.
Okay. Thank you, ma'am.
So yeah. Now next. Next candidate. Dr. Urvangi.
Yes, ma'am.
Yeah. Okay, you can go ahead.
Yes, 1 second. Good evening, ma'am. Myself, Dr. Urvangi, and I'm going to present a case in which there was a decision dilemma in a young patient with ruptured hemorrhagic cyst of ovary and von Willebrand's deficiency. As we all know, the von Willebrand disease is one of the most common inherited bleeding disorder. Most of the time, it has the autosomal dominant type of inheritance. The incidence of the disease has been reported as 1:100 to 1:1 lakh. In every menstrual cycle, there will be formation of ovarian hemorrhagic cyst formation is very common in case of von Willebrand disease, and its rupture, it may lead to hemoperitoneum because of the defect in the primary hemostasis. In our case, a young girl, age of 18, unmarried female, who was already diagnosed with a case of von Willebrand disease. By the age of 3, she came to the OPD with acute abdomen and vomiting. The patient age of menarche of 13 and her menstrual cycles were regular. She used to bleed for 5 days in a 30-day cycle with moderate amount of bleeding. In her past history, patient had the similar episode 1 year ago. On examination, our patient, she had severe pallor with tachycardia and hypotension. So the features are suggestive of the hemorrhagic shock. On per abdominal examination, there was a tense, tender lower abdomen with bilateral flank fullness. In the local examination, the patient's hymen was intact and there was no active bleeding per vagina. So immediately the patient was admitted. She was shifted to our setup and resuscitative measures were started. Patient's blood investigations were sent and a bedside USG was conducted, which was suggestive the findings of hemoperitoneum with bilateral ovarian hemorrhagic cyst. The maximum size was 3 to 4 centimeter around. In her blood investigation, her hemoglobin was 7, her platelet counts were normal, and her APTT was mainly deranged. Now here the dilemma was whether to go for conservative management or to explore it. So with a combined management of gynecologist and hematologist, the decision was taken to manage the patient conservatively. We rather preferred to go for a replacement therapy. We transfused 2 pack cells, 4 FFPs, and 14 cryoprecipitates to the patient under antibiotic coverage, and the patient was kept for strict monitoring for 2 to 3 days. Gradually, the patient got, she improved, and patient got discharged. She came for the follow-up with her normal menstrual cycles and no residual disease. Here, the point of main discussion, whenever a young female with hemoperitoneum comes to us, the thing which comes in our mind first is exploration of the abdomen. And in the era of minimal invasive surgery, we would think that what best we can do for the patient. But in the patients with the bleeding disorder, this could turn out more harmful rather than being beneficial. Especially in this patient, the incidents are recurrent. She may develop the same situation in her next cycles too. So it was better to go for conservative approach. Another thing which is that inherited bleeding disorders in the females are usually unappreciated. So the systemic approach to go to the cases like this, we can put a differential diagnosis in our mind with rapid logical thinking will help the clinicians to take a right decision and to manage the patient with the teamwork. The take-home message, I would say, a good surgeon is considered to be that who knows how to make patients' life less morbid with the knowledge of when not to operate. Thank you.
You said that this can recur frequently.
Yes,
so what do you think? Giving her so many products all the time?
Ma'am, here the situation was life-threatening for this patient.
She had before that. Did she have a ovarian cyst?
Yes,
Was it
ma'am.
diagnosed? So
Yes, ma'am.
cannot we prevent allowing ovarian cyst to happen frequently?
Yes, ma'am. We can.
So what can you do? So what
When
can
we
you
can
do?
put the patient on the OC pills by let not make ovulation every time. That is the way with low dose OC pills we can conserve this situation.
Or you investigate why she is not ovulating regularly, right? It could be thyroid associated, it could be anything. So
Yeah,
treat,
ma'am.
treat
Yeah,
the
yeah.
condition, right?
Ma'am, that we already go through all this. She was having normal thyroid profile and another things were in normal limits. So in past also she had similar episode because of ruptured ovarian hemorrhagic cyst, and within a year she developed this situation again because of ruptured hemorrhagic cyst only. But the patient was very well aware, ma'am, but because she was already diagnosed by the age of 3 years that she is having this 1 bilirubin factor deficiency. She used to have epistaxis, recurrent bruising previously too.
Yeah, but that is true. But what is our role is to prevent such type of episode frequently, right? Hello. Hello. Hello.
Hello, Dr. Preeti.
Sorry, I just joined. I've not heard.
Yes, ma'am. Hello.
Okay, okay.
Hello. I was not getting, sorry, ma'am. It got stopped.
No issues. Okay, Urvangi. Okay.
Yeah.
Yeah, so we'll start with the next case.
Okay. Thank you. Thank you, ma'am.
Okay.
क्या पूछ रहे हो? एक मिनट. हाँ, नेट बंद है.
Next कौन छे? Pooja Shah. Who is? Next,
Yes, ma'am.
Ruja છે કે હિમાની છે?
Himani છે, madam.
Okay. Okay.
Good evening, madam. Hello, ma'am. Can you hear me?
Yes, we can, and we can see your slide as well. Start.
Ma'am, I am Himani Deepakbhai Chaudhary, presenting a case of perforating hydatidiform mole, a surgical emergency. Introduction is gestation trophoblastic disease include the tumor spectrum of hydatidiform mole, invasive mole, placental site trophoblastic tumor, and choriocarcinoma. Hydatidiform mole is the most common, and its incidence varies worldwide from 1 in 400 deliveries in India. It is common in women under 20 years and over 40 years of age belonging to low socio-economic status and having nutritionally deficient diets. Invasive mole is reported in 10 to 15 of a woman who had a primary molar pregnancy. Although considered benign, invasive mole is locally invasive and may process a distant metastasis. It may totally invade the myometrium and associated with uterine rupture and hemoperitoneum. As perforating rupture of uterus and hemoperitoneum, which is life-threatening to the patient. Emergency laparotomy and hysterectomy is mandatory as a therapeutic procedure. A case report of molar pregnancy who presented with hemoperitoneum and shock requiring laparotomy and hysterectomy. Case report is a 32 years old woman was presented with pain in abdomen since 7 days. She was married for the past 9 years and had one pregnancy and has one live child. Delivery was full-term cesarean delivery with no non-complications. She had amenorrhea of 2 months. She had no history of bleeding per vaginum or passage of vesicles. There was no suggestive family or past history, no history of any surgery in past, including dilatation and curettage. On examination, she had a moderate degree pallor, afebrile, tachycardia, blood pressure was 98 by 56 mmHg. Abdominal examination, 14-week size mass with tense abdomen. Size of uterus was confirmed by bimanual examination. Urgent ultrasound in emergency ward revealed molar pregnancy with ill-defined right posterior lateral wall and moderate fluid in peritoneal cavity. Maybe ascites or possibility of ruptured head to be considered. In ultrasound finding, heterogeneous bulky uterus with cystic area in myometrium, possibility of gestational trophoblastic disease to be considered. Right posterior lateral wall of the uterus is not visualized. Possibility of rupture of posterior wall of the uterus. Her serological investigation is beta SCGS 4789 and hemoglobin was 9. Or other reports is normal. Laparotomy under general anesthesia was done using sub-umbilical midline incision. Broad ligament and lateral pelvic wall was found. Both ovaries were found normal. Total hysterectomy was done. Total blood loss was estimated to be 4 liter. Total 7 units of B positive cross-match blood were transfused. Her post-operative period was uneventful and she was discharged on 7th day. After checking, her hemoglobin was 10% and beta HCG which was 19.8. She was followed up with no complications. In laparotomy finding hemoperitoneum about 2 liter, uterus of size of 18 weeks, right posterolateral wall was perforated and found ruptured with molar pregnancy infiltrating myometrium and be associated with uterine rupture and hemoperitoneum. Surgery is indicated only if there is ruptured and sorry madam, sorry. Hello.
Yes.
Infiltrating right vaginum or passage of vesicle. There was no sorry madam, sorry.
It's okay, relax.
In discussion, hydatidiform mole is abnormal pregnancy which should be evacuated as soon as possible and follow-up is most important. Invasive mole may totally penetrate the myometrium and be associated with uterine rupture and hemoperitoneum. Surgery is indicated only if there is rupture and hemorrhage. Differential diagnosis of molar is from normal pregnancy which can be confirmed by ultrasound and beta HCG level. Conclusion, emergency laparotomy helps in saving the life
life of patient presenting with perforating mole. If we diagnose it early and evacuate early, we can prevent the patient from landing up in the life-threatening complication. Therefore, I insist that all women should have an early scan, almost mandatory at 5 to 6 weeks of gestation. In this case, the woman had an ultrasound only after the development of symptoms of an abdominal catastrophe. Had she has been diagnosed early, she would not have had to lose her uterus. Thank you, ma'am. Hello?
Yes.
Hello?
Yes, yes, we can listen you.
Now, what about follow-up of this patient?
Ma'am, follow up after every 1 week up to the 6 months for beta HCG.
Only beta HCG or something else also?
Sorry, ma'am.
What is role of sonography in follow-up?
Ma'am, whether the H-mole is perforating or not.
Follow-up.
Follow.
Follow-up. Okay, Preeti, ask question now.
So you say that surgery is only indicated if it is perforated or there is hemoperitoneum. That's it. Are you sure?
Sorry, ma'am, I can't hear you.
In your presentation, what you narrated is that surgery is indicated only if it is perforating the uterine wall or there is hemoperitoneum.
Madam, hemoperitoneum or perforating mole, both in we can do laparotomy and obsterectomy if the patient was fatal.
I just wanted to ask you, is there any other scenario wherein you need to do a laparotomy or maybe a obsterectomy also? Perforating नहीं है, उसके अलावा?
Perforating, ma'am, perforating or hemoperitoneum.
Fine, okay, good, that we got it. Okay. Now in follow-up, as madam asked, if you have done a sonography after say 2 months and again hydatidform mole is there, initial जितना था उतना ही वापस आ गया है, right? Immediately it was uterine cavity was empty, but then after 2 months again it is there.
Carcinoma also suggestive of carcinoma and metastasis.
What shall you do? कैसे proceed करेंगे?
Sorry, ma'am.
Management in this case. Suppose in another sonography, the follow-up sonography showing same picture.
Huh.
So now, what is the management?
She said sorry, ma'am.
Then, ma'am, we laparotomy issue.
And then laparotomy. Something else?
Then obsterectomy.
Yeah. Okay then.
Okay, go ahead. चलो बीजा ने next में बुलाई ली. Okay.
Thank you, ma'am.
Okay. Akash Gajjar, no? Next is.
No.
Excuse me, ma'am.
Yeah. Yes.
Who is she?
Riya Shah.
Okay, Riya.
Yes.
Okay. Go ahead, Riya.
Yes, ma'am.
Your slide.
2 minutes.
Good evening, everyone. This is Riya Shah, first-year resident from Sri Krishna Hospital, Karamsad. I am doing a poster presentation on an interesting case of placental chorioangioma. Placental chorioangioma can be detected in 0.6 to 1% pathomorphological examination of placenta. It can cause complications such as congenital anomalies, hemolytic anemia, polyhydramnios, IUGR, and IUFD. Chorioangioma causing complications may require early interventions. Polyhydramnios caused by chorioangioma can be treated with indomethacin therapy and amnioreduction. Complications like hydrops may be treated with interventions like alcohol injection, laser coagulation, and microtol embolization of feeding vessels. If complications occur in the later stage of pregnancy, then termination of pregnancy by delivery is the treatment of choice. I'm presenting a case of a 27-year-old, fifth gravida, third para, abortion 1, live-in 2, in early third trimester, who came for first visit at STH. She had no complaints. On routine examination, she was diagnosed with polyhydramnios and was further investigated for the same. Her routine ANC investigations were found to be normal. CBC was normal. Oral glucose tolerance and HbA1c were also within normal limits. Anomaly scan was done at 18 weeks at private hospital, which was suggestive of no gross congenital anomaly and placenta normal. USG was done at 28 weeks, which was suggestive of an increased AFI of 25 centimeter with normal fetal parameters, but a placental clot of around 5 centimeter. Thus, a differential diagnosis of a placental chorioangioma versus placental hematoma was made. Patient was then put under close follow-up. After 2 weeks, AFI was increased to 33 centimeter, and then patient was put on indomethacin therapy for 2 weeks. Steroid coverage was given for the lung maturity of fetus. At 34 weeks on USG, fetal growth parameters were normal. Fetal Doppler was normal. AFI was reduced to 14 centimeter within normal limits. Minimal pericardial effusion was seen in the fetus. No evidence of fetal anemia was seen. Patient then presented to our emergency at 35 weeks of gestation in early labor. She underwent a preterm LSCS in view of non-reassuring NST and maternal demand and delivered a female child with favorable outcome. Placenta was sent for histopathological examination and report was suggestive of placental chorioangioma. Sorry.
Okay. Now chorioangioma, can you see? You can see in sonography, right?
Yes, ma'am. Yes, ma'am.
So what is the differential diagnosis in sonography for chorioangioma?
Ma'am, chorioangioma can be put under differential diagnosis with a placental hematoma. Then a placental clot, hematoma.
Have you heard of uterine contraction?
Uterine
contraction in the early weeks of pregnancy? No.
No, ma'am.
There is a condition where only there is a small part of myometrium which contracts, and
contraction. Yes, ma'am. Okay.
it also sometimes mimics like this. So what will confirm your diagnosis? Adding what to sonography?
Ma'am, Doppler flow.
Color.
Color.
Yes.
Yes, ma'am.
Okay. Yeah, Preeti?
Yeah, so you want to finish your discussion conclusion or we go ahead?
Okay, ma'am. Ma'am, in discussion, chorioangioma is the most common histological type of placental tumor. An increased incidence rate of chorioangioma is associated with maternal age, hypertension, diabetes, female sets of newborn, premature labors, first delivery, and multiple pregnancies. Doppler ultrasound examination is the gold standard in primary diagnosis of chorioangioma. MRI is used only in suspicious cases. In the current case, with a high index of clinical suspicion and timely intervention, led to favorable outcome of both fetus and mother. Thus, apart from maternal and fetal factors, placental factors are also important to consider as an etiology for polyhydramnios. Although placental chorioangioma is rare, it can have serious implications on pregnancy. Ultrasound diagnosis and interventions like administration of NSAIDs, amnioreduction with continuous monitoring of fetus can decrease the complications and improve the perinatal outcome. Histological examination of placenta to confirm the diagnosis and benign nature of the disease should be done.
Okay. So now if polyhydramnios is there,
Yes,
which one of the treatments what you have narrated works for you or you are giving?
Ma'am, in the current case, we went for indomethacin therapy, which led to a favorable outcome and it caused decrease in the AFI.
Okay, so that is advised or indicated till what? And what is the criteria of using that?
The criteria can be when the polyhydramnios causes maternal distress, then some therapy should be done to reduce the amniotic fluid.
Exact question was indomethacin helps in reduction. Or
Yes.
would use indomethacin in which set of patients?
I mean, in cases where it causes maternal distress, um, in cases where the uh, the weeks of gestation have reached a limit, so that we can save the pregnancy, and so we don't have to go for termination of pregnancy.
So if your indomethacin is not working, then what would you do?
Ma'am, we can go for amnio reduction. That is,
What are the complications of
amnio reduction can cause abruption. It can cause infections, like infection to the fetus. It can.
this booklet nahi chahiye. Have you done it? Have you seen?
Yes, ma'am. We did amnio reduction in one of the cases over here.
What is the site wherein you put in the needle?
Depend. It did depend.
Fine, thank you. Thank you, Leah. Next.
Next. Who is next?
Akash Gajjar.
Yeah, Akash.
Do we have any other participant remaining?
Sujata Modi.
Yes, Sujata is
Yes,
there.
ma'am.
Yes, come on, start.
You can start.
Great, ma'am.
So after Sujata, who is there? Please prepare yourself. Okay, we can see your screen.
Good evening, ma'am.
Yes, good evening.
You start.
I am Dr. Sujata Modi, presenting a poster titled Successful Outcome of a COVID Positive Mother with Pulmonary Embolism. Now, as we know, pulmonary embolism is a leading cause of death in the developed countries, and pregnancy and other high risk factors like prolonged pulmonary embolism. And the purpose of this case report is to emphasize the importance of strict vigilance in COVID-19 pregnant males for thrombotic complications. So timely diagnosis and management of the pulmonary embolism lead us to the successful maternal outcome. So I'm presenting a case of 34-year-old female second gravida para 1 living one with previous normal delivery, presenting at 31 week of gestation to Sri Krishna Hospital Karamsad with COVID rat positive report. And on examination, she is presented with breathlessness, fever, cough for 5 days, and not maintaining the saturation. So we have to kept her immediately on an RBM support at 15 liter oxygen. And on further investigation, the chest X-ray shows the lung involvement, and then we started the medications. Injectable antibiotics were started
Then prophylactic enoxaparin 0.6 milligram subcutaneously BD dosing is started. And after 4 to 5 days of this therapy, then she developed more dyspnea and more tachypnea, and we have to kept her on HFNC high flow. And after that timely, we have planned elective intubation combinedly from gynec department, pediatric department, and intensivist department. And we have decided to plan emergency section for that patient. And patient was taken for emergency CS under general anesthesia after elective intubation, and surgery went uneventful. She delivered a male child weighing 2.5 kg, and the baby was kept in NICU under observation on air. And she got the baby got COVID negative and got discharged after 5 days. And post LSCS, the patient was shifted back to ICU, intubated, and after 15 days of being her positive, she was shifted to non-COVID side. And then uh, suddenly she developed breathlessness. And in view of sudden breathlessness, sudden dyspnea, and high D dimer levels, we were suspecting the pulmonary embolism. And in view of that, we have done the CTPA reports, and that suggestive of right pulmonary artery embolism on 22nd of April, and for which patient was timely thrombolized with the injection alteplase 50 milligram in intravenous, given over 2 hours at the rate of 25 ml per hour. And after that, the patient condition is improved. And then she was shifted on CPAP support, and then extubated after 3 days. And then she was maintaining good on face mask. And we repeated the chest X-ray after 1 month, that that suggests post-COVID fibrosis, but that suggests significant resolution of consolidation and ground glass opacities, which is indicated in the image number 2. Then we give injectable antibiotics, piptaz, meropenem, clindamycin. And then in antenatal period we gave steroids, dexamethasone 8 milligram TDS for around 10 days. And then post delivery, we have started tablet perfenidone 400 milligram TDS for the lung fibrosis, and tablet apixaban 2.5 milligram BD for 10 days. And that is to be continued post discharge. And the patient got discharged on her 35th post operative day. So to conclude my case, I would like to say that first thing is we have to see in such patients who have a high oxygen requirement.
Time is over.
Timely. Okay, ma'am.
She's my college, madam, so I'll not ask questions.
Priti, go ahead.
Yes, yes. So it's a nice case. I mean, I see that pulmonary embolism and you should bring your patient back.
Yeah.
So, yeah. But then after this, what are the carry-home messages or SOPs? Have you changed anything? What do you routinely advocate now?
Sorry, ma'am?
Okay, to prevent such an event, what would you like to do?
Yes, ma'am, first thing for the pregnant females, especially when they had complaints such as breathlessness, she should immediately rush to the hospital. She should not wait at home, because in such cases, with prolonged hypoxia, it could get worsen, because we just have we saved the near loss case in this case.
So one is that, but then if you can narrate just what are your points, what will you do?
Ma'am, what I would like to say, we have already started the enoxaparin for prophylactic basis. So we cannot rule out the pulmonary embolism will not occur in this case because we have prophylactically given the medicines. So it should always be kept in mind.
Okay.
It could happen.
Okay. So irrespective of the reports, this is your SOP you give in each and every one, is it?
No, ma'am.
Okay.
No, we will give like on the basis of O2 requirement. If patient is having oxygen requirement or patient develops sudden breathlessness, then that
And
should
only
be
you
the.
give this anticoagulant, otherwise no, is it?
No, ma'am. If the hospitalization there is prolonged hospitalization, then prolonged bedridden condition, patient could not move. So we have to start anticoagulants.
Okay, time is over. Thank you.
Thank you.
Thank you, ma'am.
Okay, thank you.
Next.
Next why
Start sharing your screen, please.
Yes, ma'am.
Yes.
Yes, Dr. Sheetal.
Good evening, everyone. I'm Dr. Sheetal, first year resident from PSMC Karamsad. I'll be presenting obstetric complication of pregnancy with uterine fibroid. Uterine fibroid is the commonest benign tumor of female reproductive tract. It occurs in 20 to 40% of women. Incidence in pregnancy is 0.1 to 3.9%, with complication rates of 10 to 30%. In pregnancy, it may lead to anemia, miscarriage, antepartum hemorrhage, malpresentation, preterm labor, increased C-section rates, postpartum hemorrhage, and blood transfusion. Our patient got all the possible complications together, but with good outcomes. So presenting here, our patient, 26 years old female patient, gravida 2, para 1, leaving 0, with 30 weeks of pregnancy and previous CS, came to hospital with complaint of bleeding PV. No other specific past personal or family history. Previously, patient had male child by C-section, but early neonatal death. She was our book patient as well and was under strict antenatal care. Though she got complications, patient got admitted twice in antenatal period. First time she came with complaint of bleeding PV, had HB of 6, we gave blood transfusions and managed conservatively. Again, she came with the same complaints. On examination, patient had good build. General examination was within normal limit, vitally stable, but a common 30-32 week size. FHS local examination was minimal bleeding present. This time she delivered male child weighing 1.7 kg, initially admitted to sorry ma'am, in view of low weight and preterm. USG was suggestive of posterior wall fibroid as shown in the picture, and placenta was anterior and right lateral to the lesion. Intraoperatively, incision was put on the lower uterine segment and placenta was seen. Clots were present. BB was lying in the upper segment, delivered by the breech presentation. Bleeding was continued, so the bilateral uterine arteries were ligated and intrauterine packing was done. Multiple fibroids were present in the upper segment, fundus, and the lower segment. The largest one was 8 by 10 centimeter fibroid in the lower segment in posterior uterine wall. Post-operatively, we removed the week on second post-op day. Patient was given blood transfusions and discharged on the 12th post-operative day. Multiple intrauterine fibroids leads to distortion of the cavity, which leads to abnormal placentation and malpresentation. Decidua over the fibroid usually thins out, and blood flow surrounding fibroids found reduced. All these changes lead to detrimental outcome of the pregnancy.
high index of suspicion, maintaining HB, microbirth planning at suitable tertiary care center are key factors to minimize the complications. In this case, due to high chances of blood loss, we did not perform the cesarean myomectomy. Our patient had all the complication, but in such complications, good surgical decision, planning incision, and timing can lead to good fetal-maternal outcome. In conclusion, uterine fibroid in pregnancy are usually asymptomatic. Thus, the first line of management is conservative, but sometimes it may lead to fetal complications. Hence, it should be always considered as a high-risk pregnancy. However, in the presence of complications, good selection criteria need to be applied to individualize patient care for optimal results. Thank you.
Time is over.
Okay, so Sheetal, like, how will you follow up now? You have not removed the fibroid, correct?
Ma'am, in follow-up, we did the USG. The size of fibroid were reduced. Ma'am, we can, sorry, ma'am.
Natural course, what do you expect?
Ma'am, usually the size of the fibroid reduced after the delivery. And ma'am, in this case, we can do myomectomy after 6 months.
So myomectomy after 6 months. So what are the criteria? Would you always like to do? Then why not now?
Ma'am, actually patient was anemic, patient had placenta previa. She already had high risk of blood loss. So we did not perform the myomectomy at that period. Patient already had history of multiple blood transfusions.
So do you know red degeneration?
Yes, ma'am. Red degeneration is, sorry, ma'am.
How shall you diagnose it?
Ma'am, pelvic pain will be there, acute pelvic pain. Patient will be having leukocytosis. Fever can be there, ma'am.
Okay, fine. Okay, ma'am.
Okay, okay. She's my college.
Yes, ma'am. Oh, so sorry. Yamini, ma'am.
Okay, okay. Go ahead, bus. Good.
That's good.
Okay, thank you.
Thank you.
Now I invite Dr. Gajjar to please say a vote of thanks to all of us. Dr. Gajjar, are you there? Sir. I asked.
One second. I am calling him.
Oh, okay, ma'am.
Okay.
So meanwhile,
Meanwhile, સાંભળને પ્રીતિ.
Madam.
Madam, I am available. Am I available? Am I audible?
Yes, sir, you are. You are audible.
Yes, sir. Yes, sir.
So, on behalf of Nursery Gynec Society and West Zone Yuva Fogsi organizers, I really express my thanks to you all learned judges, Dr. Rajal Thakur, Dr. Yamini Trivedi, Dr. Aarti Patel, Dr. Ashwin Vachani, Dr. Maitri Shah, Dr. Shilpa, Dr. Smruti, Dr. Preeti Punatar, and Dr. Deepa Pitre. Really, you people have done marvelous work. And really, I salute your spirit. I salute your hard work. You are really great teachers. Thank you very much for helping us.
Thank you, sir. Thank you, sir.
Thank you so much, sir.
It was a nice experience. Thank you, sir.
Okay.
Thank you.
Our Preeti.
Yes, ma'am.
સાંભળને માર્ક્સ નું કેવી રીતે કરવાનું છે બધાએ કેવી રીતે કર્યું છે
હા મેડમ મેં લખ્યા છે અને આપણે આઈ થિંક આ પતાય પછી આપણે ત્રણેય જણા શેર કરી લઈએ
હું તને એ જ કહું છું
મેડમ અહીંયા સ્ટુડન્ટ સાથે પ્લીઝ અહીંયા ના વાત કરો
we cannot talk here exactly
અમે માર્ક્સ નહીં બોલીએ ઝલક
we will
અમે
not
મારી સ્ટ્રેટેજી નક્કી કરીએ છે કે કોણ કોને મોકલશે ઓકે પ્રીતિ કોલ મી ઓકે કોલ મી
સ્ટુડન્ટ્સ ને આપણે we will request to please leave.
Oh no issue ઝલક અમે લીવ થઈ જઈશું ડોન્ટ વરી અમે ફોન થી વાત કરી લઈશું
I just want to ask કે હવે કેટલા સ્ટુડન્ટ્સ છે ma'am our presentations are left. Yes, we know Dr. Shweta Sawant. Yes, are you ready? Ketla students baki hai? How many of you are remaining? How many students are you are there? I mean, can you just raise your hand or write in the chat box?
કોઈ કેતુલ બારોટ છે કોઈ હા એ બધા કરવાનું છે
Yes, yes. So line up so that we can.
એમની એટલે ઝલક આપણે પૂછી લો ને કે છે અવેલેબલ, નહીં તો પછી we land here.
હા એટલે કોણ જે પેલા
Shivani,
અહીંયા યસ
yes,
મેડમ
you are available. Hold on, Shivani, can you come?
અટેન્ડન્સ લઈ લો ને.
Madam, Shivani Shinde છે.
શિવાની આવે છે, શિવાની આવતી લાગે છે.
Let her in. You can present Shivani. Share your screen.
શિવાની.
And after Shivani, Ketul. Are you ready? After Shivani, Ketul, be ready.
And then Shweta. 3 are remaining.
ના પણ are they available?
Yes, madam. Ketul and Shivani, both of them are there. Ketul, you are after Shivani, okay? And Shweta, you are after Ketul. Go ahead, Shivani. Yes, yes.
Good evening, everyone. Myself, Dr. Shivani Shinde from the MGM College and Hospital, Aurangabad. Today, I am presenting my poster over the conservative management of the adherent placenta post-abortion adherent placenta. The incidence of the adherent placenta is definitely more after the delivery than the post-abortion. The rate of the recent retained placenta after the spontaneous abortion is 0.1%, whereas the after spontaneous abortion is spontaneous delivery is around 3%. It may lead to the hemorrhage, hence it has a case fatality rate nearly 10%. My case was 23-year-old Fanny Gramida with the 4 months of amenorrhea. I was referred to the MGM hospital with the returned placenta after the spontaneous abortion of 16 to 18 weeks. Evacuation was tried outside, but the placenta could not be removed. On examination, the patient was vitally stable and pale. On per abdomen examination, abdomen was soft, non-painful. On per vaginal examination, minimum dark color of blood was seen. On per vaginal examination, os was closed and unencased. Uterine size was 12 to 14 weeks. Cornices were free and non-tender. On admission, her beta hCG levels were 28,041. USG was suggestive of the retained placenta of 8 by 4 by 5 centimeter size, volume of 90 cubic centimeters with a mild internal vascularity. In view of the no active bleeding and possibility of adherent placenta, decision of the conservative management was taken. Patient was started on the methotrexate followed by the folinic acid supplementation along with the antibiotic coverage, followed by the serial monitoring with the beta hCG, ultrasonography, hemogram and LFT. Hemogram and the LFT for the monitoring of the bone marrow and hepatotoxicity. Initially, one cycle of the 4 doses was given. The fall in the beta hCG and the vascularity was not satisfactory. As we can see in this chart, fall in the beta hCG was not that much satisfactory. Then, decision of the continuation of the treatment was taken till the beta hCG less than the 100 milli international unit per ml. Total 4 cycles of the methotrexate was given. At the end of the 4th cycle, beta hCG level was 52 milli international unit per ml and USG was suggested of 3.4 by 3 centimeters of size of retained placenta with mild peripheral vascularity. After 3 months of the treatment, she experienced the placenta at home completely, which was confirmed with the ultrasonography. Outcome varies widely ranging from the expulsion at the 7 days to the reduction of the placenta in 6 months. Ultrasonography in the incomplete abortion should be considered for the possibility. Conservative management appears to be a safer alternative to the active surgical management in a hemodynamically stable patient desiring future fertility. It was a lengthy process, hence it tests the patience of the patient,
Hold on, Zala, can you mute everybody else?
Patient with the follow and the investigation. This case report shows the mental technology as important as the drug technology in such cases of prolonged drug therapy of the successful mechanism. Here we can see the ultrasonography showing the placenta along with the peripheral vascularity. In the next chart, I have shown the falling trend of the beta hCG after the surgery. And third picture shows the placenta breaks after the methotrexate treatment. Patient has passed the placenta breaks.
એક મિનિટ વેટ. અરે ઝલક બધાને મ્યુટ કર દો ને. તમારા લેવલે?
I mean, can you do this? કારણ કે નથી સંભળાતું.
Okay.
હવે પેપર પેટર્ન એવું થઈ ગયું છે. ઓનલાઈન જ થશે ને આ વખતે બી સપ્ટેમ્બરમાં જ થશે હવે. 1 ઓગસ્ટ તો પોસ્ટપોન જ થાય.
Can we just mute this?
રાજલબેન નું છે ખબર નહીં.
Chalo, mute everybody, na? I mean, except for Shivani and me. Yes, I can also do better, but Shivani, beta, can you again come up? From when this discussion
ફોન નહીં કરતી પણ કદાચ તારા પાસે કોઈ ફોન આવે તો તને ખબર હોવી જોઈએ કે
ટિપિકલ સ્પીચ है नहीं है बहुत की है सर्वाइकल लेंथ पर मत जाओ मां इनकी खुली दस्ता
તો એ જ કહેતી કે બુદ્ધિ
રાજલબેન અને અશ્વિનભાઈ નું કન્વર્ઝેશન મને ઓડિયો માં આવી ગયું.
Shall I start again?
Start better.
Yeah, minimum. Yes. Okay, fine.
Start from the beginning or
no? But actually, we could not.
From where you had, yeah.
Okay.
My case was 23-year-old primary gravidia with a 4 months of amenorrhea was referred to MGM hospital with a retained placenta after the spontaneous abortion of 16 to 18 months. Evacuation was tried outside, but the placenta could not be removed. On examination, patient was vitally stable and pale. On abdomen examination, it was soft and non-tender. First spectrum examination revealed minimum dark colored blood. On per vaginal examination, os was closed and unclosed. Uterus was of 12 to 14 week size and fornices were weak and non-tender. On admission, her beta HCG level were 28,041. USG suggestive of the retained placenta of 8 by 4 by 5 cm size with the volume of the 90 cubic centimeter internal vascularity. In view of the no active bleeding and the possibility of the adherent placenta, decision of the conservative management was taken. Patient was started on the methotrexate followed by the folinic acid supplementation along with the antibiotic coverage, followed with the serial monitoring with the beta HCG, ultrasonography with the Doppler, hemograph and LFT. Hemogram and LFT for the monitoring of the bone marrow and hepatocytes. Initially, 1 cycle of the 4 doses given, but the fall in the beta HCG and the vascularity on the USG was not satisfactory. As we can see in this graph, from the 28,000 to the 25,000, there wasn't that much significant. So the decision of the continuation of the methotrexate was taken if the beta HCG is less than 100 milligram international unit per ml. Total 4 cycles of the methotrexate was given. At the end of the fourth cycle, beta HCG levels were 52 milli international units per ml with the USG suggestive of the 3.453 centimeters of the retained placenta with a mild peripheral vascularity. After the 3 months of the treatment, she expelled the placenta at the home completely, which was confirmed by the US ultrasonography. The outcome varies widely, ranging from the expulsion at the 7 day to the resorption of the placenta in 6 months. Ultrasonography in the incomplete abortion should be considered for the possibility of the adherent placenta. Conservative management appears to be a safer alternative to surgical management in a hemodynamically situation. Designing for the future fertility. It was a lengthy process. It tests the patience of the patient's family, and obstetrician. Also, the compliance of the patient with the follow-up and investigations and treatment. This case report shows the mental technology as important as the drug technology in such cases with a prolonged therapy for the In the first picture, we can see the ultrasonography showing the retained placenta along with the peripheral vascularity. Second picture was showing the trend of the falling trend of the beta HCG with the exit treatment. And third picture was showing the expulsion of the placental fluids after the
Fine. So that's a good case that you have picked up so early. Just my question is, supposing you have not picked up, what are the complications which can occur while you're doing DNC of such a case? Have you seen?
While doing DNC, it can lead to the perforation of the uterine cavity, or it might have, we had retained more, we couldn't have removed all the placenta braids, and some of might be retained.
Have you seen these things? I'm just asking you what you have seen. Have you seen any such complications in your case?
No, what is the most severe complication which can occur?
Ma'am, sepsis, she might lead into the sepsis.
Sepsis might even be possible in
that is, yeah, that's late, immediately. Yeah.
Practical.
Might have led into the hemorrhage, ma'am. But she, my patient wasn't into the any such complication. She has come within 4 hours after the abortion.
Yeah, so 4 hours after the abortion, but usually do you do this? I mean, this is an extensive workup which you have done. So you do it in all patients? Better you muted your, you need to unmute yourself first.
Generally, we do only the ultrasonography and the hemogram for the
Correct. So on ultrasonography, it's really difficult to get this. Correct?
Yeah, ma'am. We have to do MRI for this for further evaluation. If you are suspecting further,
that's what my point is. Practically speaking, we don't do MRI in each and every patient.
Every patient.
Yeah. So how do you know? What is one dreaded complication which we are scared of? One or two? Practical. Okay, no issues. So what is the future? What about future pregnancy of this patient? If patient is asking you, what your answer would be?
For the future pregnancy, she has to be cautious. She has to keep the follow up with the serial antenatal visit. We have to take care of the as soon as the 18 to 20 days as the placenta is fully formed. We have to do the ultrasonography mainly for the placenta localization. As as she had a history of adherent placenta in the previous pregnancy, she might have the adherent placenta in the next pregnancy also. So USG with the color Doppler mainly directing towards the possibility of adherent placenta.
Okay, she is Shivani Singh. Okay.
Then you are done. Thank you so much, Shivani.
Thank you.
Thank you, Shivani.
So now Ketan. Ketul. I don't know.
Yes, yeah, Ketul Barot. Ketul Barot.
Yes, I'll be sharing my.
Yes.
Yeah. Share your slide and start.
एक क्वेश्चनचा आन्सर नाही आला पण मला.
Hello everyone.
Hold on, but I need to mute everyone now.
Your audio
म्हणजे ती बोलत होती एक पहिले. मला काहीच नाही कळालं.
So madam, and then you unmute yourself. Okay. Okay, now unmute yourself, Yamini ma'am, if you want to, and come on, Ketul, start.
Yes, sir. So, hello everyone. I am Dr. Ketul Barot, and I'll be presenting my case on splenic artery aneurysm. So, this is the case that I, along with the team, came across during my internship. So, aneurysms are abnormal dilatation of the vessel, which can be a vein or artery. So I am presenting a case of 25-year-old primi gravida in her 36 weeks of pregnancy. She came to the trauma and emergency care at Sri Krishna Hospital. On presentation, she was confused, lethargic, severely pale with rapid steady pulse and hypotension. Her abdominal examination revealed that the fundal height was 34 centimeters. The abdomen was diffusely tense, and There were no fetal heart sounds audible. Her USG abdomen revealed free fluid in the abdomen and absence of fetal cardiac activity. The patient was then taken for emergency laparotomy, but preoperatively the patient collapsed and code blue was activated. The patient was resuscitated and then taken for surgical intervention. Intraoperatively, approximately 1.5 liter of hemoperitoneum was encountered, and the uterus, when it was exteriorized, there were no signs of uterine rupture. So here is the figure 1, which is showing a large hematoma in the lesser sac. So the after the fetus was delivered, the dead fetus was delivered, and placenta was also delivered. The placenta was examined thoroughly, and there were no abnormality. There was no retroplacental collection of blood. There was search for other causes of intraperitoneal hemorrhage, and a large hematoma was seen in the lesser sac, as shown in the figure 1. Intraoperative consultation from general surgeon and vascular surgeon was obtained. Lesser sac was explored, opened, following which there was a sudden gush of blood from the ruptured artery. The ruptured artery was identified to be a splenic artery aneurysm. Following that, a splenectomy with aneurysmectomy was done, and abdomen was closed after achieving proper hemostasis. During the operation, 6 PCVs, 4 FFPs, and 3 platelet concentrates were transfused. Post-operatively, the patient was transferred to the intensive care unit, and her vitals showed tachycardia, and the BP was not recordable. The patient again collapsed in the intensive care unit, and code blue was activated. But unfortunately, the patient didn't made it, and she succumbed to the complications of irreversible shock. So splenic artery aneurysm is the second most common visceral artery aneurysm following abdominal aortic aneurysm. The development of aneurysm is mostly due to weakening of the, it is due to pathological weakening of the vessel, and it is due to atherosclerosis, fibromuscular dysplasia, or arteritis. And pregnancy individually, it is a risk factor for development and rupture of a splenic artery aneurysm. The incidence is unknown, and underlying pathology is related to same, the atherosclerosis, fibromuscular dysplasia, and arteritis. The changes that are the hemodynamic changes associated with pregnancy can increase the risk of rupture. So the main objective of this case is to highlight this rare occurrence, as the splenic artery aneurysm is has shown to has been associated with high significant mortality in both maternal and fetal mortality. It is associated with approx 75% mortality in mothers and 95% mortality in fetus. And majority of these patients remain asymptomatic until it ruptures. And the development of shock is also rapid in pregnancy. So the main objective is to highlight this rare occurrence, so that the obstetrician should keep in mind this case in back of the mind, and should have high suspicion in such cases where the patient is presenting with hypovolemia. The figure 2 is showing the splenic artery aneurysm stump, and these are the lab findings when initially the patient was admitted to the hospital in the trauma. Thank you, ma'am.
Okay, good. So this is a good case and a rare case, I would say. But then what are the differential diagnoses?
Yeah, of
such a patient.
Yeah.
Yes, so the differential diagnosis of hypovolemia, patient presenting with hypovolemia in 3rd trimester of pregnancies, it can be a uterine rupture, it can be a abruptio placenta, but there were no signs of pervaginal bleeding. So initially it was highly suspected to be a uterine rupture, but it was clear after entering the abdomen and examining the uterus.
See, a case coming from you, I mean, these are the DDs we won't accept. DDs means इसके close में क्या दूसरा हो सकता है? Abruptio is totally different. Come on, वो पता चल जाता है, correct? What else? As this is rare, what other rare things are there?
Sorry, ma'am, I don't know.
See, okay, fine, not an issue.
Okay, but the case was very interesting. Yeah.
The case was good and interesting.
Yeah,
Yes, rare and interesting case.
Very good.
And you rightly said that it's really difficult to protect the life of a mother when she presents with such a scenario.
Yes.
Yes, okay, fine. Thank you.
Thank you, ma'am.
Yeah.
Last one,
Shweta.
Shweta.
Last one. Shweta. Shweta, are you there?
Yeah, I think, no.
This is Nidhi Patel. No, this is done, okay.
No, Shweta.
Good evening, ma'am.
Yes, good evening, Shweta. Start.
Good
Yes, we
evening,
can see you on
everyone. I am
screen.
Shweta. I am Shweta Sawant presenting before you a case report of post-MTP uterine rupture under the guidance of Maharshi ma'am and Shubhangi ma'am from MGM Medical College and Hospital, Aurangabad. Uterine rupture is defined as the full thickness separation of uterine wall and the overlying serosa. It may be primary, defined as occurring in a previous intact or unscarred uterus, or may be secondary and associated with a pre-existing myometrial incision, injury, or anomaly. Some of the causes of uterine rupture include prior hysterectomy or C-sections, operations or manipulations that traumatize myometrium like uterine curettage. My patient was a 25-year-old para-1 living 1 abortion 2, came on oxygen support with intravenous and urinary catheter in situ with a referral letter in view of septic shock, abdominal hematoma, uterine rupture for further management. Patient complains of pain in lower abdomen since 5 days. Patient gives history of second trimester medical abortion, followed by which there was retained placenta which was removed manually. Following this, she had episodes of fever and chills and pain in abdomen. Her obstetric history has one LSCA 6 years back, delivered a female child. Second was termination of pregnancy by medical method done at 16 to 18 weeks 4 years back, for which check curettage was done. Third was this pregnancy where termination was done by medical method at 18 to 20 weeks 4 days back. On examination, she was conscious, oriented, and febrile. Her pulse rate was 124 beats per minute, low volume pulse. Blood pressure was 100 by 70 millimeter of mercury, 32 cycles per minute of respiratory rate, and SpO2 was 100% on 2 liter O2. On per abdominal examination, guarding, rigidity, and tenderness were present. Scar of previous LCS was seen. On per speculum examination, dark colored clots were seen. On per vaginal examination, os was open, clots were seen, uterine size could not be made out due to tenderness. Her hemoglobin level was 7.8, TLC was 28,700, and platelet count of 5,17,000. USG abdomen and pelvis showed loculated fluid in perigastric, both paracolic gutter and pelvis. Uterus was bulky. Loculated hyperdense collection suggestive of hematoma in mid and lower endometrial canal were seen. Defect in anterior wall with extension of hemorrhagic collection, features suggestive of uterine rupture. CECT abdomen pelvis findings were corresponding with the USG findings. Management. Under general anesthesia, laparotomy was done and there was evidence of scar giveaway with extension of approximately 5 cm from the scar to the left lateral uterine wall with no uterine artery involvement. No active bleeding was present. There was evidence of hemoperitoneum of approximately 700 ml, dark in color. Margins of the rupture were freshened up and suturing was done. Intraoperatively and postoperatively, blood loss replacement was done, and postoperatively, the patient was put on higher broad spectrum antibiotic coverage. In the picture, we can see the upper edge of the rupture, the lower edge of the rupture, and here the scar gave away going to the lateral uterine wall. Decision for suturing was taken considering the patient's hemodynamical stability and obstetric history. Quick decision in this case helped us to avoid hysterectomy. Patient withstood the procedure well and was stable postoperatively. On discharge, the patient was advised to avoid pregnancy for minimum 3 years. Counseling for strict contraception was done and the patient was administered injectable hormonal contraceptive before discharge. Conclusion: this study helps us to know that how early diagnosis and referral is important in avoiding obstetrical hysterectomies. It also helps us to know that obstetricians should be vigilant while terminating all pregnancies by medical method in previous scar cases. USG guided check curettage should be considered in cases of scarred uterus, like in this case where previous LSCS underwent prostaglandin induced abortion with check curettage. Thank you.
Sweta, she had
Yes,
first CS. She had first CS. Second, medical termination with medical methods, right?
Yes, ma'am.
In the third pregnancy had rupture. Was there any history of any other surgery on uterus or no?
No, ma'am. No, ma'am.
No. And what was the duration between the CS and the termination of pregnancy?
Ma'am, C-section was done 6 years back. The second termination was 4 years back, and this one was 4 days back. Like when she arrived at our hospital, she had terminated a pregnancy 4 days back.
Okay.
Okay.
Okay. Preeti?
Fine. So while you said that you resutured, right?
Yes, ma'am.
So what care would you take while doing that procedure surgically?
Ma'am, we first of all we should make sure that the bleeding is not much. For resuturing, the first criteria is that the margins
See,
or
once
the
rupture
edges
is
should
there,
not be
तो bleeding
fibrotic.
तो होगा भी और नहीं भी होगा, right? Correct.
Yes, ma'am.
So,
So
but you
first
want
we
to
should,
resuture it.
yes, ma'am. So we should first make sure that the margins are not fibrotic, like the margins are fresh.
How will you make
and,
sure? दिखेगा क्या?
Ma'am, वहाँ से bleeding, there will be bleeding from the margin, fresh bleeds from the margins. It will make sure that the margins are fresh.
Okay.
Yes, ma'am.
Okay. So if they are bleeding, you'll suture. Else, what will you do?
Ma'am, check for the vessels, like first of all, uterine arteries. If bleeding is from there, that the uterine arteries are involved, we will have to ligate it to make sure that she does not bleed post-operatively or the bleeding does not go missing.
Okay. Which suture material would you like to use in this?
Ma'am, in our case, we used chromic catgut number 1 for resuturing.
Okay. What is the reason of using chromic catgut number 1?
Ma'am, it is an absorbable suture and the reaction would be less comparatively.
The reaction would be less. Is that so? Okay. Okay. Fine. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
So, do we have anyone left out? Jhalak, can you check that is anyone left out, or we can just end this thing? Ashwin bhai, take the lead now.
હા તો તમે લોકો હવે માર્ક્સ મોકલી આપો.
Correct. હવે
Thank you
એક
very
હું
much.
વાત કરી લઉં. Can
Thank you very much. All the judges of second half, particularly, it is more tired. Boring.
યામિની બેન mute છો?
યામિની મેડમ હાઇપોગ્લાયસેમિયા નથી થયું ને?
As well as the students also, Ashwin bhai, because I mean it's quite late for them also. They have been waiting since I think morning.
Completed now. No one left.
Yo, but yeah, if anybody is left, please raise your hand or write in chat box. Else we will end this meeting. I think that should be it.
I think nobody is left. We should end the meeting.
Okay, fine. Thank you all. And Yamini ma'am and Smriti ma'am, I'm calling you.
અશ્વિનભાઈ હાઇપોગ્લાયસીમિયા વિશે કહું કે એવું થયું કે પેલા વચ્ચે વોટ ઓફ થેન્ક્સ બોલી ગયા ને એટલે મને એમ કે હવેના છોકરાઓ છે જ નહીં.
નહીં, like sir wanted to
હવે
come
બધા
in.
કોઈ છે જ નહીં, હવે પતી ગયું આપણું કામ એમ. એટલે મેં કીધું આ લોકોને કહી દઉં કે આપણે એક્સેલ શીટમાં મોકલવાનું છે કે આપણે ડિસ્કસ કરવું છે કે કેવી રીતે. તો ઝલક મને કે હજી તો સ્ટુડન્ટો બધા ઓનલાઈન. Okay.
More than 56